Dr. Bhattacharya is the founder secretary of Institute of Pulmocare and Research. He's engaged in activity to achieve the motto of the institute, that is research, education, and patient care through innovative research, education, and other activities. Sir, I request you to continue with the session.
Thank you very much. It's my pleasure and honor, privilege to welcome you all to Pulmocon 2022. Without wasting time, I'll go straight to the issues. The first session is going to start soon. And for that, may I request my good friend, Dr. Hindol Dasgupta, onto the stage. Dr. Dasgupta is a senior consultant pulmonologist. I met him, my classmate and a friend. He has got a lot of experience, a lot of publications at home and abroad. And I request him to take hold of the session and introduce the speaker. Thank
you. Good morning. Good morning, ladies and gentlemen. We are just starting the session, and therefore I expect and hope that there will be others who are on their way to listen to a great speaker, two speakers actually, opening the session with severe and difficult to treat asthma. Over to Raja Dhor and Beauty Bishash. I'm sorry that I haven't been introduced to Beauty. I know Raja for a very long time, and he definitely doesn't need any introduction. He is one of the leading pulmonologists, not just in Kolkata, but all over Bengal and India. So without much ado, let me call him, and the stage is yours, Raja and Beauty.
Thank you very much, everyone. Thank you, Parthoda, for inviting me to Pulmocon every time. It's an absolute pleasure. Like Hindolda said, it's early in the morning and on a Saturday, so we don't see many people, but hopefully we'll have people coming in through the course of the day. I just came over to introduce my colleague, Dr. Beauty Bishash. So Beauty has trained with us and then has become a consultant in respiratory medicine at the CMRI CK Birla Group of Hospitals just now. She's worked credibly and is working in building up the severe asthma clinic and service at CMRI Hospital just now, and is doing a very good job at this. So the way this program will flow is for Beauty to present a case, a real life case, which she'll share with all of you. After that, Hindolda will ask some probing questions to all of you, and then together we'll discuss answers which might be useful to you in your day-to-day clinical practice. So over to Beauty.
Thank you, sir. So, hello everyone. I am going to present a case on severe asthma. So let's start the case. A 36-year-old young lady residing in Kolkata who is suffering from long-standing asthma. She has no addictions, except her husband is used to smoke at home. Hence, she has passive smoking exposure. She is slightly overweight, as all of you can see from the BMI. She has no history of any comorbidities like hypertension, diabetes, or chronic heart failure, which mandate use of regular medications. Her symptoms started at the age of 24 years. So she's suffering for around 12 years with intermittent attacks of cough, wheezing, chest tightness, and allergic rhinitis symptoms. She was treated optimally with the use of inhaler medications in the form of ICS, LABA, which was prescribed initially as DPI, later switched to MDI. But still, she is suffering from some mild to moderate exacerbations for 1 to 2 times per year, which was treated with anti-allergics and on and off steroids. So in 2016, there was a severe exacerbation, which was leading to her hospital admission and ICU admission, in fact, but not amounting to mechanical ventilation. She was hypoxic, wheezy, and her chest was full of phlegm. Hence, we have done HRCT thorax, which showed presence of random nodules and diffuse tree in bud, which I can show you with the cursor itself. These are the tree in buds and diffuse nodules. Hence, we have done bronchoscopy, not only to clear the secretions, but also to isolate a bug. Her BAL galactomannan was 2.48 and fungal culture showed growth of Aspergillus, but she was bacteriologically negative. She was treated with IV steroids and IV antibiotic in the initial period since her admission in ICU, and antifungals added in due course after getting culture reports. She was gradually better with the current treatments and got discharged with reducing course of steroids. She also has family history of asthma, and she's suffering from some other comorbidities, allergy-related comorbidities like allergic rhinitis without polyps. She also gives history of suffering from allergic dermatitis in the initial course of illness, but not requiring any current medications for this. She's slightly overweight, as I already talked about, and she used to take regularly proton pump inhibitors for gastroesophageal reflux disease. But unlike the girls of her similar age, she has no history of anxiety. Dust, cigarette smoke, cold, and strong smells, these are the usual exposures for triggering asthma. But she also told us that whenever she used to take an apple, she developed throat irritation and wheezing. Hence, she stopped eating apple for 6 to 7 years, as her treating physician told her to do so to avoid exacerbations. She was treated with optimal doses of high-dose ICS, LABA, LAMA, and leukotriene receptor antagonist with optimal adherence and on oral corticosteroid for recent exacerbations. We have ensured her inhaler technique, the adherence, we have done the environmental triggers, and those slightly overweight, but we have done the sleep study and it is negative for obstructive sleep apnea. So we have done the following investigation to phenotyping her in 2016. Her serum Ig raised, absolute eosinophil count also raised. Her fraction XL nitric oxide is 88. The cutoff point is 50 to predict an asthma exacerbation as per ATS and ERS guideline. We have done the PFT after 6 weeks of exacerbation, which showed moderate obstructive physiology with reversibility. We have also done the allergen sensitization testing, and it was positive for house dust mite, Dermatophagoides farina, and Dermatophagoides pteronicinas. So just to summarize, a young lady with asthma, with allergic rhinitis, gastroesophageal reflux disease, and obesity, with good inhaler technique and compliance, suffering from frequent episodes of exacerbations, and with poor quality of life because of the poor symptom control, and now on oral corticosteroid for last 1 month. So come to the phenotyping of this patient. She basically belongs to atopic, eosinophilic, type 2 high, and basically overlap category with increased IgE and increased eosinophil levels. So we have the following options to optimize her. First is biologics anti-IgE, as there is increased IgE in the form of omalizumab. Second option, biologics anti-IL-5. 2 forms are there, mepolizumab and reslizumab, and anti-IL-5 receptor antagonist in the form of benralizumab. Third option is bronchial thermoplasty. It is of limited value because it is only applicable for neutrophilic and paucigranulocytic asthma. Fourth option is macrolides. This is again also applicable for neutrophilic and paucigranulocytic asthma. So in 2016, we have switched her to smart therapy with formoterol budesonide with optimal dose. We have continued the tiotropium and started omalizumab 300 mg monthly. All of you know from her body weight and IgE levels, the optimal dose should be 300 mg twice weekly, but we can't give her because of the financial reasons. But the lady took the omalizumab very religiously for 2016 to 2017 for 1 year. And she's responded very well. Her symptoms become well controlled. Her rate of exacerbation reduced dramatically. Hence, we are able to wean off steroids and her quality of life improved magically. But in spite of this, she stopped omalizumab taking after 1 year because of the financial reasons. This chart is showing the rate of exacerbation from 2016 to 2020. And all of you can see that in 2018 and 2019, there was a significant reduction of exacerbation, which is the immediate post period of omalizumab. In 2020, she had COVID, and post-COVID, there is 2 times of exacerbations. 2021 is a very bad year for her. She loses her asthma completely out of control, and she's suffering from multiple episodes of exacerbation, which recurring on and off steroids and ultimately on maintenance low dose steroids. And there was also one episode of severe exacerbation amounting to hospitalization following episode of viral or upper respiratory tract infection. So we again reevaluated her in 2021, and serum Ig also raised, acute eosinophil count raised. Pheno is slightly decreased than before, but still it raised. And we have done the PFT, which also showed the moderate obstructive physiology with reversibility. So we face some practical problems in addition to medical issues here. These are the financial issues, the medical insurance coverage, and the far away locality from the hospital, etc. So we have now left the following options. First, to restart omalizumab again. Second, to switch to mepolizumab. Third, to switch to IL-5 receptor antagonist benralizumab. And fourth option, bronchial thermoplasty, which is practically non-applicable. So finally, we have enrolled her in an ongoing trial on mepolizumab for oral corticosteroid dependent severe asthma. So take home message, effect of biologic will wane after stopping the biologic in a subset of responders, and patients with overlap phenotype are candidates for both anti-IgE and anti-IL-5 biologics. Biologic class switch may be considered. Thank you.
Thank you. Thank you, Beauty. That was very nice. That is a very good example of what we face in our day-to-day clinic. And sometimes we fail to give patients symptomatic relief, and then we do not know how to proceed. And you have actually raised quite a lot of questions with that young girl. What about the thing which you did is absolutely fine. I wonder if you could explain the necessity of bronchoscopy in a patient with asthma, who's difficult to asthma, because we know that while we are doing the bronchoscopy, she can go into a severe asthma attack, and then that can pose problem during the procedure. But doesn't matter, you did absolutely fine. But the necessity of bronchoscopy in a patient who has got severe asthma, could you enlighten us with the reasons why we do bronchoscopy? Yeah.
So, you go ahead. The aim was actually to also involve the audience. Maybe.
Oh, right. Okay.
So ask the questions to the audience first, and then maybe Beauty and I can.
Do we do bronchoscopy as a routine with patients who are not getting better on asthma therapy, who are asthmatic?
I cannot see anyone actually, but
no, just come and use this mic.
So Beauty, you have a go first, and then I'll try and give an answer. So indication of bronchoscopy in this case, and normally where do we do bronchoscopy in our practice? The way we have practiced, we practice together. So the way we practice, where would you place bronchoscopy in the management of an obstructive airways disease exacerbation?
So for her, the indication is probably as she is hypoxic, rattly, and full of phlegm. And her HRCT thorax also showed presence of mucus plugging, tree in bud. So two indications, not only to clear up the secretions, but also to isolate an organism so as to narrow our antibiotic therapy and to discharge her early and to optimize her treatment.
Sure. So Beauty, go back to the slide which shows her CT. So keep going. Yeah. So, people in the audience would appreciate the number of nodules. Just use your cursor to show the nodules. Beauty, I don't know whether they show up or not, but look at the screen. So if you see these are the bottom cuts on the CT, and you would appreciate that there are plenty of nodules there. The nodules are peripheral, they are random, and they are multiple. In a patient with background structural lung disease or airways disease, if you get these nodules in the background of having an exacerbation, you would think that these patients have a secondary infection. Now the question arises, do you actually need to bronch all patients with nodules like this? And you don't. But this patient to us at that point of time seemed to be plugged. The sputum was not being produced, even though she was coughing all through the night. She was very, very breathless while coughing. And we thought doing a bronchoscopy in this lady would add value. It would add. So the other question we were asking is about fungal disease, which Beauty spoke about in that case. We wondered whether there might be aspergillus in this particular case. We also sent a galactomannan, which she spoke about. So that's in the acute scenario. In the more chronic scenario, like Hindolda said, there is actually no clinical data which supports doing bronchoscopies, lavages, and biopsies. There was a time when people would look at eosinophil counts in the lavage fluid or would look at T lymphocyte numbers. They would do bronchial biopsies to try and establish the degree of inflammation in patients with refractory asthma. However, even after 15 years of its use, it's used only as a research tool and not really as a clinical tool for people like us in the management of stable but refractory asthma.
May I
Sure.
interject? Now, if I had seen that CT and I thought of mucus plugging, I would think of ABPA rather than invasive fungal disease. And therefore, I possibly would take the next step of treatment of ABPA or try to establish the diagnosis of ABPA by skin test or whatever, and then go on straight off to corticosteroids or antifungal or both together and see the response.
Sure.
But I possibly would not have done the bronchoscopy.
Sure.
The very fact that you did and you got some galactomannan positivity and you gave the antifungal, I possibly would have done that based on the CT alone.
Sure.
Would I have gone wrong, Raja?
So I don't think you would have gone wrong, Hindolda. So as you would see that this CT, while it shows a lot of nodules, does not really show bronchiectasis. And if you look at the rest of the lungs, there was actually no bronchiectasis. And you would remember this patient actually came in the background of being acutely unwell with oxygen requirement, admitted to the intensive care unit. So while there might be a background allergic bronchopulmonary aspergillosis, we were trying to treat someone with airways disease and an exacerbation. Our logic was that if we managed to isolate fungus and stamp this as being aspergillus, we would probably treat it better as SAPS or ABPA, etc. I mean, ABPA was not really a possibility here because of the lack of bronchiectasis. And you would agree that we had given the patient steroids anyway. The patient came in with an asthma exacerbation, got the first dose of steroid while in the emergency, and hence sending off an IG or an IgG for aspergillus at that point of time would not have been useful. So I don't think your rationale is wrong. We could have given empiric antifungals along with the steroids, which we were giving anyway. But I don't think the other option of looking at a BAL and doing a galactomannan and looking for aspergillus is wrong either. So I think there isn't.
What I said is the usual thing that we do.
Sure.
We look at the CT picture, we look at whether there is any plugging and interpret it that way. That's
Sure.
what I
I think Arup wants to say something. Arup?
Yes, I have a question, actually, an observation. So in this particular case, this is actually a bronchiolitis the patient is having, and this may be the cause of severe asthma symptoms. And patient also had invasive aspergillosis. So do you treat the patient first with antifungal, then we go for the MAP therapy, or you haven't mentioned actually about the treatment of the antifungal in this patient. So what is the sequel that should be?
So Arup, I think, so if you think about, you probably had to walk out in the middle. So this was the initial presentation, like it says on the slide. The MAP therapy was much later on. It's 2020. So the initial presentation was this. This was the first time we saw this patient, and the patient presented like they often do to us with an exacerbation. The diagnosis of asthma was pre-existing. We thought about fungal trigger for asthma at this point of time when she presented, which is why we did the bal-galactomannan. Now, if you look at the literature, and there's a lot written in the literature about fungal sensitization and severe asthma, about ABP, etc. Where you place galactomannan is still a challenge. You don't really know where to place the galactomannan. Neither do you know what level of galactomannan cutoff would qualify as being abnormal. So if you think about Dr. Ritesh Agarwal's paper, so Ritesh talks about SAPS, which is what we thought this might be, even though we did not manage to isolate aspergillus. SAPS is somewhere in the middle of a continuum where asthma is one end and allergic bronchopulmonary aspergillosis is the other end. SAPS is somewhere in the middle. Now, SAPS can be treated exactly the way you treat severe asthma, including the use of biologics. There is one paper from Andrew Denning, who is sort of the guru of fungal sensitization with asthma, where he's tried itraconazole, and he said in 60% of patients, the quality of life seems to improve. So you would agree, quality of life is a very soft marker. I mean, if you don't get any other positive outcome, you talk about quality of life, because quality of life is so subjective. So the primary outcome was negative. He showed a secondary outcome improvement. And I guess we are still unsure where to place galactomannan in this issue of talking about invasive aspergillosis. I mean, this patient, in my understanding, just had SAPS, did not have invasive aspergillosis, but the galactomannan was positive. So we gave the antifungal for a short period of time. We only gave it for a period of 2 weeks.
But the fungal culture was positive for aspergillus in this patient.
Was it? I thought it was negative. Was it positive? Positive, was it? Okay. Yeah, so if the fungal culture, so I'm sorry, so I thought of remembered that this fungal culture was negative. So fungal culture being positive, you would have to sort of investigate the patient further. You would have to do an IG and an IgG for aspergillus, try and categorize the patient according to that PGI flow diagram, you know, where you place the patient. But you would use the antifungal for a longer period of time in that case, for sure.
The other interesting point that you raised for us Indians is that we face the financial problem all the time. So we have to modify and improvise. And this patient got half the dose of what she needed of the MAP. And yet she improved. And now can we take that message home? I'm saying if the patient cannot afford, can we give, is there any data what the lowest dose is, and whether we can actually alter the dose? Because this patient definitely got better, the symptomatically at least. Did we do an ACT or ACQ? How did we monitor whether she's getting better?
From the asthma control questionnaire.
Yes, but then you didn't show us that. But did we do that? Okay. So any data on whether we can change the dose?
I'll tell you the little bit of data that's available, Hindullah. So there is one trial which you know about, which is called the export trial. And there is one with mepolizumab. So export is with omalizumab. And there's another trial, which the name of which escapes me, which was with mepolizumab. This looked at discontinuation of biologics after a certain period of time, rather than looking at reducing the dose. Reducing the dose, there is zero data. But I don't know about you. I have done it in some of my patients where we have needed higher doses. The other area where we have actually reduced doses in patients with ABPA. there are there's now a meta-analysis of case reports. Interestingly, to the best of my knowledge, the only disease process where there's a meta-analysis of case reports only is in the area of use of biologics in ABPA. And the meta-analysis shows that there is a distinct reduction of exacerbations in patients with ABPA with the use of Omali, which was the only biologic available of the time. And there were 90 cases in total in that particular meta-analysis. Why I'm telling you about ABPA when you're asking me something else is because in ABPA, you know that you have industrial levels of IgE. The IgE is in thousands. So when you give the biologic, when you give omalizumab, if you had to dose calculate based on the Ig and the body weight, you would come up with maybe 1200 milligrams of omalizumab in a month, which is unthinkable. So all the trials have used between 300 to 600 milligram in a month, which is a far more suboptimal dose. And the improvement in symptoms have been fascinating to such an extent that Mepo and Benrali are now being used in trials for ABPA across the board. So the only data we have is extrapolating that data and using smaller doses in patients like this. The only countries which will do studies like this is like ours, Hindolda. So I think unless we get together and keep our data and use suboptimal doses, look at use of suboptimal doses, we probably won't have data. It worked in this lady. I can think of other patients where it's worked. I'm sure you can, and Arup can, Parthuda can, and the remaining people in the audience can. But they are sort of, there is no data as such.
The flip side is not everybody gets better on omalizumab.
Absolutely.
And therefore, if the suboptimal dose doesn't work, I might just think that possibly the omalizumab. You understand what my
so the problem is, Hindolda, that these patients actually don't have an option. What do you do with them? No, so there is absolutely nothing.
Absolutely.
What do we do?
Absolutely. So I think you want to talk about the overlap category.
Yeah. So the overlap category is patients with the overlap category is about patients who have both a raised eosinophil and a raised IgE. So common sense mandates that in this category, if they qualify as per definitions of severe asthma, you could either use an anti-IgE or you could use an anti-IL-5 receptor antagonist. This overlap category in our country, and we're talking about India just now, the percentage of patients belong to the overlap category has been thought of as somewhere between 25 to 35%. So a ballpark of about 30% of patients
severe
asthma, correct, of severe asthma, of GINA 5 asthma. So we are talking about 1 in 3 patients in, as Hindolda said, in the severe asthma GINA 5 category of patients once you have phenoendotyped them. Now, if you think of that, the numbers there, that would still be quite a high number. Remember, 42 patients out of 100, 42 patients out of 100 dying with asthma today are from India. So that's startling data. When I read this data from the Global Burden of Disease data from 2020, I was actually amazed, shocked, disappointed that out of 100 patients dying of asthma, 42 are from India. So we have a large burden of severe asthma. You need to choose between Omali versus Benrali or Mepolizumab. So omalizumab is more for childhood asthma. It is for more with people who have a moderately raised levels of eosinophil. So the number quoted in literature is 260. Whereas with Mepoli and Benrali, it's more for adult onset asthma. It's for patients who have nasal polyposis and chronic rhinosinusitis. So there are phenotypic indicators and there are the mandate today. Please remember about the overlap category and choose the biologic judiciously if your patient is suitable for that biologic.
That's a very good point Raja has brought up for our junior colleagues. We must stick to the definition of severe asthma and not use the expensive stuff on routinely on everybody. We have got about 2.5 minutes left, and a few things that always bothers me is that, 1, can we combine 2 biologics? 2, when do we stop a biologic? Is there any cutoff? Is there any data?
Sure. So I cannot combine 2 biologics. I think I'll keep that short and sweet. There is no data in the world just now which would support the combination of two different biologics. That's number one. And I want to keep that simple so that the message grows across. There is absolutely no justification in science today to combine two biologics. And I'm sure Hindolda and Beauty would agree with me. The second point is about when to stop. So there's a trial which is called the EXPECT trial. The EXPECT trial, for the first time, stopped omalizumab at 3 years. They looked at follow-up of these patients. They looked at the follow-up of these patients, and they found that the patients exacerbated beyond 12 months of stopping omalizumab, but up to 3 years of follow-up, the number of exacerbations were 50% compared to the time when they were on omalizumab. So these patients worsened, but did not worsen to the degree as they were when they were on omalizumab. There's a similar follow-up study of MEPOLI, which has looked at this criteria, and the numbers obtained from MEPOLI were similar to that found with the EXPECT trial with omalizumab. So carry home, in an ideal world, there is no question of stopping a biologic. However, in countries like ours, the so-called LMIC countries, the low middle income countries, unfortunately, we do have to stop from time to time. We stop with the understanding that the effect of the biologic will wane off sooner rather than later. The normal average time frame is about a year when the effect wanes off. We would expect an exacerbation. However, there is some residual effect which will last patients and reduce the number of exacerbations in the following years, not to the same extent as what it was before.
Thank you, Raja. We can take another question, just the last one, if there is any. Short and sweet.
Treatment of severe asthma in T2 low phenotype. Few short answers.
T2 low.
Okay. So T2 low asthma, there are two things which are there in that GINA algorithm, as you know, Arup. The first is use of low-dose macrolide. So there are very short and sweet, Hindolda. So there are two trials. One is called the Azizas Trial, which had far greater number of patients as compared to the other trial, which is called the Oasis trial. The Azizas Trial says that you use it in neutrophilic asthma, that T2 low asthma that you're describing. The other much more recent trial, which came out in the Blue Journal, is called the Oasis trial, in which they used it across the board in all patients with severe asthma and showed a result. The recommendation still remains with neutrophilic asthma. The other area, which Beauty mentioned briefly, was with bronchial thermoplasty. Bronchial thermoplasty license is in patients with neutrophilic asthma. However, I was just telling Hindolda that the bronchial thermoplasty will go out of vogue from mid-2025. It's been declared all the instruments will be withdrawn. It's been thought to be not of clinical benefit to the extent that this instrument, the probes, get manufactured further on. So the last patients included for bronchial thermoplasty will be mid-2024, and we will not have this procedure from mid-2025, June 2025. That's what the company has written on its website just now. So thermoplasty was more about hype rather than about hope, unfortunately. It's not really, we've not really managed to identify a cohort of patients who benefit from it. Biologics seem to work much better, irrespective of which cohort they are in. And you know, there are biologics on the annual, even for patients with T2 low asthma going forward. So thermoplasty will not be really something that's available going forward.
Thank you very much for your participation. And thank you, Raja, and thank you, Beauty. That was absolutely marvelous. Thank you.
Thank you so much. Thank you, Hindolda.
Thank you, Dr. Dasgupta. Thank you, Raja, and thank you, Dr. Beauty. So we are going to the next session. This is on sleep. And to chair the session, may I request Dr. Lakshmikant Yange. Lakshmi, please come. So he's a savior for now because my chairperson is on the way. So Dr. DJ Rai will be coming and joining him. Let me introduce Lakshmikant. He is DM Pulmonary Medicine, presently in working as a consultant in Pune, and he's a very sharp mind. He will chair this session. And there are two presentations, Lakshmi. One is by Dr. Abhishek Kaur. He happens to be from my place, Institute of Pulmocare and Research. The other one is by Dr. Arup, who is a consultant pulmonologist in Kolkata. So with this, I am leaving the mic to you.
Thank you. Thank you for the opportunity. I have been introduced as a last minute chairperson, so I don't know much about the session. Still, I'll try to coordinate. So who is going to present the first one? Yes, so you can start, please.
इंडिया में कौन सा ड्रग है थायराइड पे इफेक्ट हो भाई थायराइड को फिर ट्रीटमेंट है
A very good morning, everyone. Today I am going to present a case on sleep disorders. So let's start the case. A 40-year-old man with a history of snoring and daytime sleepiness underwent a split night sleep study. During the diagnostic portion of the study, the AHI was severely increased, but the arterial oxygen desaturation was mild. During the titration part of the study, the AHI remained elevated because of the central apneas that did not have a Stokes morphology. There was no history of congestive heart failure or opioid use in the patient. The only medications the patient was taking were levothyroxine and bupropion. Now you can see the summary of the events in the split night study. The total sleep time in the diagnostic part was 120 minutes with a REM of 24 minutes. The AHI was 36 in the severe category. The REM AHI was almost double that of NREM, with obstructive apneas of 30. Hypopneas were 37, desaturations were, number of desaturations were 72, and the least SpO2 that recorded was 85. In the titration part of the study, the total sleep time was 220 minutes. Sorry. With a REM of 44 minutes, but the AHI remained at 32.2. In this part, the NREM AHI was significantly high at 39, and the central apnea index, which was only 5 in the diagnostic part, there were 81 central apneas in this part. And the number of desaturations were also higher, with the least SpO2 recorded of 88. If we look into the PAP titration table, we could see that the titration started from 5 and gradually ended up in 12, where at the optimum pressure, where most of the obstructive events could be get rid of, with some central apneas, was the pressure of 8. But after the pressure was increased to 9, 10, and 12, the AHI started increasing. So naturally, the optimum pressure which was selected was of 8, in which most of the obstructive events could be get rid of with minimal central apneas. So the patient was started on CPAP therapy of 8 centimeter H2O, as this was the lowest pressure, and it was presumed that the central apneas would resolve on chronic treatment. The patient returned to the clinic with the machine download compliance data after 1 month of usage, and patient reported still having many awakenings at night, and his daytime sleepiness had not improved. He also reported difficulty falling asleep on CPAP. The machine download data that we could see was average usage was 20 or 30 days, and the number of hours was 4 hours per day, with the AHI, average AHI remaining at 20. The clear airway apnea index was at 18, with the obstructive airway apnea index at 2. There were not large leaks per se. So at this point of time, a diagnosis that we made was the patient met the criteria of ICST-3 criteria for treatment emergent central sleep apnea, because he had more than 5 predominantly obstructive events per hour on the diagnostic portion of the study. And during the PAP titration, obstructive events were eliminated by CPAP or BPAP without a backup rate, but central events emerged with a central AHI of more than 5 per hour, and more than 50% of the residual events were central. In addition, the CSA was not better explained by another CSA syndrome, namely CSA-CSB or due to narcotics. Now, if you could see this is the epochs showing the emergence of central sleep apneas in the part where the titration has started. So gradually at the CPAP pressures, the central apneas were emerging with periods of hyperapnea. This did not meet the definition of Kienstokes respiration because the duration of the periods of apnea and hyperapnea did not meet the criteria of Kienstokes. And if we look into the histogram of this patient, what we saw as the patient was titrated very rapidly. There was rapid increase in pressure, as we can see in the black parts. The gradual increase should be there, but a rapid titration and then the rapid reducing of pressure led to the emergence of central apneas in this patient. The current patient did not do well on CPAP at 1 month. The overall AHI on CPAP remained quite elevated due to these central apneas. So his CPAP adherence was also poor with high residual AHI. So he was referred for repeat PSG titration, and at which the patient was put on ASV, where the AHI was reduced to 5 per hour. And he tolerated the pressure well and was started on treatment, and a download in 1 month showed excellent adherence, and the patient reported much better sleep on treatment with ASV.
So you're done.
That's all about the
Okay.
case.
You said the rapid increase and decrease of the pressure actually led to the treatment emergent apneas. So can the change in ramp time will help such patients to abort or decrease the chances of emergence of central apnea?
No, sir. If we look into the risk factors of this emergence of treatment emergent central sleep apnea, we could see there are many risk factors. The demographic factors are there: male, sex, older age, lower BMI. The medical comorbidities like CHF, CAD, opioids, these also play a part. Baseline PSG factors like more severe OSA, higher central apnea index, higher mixed apnea index, and higher arousal index, these also play a factor. The titration study factors, mainly split night study or hasty or excessively high titration or high mask leak, these also lead to these may also lead to the treatment emergent. So during titration part, actually most of the titration studies now are going on auto titration part. So the machine gradually increases the pressure. So the ramp time is the time where after prescribing a pressure, the time we are allowing for reaching that optimum pressure.
Yes.
So if we increase the ramp pressure, but in titration part, that will not lead to the abolishment of the treatment emergent
No,
sleep
I'm just
center.
asking, you said rapid increase and rapid decrease of the pressure, especially if you are using auto CPAP machines, the AHI will never come to 0.
Yes, sir.
Because they'll keep decreasing the pressure till the AHI recurs again, and then the machine will start increasing the pressure. So some of the newer machines have a faulty algorithm where they don't recognize AHI at all. So they report AHI as 0. When you repeat a lab PSG with CPAP on, the AHI will still be 60, 70, or 80.
Yes, sir.
So that algorithm problem is there. But I'm just raising the question of rapid rise and rapid fall of the pressure.
Yes,
If
sir.
that is the reason, can that be avoided by using ramp time? That was the question. Anyway, so for the sake of everybody to understand, can you just tell us what are the differences between CPAP, manual CPAP or fixed CPAP, auto CPAP, and ASV? How are the algorithms differ, which actually takes care of central sleep apneas?
So in manual CPAP, actually, we need a manual titration first, where over the night, we gradually increase the pressure.
No, I'm not talking about titration, use of CPAP as a therapy at home.
At home, in a manual CPAP, we have a set CPAP pressure which is present throughout the night. It is the same. But in case of auto CPAP, the pressure is varying throughout the night according to the level of obstruction. So when the patient is having obstructive events, the machine will automatically raise the pressure to a particular level. When all the obstructive apneas will come to zero, machine will again try to decrease the pressure so that optimum pressure is reached where all the obstructive events are abolished.
Yes, the second feature is to improve the comfort and
Yeah.
compliance of the patient.
Yeah, but the whole night the pressure will come up and come down. But in case of ASV, what it does is it has a EPAP setting should be done so that obstructive physiology is abolished, and the pressure support will vary dynamically it will auto detect the breathing pattern of the patient over a 3 to 4 minute interval, and it will auto analyze that, and then it will vary the pressure support to give an optimum amount of tidal volume to the patient with a backup rate. So the central apneas, emerging central apneas, if any, will also get abolished, and the patient will also not be hypoventilated.
Yes, so basically the machine reads the sleep architecture of the patient in preceding 10-15 minutes, and accordingly it calculates the tidal volume and the frequency which is the patient is most comfortable with, and the machine tries to match that breathing pattern of the patient eventually, which takes care of central sleep apneas. Yes, I think with that, anybody has any more thoughts, questions? Yes, sir, please.
So Abhishek, first of all, very nicely presented. I like the confidence, the thought process with which you presented. So very well done. So that's the first thing.
Thank you, sir.
The second thing I wanted to ask you was, you did a split sleep study here. So myself and Dr. Radha Munje were just discussing that the split night study without the CPAP titration was only for 120 minutes. And even in those 120 minutes, while the patient had multiple apneic and hypoapneic episodes, there was not much of desaturation. So do you think that in these patients who have so-called apneic and hypoapneic episodes but don't really desaturate, you would rather do a full night polysomnogram, look at the pattern over a longer period of time, rather than shifting to a CPAP titration immediately after 2 hours? So this is not as a criticism to your case, but generally, if you have a technician who's good enough to recognize this factor, would you want to prolong it for overnight and then do a titration on a separate night? Or would you still continue to do it the way you've just done it?
Yes, sir. Definitely, we would like to, for this patient where there is desaturations are little less, and the AHI index is also in a borderline severe category, we would like to have a full night diagnostic part, so that if possible, the positional component of the OSA without any treatment with CPAP or BiPAP or these expensive devices could be taken care of.
Though there are no significant desaturations, sir, the number of desaturations leading to awakening still is significant. If we have to take care of that, and if they are recognized very well in 2 hours time, I think that is valid reason for us to proceed with titration therapy in the same night, so as to avoid time. This comes.
Can I add something?
Only thing is that if it remains sort of very dicey whether really has OSA or not, if that question remains to be answered, then the extension to whole night will definitely be recommended. Yes, ma'am, please.
Can I add? That was a very nice presentation. In fact, me and Raja were discussing. Very well done, and very nice explanation given to the questions also. Right. But what we want to say is that we have in the audience, we have students, the young pulmonologists, as well as seniors, when we did not have these facilities available. Right. So whenever there is a case which is being presented as either unusual or a learning case, at least that time, if you would do a complete study, and if there are any changes observed which you were expecting, like desaturation or those with position and all that. That could be very well told whether you got it or you did not get it and what could have been the possible reason. But
Sure.
all in all, well done.
Thank you, ma'am.
Yes, sir. Please.
Rapid increase in pressure actually causes treatment emergent central sleep apnea.
Yes,
So
sir.
can you describe how actually this titration is done according to the ASM guideline? How we should increase the pressure?
So actually, according to the ASM guidelines for CPAP titration, we should start at a pressure of 4 or 5 and then gradually increase the pressure at a 5-minute interval, provided the conditions are met to increase the pressure. The conditions are we should encounter at least 2 obstructive apneas or 3 hypopneas, or to increase the pressure to 1 centimeter of H2O. So gradually we go on increasing the pressure until all these until all the apneic spells are met with, and then when we reach an optimum pressure, we try again to then we wait for the REM to come. If the REM comes in that pressure, so we will wait for ideally we hope for a supine REM of 15 minutes to call it an optimal titration. So at the time the optimal titration is reached, we will try to decrease the pressure by 1 centimeter gradually, to keeping in mind not to encounter any apneas or hypopneas at that pressure. So at that pressure, that will be the optimal pressure, where the least amount of pressure that we can manage with the CPAP. And for BiPAP titration, the algorithm is slightly different. For each apneas, we increase the IPAP and EPAP both for 2 apneas, obstructive apneas. But in case of hypopneas, we only increase the IPAP, or in case of desaturations, we only increase the IPAP. The EPAP remains the same because the airway patency is maintained. So, and we gradually reach a pressure support. We initially start with 4 EPAP and 8 IPAP, and then we gradually increase the pressure support. So until we reach a pressure support where all the events are abolished, and then we can increase the pressure based on 3 criteria: whether the flow is good, whether the oxygen desaturations are not that high, and if that pressure for that, and snoring is absent for 3 minutes. So these are the 3 criteria. For that, we can increase the IPAP up to 3 centimeter of water. And after increasing, and if when the conditions are met, then we prescribe that pressure, provided that supine REM is achieved, or if it is not achieved, then available amount of titration can be set.
Okay, I think with that, I thank you, Dr. Abhishek. We are left with 30 minutes for the next presentation, sir. You can start, please.
So wonderful concept this year in Pulmocon. This is meant for the trainees mainly. And I'm going to present 2 cases of a similar disease, which was described much earlier than obstructive sleep apnea. Obstructive sleep apnea was first described in 1969 by Barwell and colleague, but this disease was described in 1956 by Beckelman. And these 2 cases are of Pickwickian syndrome. So do you think this Pickwickian syndrome is very rare in our clinical practice, or it's very common in our clinical practice? Is it common? It is very common actually. So first case, 65-year-old lady admitted in ICU with acute confusional status followed by drowsiness for last 1 day. She was obese with a BMI of 34, diabetic and hypertensive. Family members gave history of a low-grade fever for last 2 days and a dry cough of the same duration. They also complained about excessive daytime sleepiness and loud snoring with choking at night of long duration. On examination, she was hypoxic in room air. Vitals was pulse 94, blood pressure 150/86, respiratory rate of 18 per minute. Saturation was 80% in room air. Workout breathing not much increased in spite of this desaturation. There was no pedal edema. Neck vein was not engorged. Chest auscultation revealed crepitations in both bases, but this was more on the right side. Capillary blood glucose was 254 and arterial blood gas analysis revealed acute and chronic type 2 respiratory failure with hypoxemia. So basically this is an obese patient with acute and chronic type 2 respiratory failure with hypoxemia with some features of sleep disordered breathing and some features of lower respiratory tract infection. Now the case 2, the gentleman presented in OPD. This was not an indoor patient, 60-year-old with BMI of more than 40. And he took OPD consultation with a history of breathlessness on exertion, dizziness while walking, and excessive daytime sleepiness, fatigue, and snoring during sleep of some duration. He had a history of pre-syncope a day before consultation. He was non-diabetic, but having dyslipidemia and hypertension. On examination, his vital was pulse 102 per minute and regular. BP was 160/100, saturation of 94% in room air, respiratory rate of 20 per minute, and bilateral pedal edema was there. Chest auscultation revealed diminished breath sound bilaterally. Cardiac auscultation revealed a loud S2. I think these kind of presentations are very common in our indoor and outdoor. So what are the common thing between these two cases? First is obesity. Both patients were obese, one having a BMI of 35 and another 40. They both have symptoms related to sleep-related breathing disorder or probably obstructive sleep apnea. They both have multiple cardiovascular and metabolic comorbidities. They both have symptoms of pulmonary. The last patient has symptoms of pulmonary hypertension. The first patient didn't have. And when we have done the stop bank questionnaire and EPORT sleepiness scale for both of them, this was raised. So for all patients who presents with symptoms of sleep related breathing disorder, we usually perform two kind of screening questionnaire. One is the stop bank and another is the EPORT sleepiness score. So EPORT sleepiness score consists of 24 points, out of which if the point is more than 9, that suggests patient have excessive sleepiness. So 10 to 16, excessive sleepiness, more than 16, severe excessive sleepiness is there. And stop bank, this is a very important tool to rule out obstructive sleep apnea, likelihood of obstructive sleep apnea. And it consists of 8 points, S for snoring, T for tiredness, O for any observed apneic events, P for blood pressure, then B for the body mass index, A for the age, N for the neck circumference, and G for the gender. 1 point is given for each of these features, and if the point is more than 5, then it suggests patient have a very high likelihood of having obstructive sleep apnea. If it is less than 2, then the likelihood is less. And based on the stop bank questionnaire, actually we decide whether we should go for a level 1 study or a level 1 PSG or a level 3 PSG. So this is mandatory in all cases of suspected obstructive sleep apnea. What are the important clues during the examination? We always check the BMI for these kind of patients. We always check the Malampatti. We all know what the Malampatti classification is. So patient has to open the mouth widely with tongue inside. The original Malampatti was tongue outside, but the modified Malampatti is tongue inside. Patient has to widely open the mouth, and we have to see what structures we can see inside the mouth. If everything is visible, then it is Malampatti 1. If nothing is visible except the hard palate, this is Malampatti 4. And in between, you have Malampatti class 2 and 3. This Malampati classification was given by an Indian doctor who is probably from Andhra Pradesh, and this is widely used in clinical examination of obstructive sleep apnea. We also have to measure the neck circumference. If it is more than 17 inches in male or 16 inches in female, that suggests patient may have a high likelihood of having obstructive sleep apnea. And in Indian patients, we also look for the waist circumference. For male, if it is more than 100.5, or for female, if it is 95.5, then there is high likelihood of having obstructive sleep apnea. Then we have to look for the poor attention span. Some questionnaires are available, but these are not usually applied clinically in day-to-day practice. And we always look for the unexplained hypoxemia in obese patient that might suggest this Pickwickian syndrome. We have to look for the pedal edema and loud S2, which suggests there is a right ventricular strain, or there may be signs of pulmonary hypertension. So what are the investigations important in this kind of patients? Arterial blood gas, definitely. And in both of our patients, it showed hypercapnia. In first patient, it was associated with hypoxia, and in second patient, it was not that much of hypoxic. Chest X-ray, usually to rule out other causes of this hypoventilation, but in pure Pickwickian syndrome, this is usually normal, except some restrictive changes we can observe in due to the obesity. ECG is very important. It can show P pulmonale, right axis, or RV strain if there is a chances of pulmonary hypertension. Echo is very important. Echo showing pulmonary artery systolic pressure of more than 30, or TRV jet of more than 2.8 per meter per second square, or RB hypertrophy, or LV hypertrophy, or enlarged LA, or systolic or diastolic dysfunction, or decreased TAPC. These are some features which may be present in this kind of Pickwickian syndrome. PFT, usually these are normal because if COPD is present along with this Pickwickian syndrome, then we cannot delineate whether this hypoventilation is due to COPD or the Pickwickian syndrome. So usually in pure Pickwickian syndrome, the PFT is normal or restrictive, and this is usually the extra pulmonary restriction. And the reduced DLCO in such kind of patients may be due to a pulmonary vascular disorder or pulmonary hypertension. And the most important is the polysomnography, where we see for obstructive sleep apnea or sleep-related hypoventilation. And I will discuss what we have got for this patient in my few of next slides. Now, based on all these features, what is the diagnosis for the case 1? So the case 1, the lady who presented to ICU with history of 2 days of fever and shortness of breath and cough, along with symptoms of sleep disordered breathing. Our final diagnosis was, it was a case of bronchopneumonia with acute and chronic type 2 respiratory failure, with hypoxemia, with obesity hypoventilation syndrome, hypertension, and diabetes. And for the second patient, the diagnosis was obesity hypoventilation syndrome, pulmonary hypertension, both group 2 and group 3, and a metabolic syndrome. So Pickwickian syndrome has now been termed as obesity hyperventilation syndrome, and this is very common in our day-to-day clinical practice. So how would you define a case of obesity hyperventilation syndrome? The patient should satisfy 3 criteria. First, BMI should be more than 30 kg per meter square. Awake daytime hypercapnia, or PaCO2 should be more than 45 at sea level, or its surrogate like bicarbonate should be more than 27. And patient should have either a sleep-related breathing disorder like obstructive sleep apnea or non-obstructive sleep hypoventilation. So if the patient satisfies these criteria, then we say the patient is having obesity hyperventilation syndrome or Pickwickian syndrome. Now, how common is obesity hyperventilation syndrome? So there has been a 5-fold increase in the morbid obesity from 1986 to 2005 in the US. So with the rise of obesity, the prevalence of OHS is also increasing. For overweight or BMI more than 25, 1 in 3 adults have OHS. Whereas where the BMI is more than 30, 1 in 10 adults have OHS. In US, 1 in 160 adults have OHS. So if suppose if this in the conference we have 320 delegates, at least 2 will have this OHS syndrome. So this is very common. 13 studies have reported the prevalence of OHS as 8 to 20% in obese population referred to sleep clinics for evaluation. So all referrals you are getting for a sleep disorder, 20% of your patient will have this obesity hyperventilation syndrome. Now, how and when to suspect this obesity hyperventilation syndrome? They usually present in the 5th or 6th decade of the life, and they often have a history of frequent healthcare utilization because of this undiagnosed condition. And 8% of the patient admitted with acute and chronic type 2 respiratory failure have OHS. And 75% of such patients are misdiagnosed as COPD in ICU. And they are given as a treatment of COPD, but actually they're suffering from obesity hyperventilation syndrome. An acute event like pneumonia, like in the first case, may precipitate this acute deterioration of the chronic respiratory failure in such patients. They often have the excessive daytime sleepiness or the EPOR sleepiness scale of more than 12. They often have exertional dyspnea and symptoms of pulmonary hypertension. And in OHS, in normal OSA patients, the incidence of pulmonary hypertension is 9%, whereas in OHS, it is more than 50%. And some patients can progress to cor pulmonale. What are the typical polysomnographic finding in OHS? If we suspect OHS, we have to go for a level 1 PSG. In level 1 PSG, if the carbon dioxide monitoring is available, like the ET-CO2 monitoring or transcutaneous CO2 monitoring, that is preferred, but this is not widely available in our country, and it is not available in our state also. So what we do, usually measure the arterial blood gas before the sleep and after the sleep in the morning. So if you see a 10 millimeter rise of the PaCO2, that this is another surrogate of, we can tell the patient is having sleep-related hyperventilation. And in PSG, there are two kind of findings. Either we get a severe OSA of AHI more than 30, or we get a purely sleep-related hyperventilation where the AHI is less than 30. So OSA where AHI is more than 30 events per hour, sleep-associated hypoxemia below 85% for continuous 10 minutes should raise the suspicion of OHS. Suppose you do not have the facility for measuring the transcutaneous PCO2. So if the patient have a 85% saturation for more than 10 continuous minutes, that will also suggest the patient is having a sleep-related hypoventilation. And in few patients, 90% patient, we get a frank OSA, that means the AHI of more than 30, but in 10% cases, the AHI is less than 30, and these cases are actually a non-obstructive sleep hyperventilation, and that have a fixed definition, where the PCO2 or ETCO2 or TCCO2, whatever you measure, is more than 55 millimeter Hg for more than 10 minutes during sleep, or absolute rise of this PCO2 is more than 50 for a relative rise of more than 10 than the awake value for a duration of 10. So this is becoming very complicated. To make it very simple, the PCO2 rise should be more than 10 millimeter Hg. The absolute value should be more than 50, and the duration should be more than 10 minutes. So that suggests patient is having a sleep-related hypoventilation. Now, how the PCO2 or bicarbonate used in the diagnosis? For obesity hyperventilation syndrome to diagnose, we must have the awake state PaCO2 value. That patient when is not sleeping, that should be more than 45. And a resting hypoxemia, that means if the patient is hypoxemic even when he's awake, that suggests patient will desaturate during sleep. That also suggests that if the patient is obese, the patient may have this Pickwickian syndrome. Or we can use serum bicarbonate as a surrogate marker of this Pickwickian syndrome. And it has been shown that the serum bicarbonate is less than 27. That means it has a very high negative predictive value. If the serum bicarbonate is less than 27 in an obese patient, that has a 97% negative predictive value for excluding OHS. So we can use this marker in our day-to-day OPD practice. Now, the big question is that why some obese patients develop OHS? So I have already mentioned only 20% of the obese patients develop OHS, rest 80% doesn't develop. So why it is like that? So there are three theories on that. First is the increased CO2 production or CO2 imbalance theory. So as we get obese, we have more metabolism. This more metabolism produces more carbon dioxide. This more carbon dioxide has to be excreted by the respiratory system. So what leptin does, the adipose tissue produces leptin. This leptin increases the ventilatory drive and we wash out the PCO2. So we have a eucapnic obesity. But what happens in OHS? There is CO2 imbalance. The production of PCO2 is high, but the excretion of the PCO2 is low because there is some obstruction in the upper airway in the form of obstructive sleep apnea, or the respiratory system compliance is very low because of the obesity, because the function residual capacity is low, or the respiratory system compliance is lower, or there is a low chemosensitivity in few obese patients. That means they have a ventilatory instability and this increased ventilation perfusion mismatch. Like in the first lady, she had pneumonia and she had a ventilation perfusion mismatch and this CO2 imbalance happened. So if the production of CO2 and the excretion of CO2 doesn't match, then it produces a net accumulation of PCO2. Second is, there is another theory which called is a functional leptin deficiency or leptin resistance. So in obesity, we have increased adipose tissue. This increased adipose tissue produces higher leptin. This leptin actually penetrates into the cerebrospinal fluid in the medullary center and it increases the respiratory drive. So if it is okay, then the patient is non-OHS. But if the penetration of leptin into the CSF is low because of some reason, those patients actually develop OHS and they actually develop a functional leptin deficiency. Leptin level may be high, but leptin cannot penetrate into the CSF and cannot erase respiratory drive. That can cause a functional hyperventilation. And the third and important model is the Norman model. So Robert J. Norman described this model. He described that hypoventilation during the obstructive respiratory events during sleep, that increases the PCO2. So when there is an obstruction, that means there is apnea or hypoapnea during sleep, that there is no ventilation and that raises the PCO2. But that raised PCO2 is being normalized in the next breathing by the hyperventilation after resumption of the normal breathing. So we have apnea, PCO2 rises, then we wake up, or there is resumption of the obstructive events, and there is hyperventilation, that PCO2 is washed out. But in OHS patient, the inadequate interapnea hyperventilation actually leads to net gain in PCO2. So let's go to this figure. This is a 2-minute epoch of a patient having a severe obstructive sleep apnea. You can see this is an obstructive event associated with desaturation. As it is a 2-minute epoch, this obstructive event lasted for around 20 seconds. And the next event occurs sometime after that. And you can see in between these two obstructive events, the interapnea hyperventilation time is very less. So during this time, patient is having an increased carbon dioxide, and this should be washed out during this period when there is no event. But in this patient, these obstructive events are so close together that he gets insufficient time to excrete this carbon dioxide during this hyperventilation event. So this kind of phenomena can actually lead to net gain of bicarbonate or net gain of carbon dioxide during sleep. So there is acute hypercapnia during sleep. This acute hypercapnia causes a kidney compensation. If you remember the arterial blood gas equations, if there is a 10 millimeter rise of carbon dioxide, that should raise the bicarbonate level by 1 in acute and 3 in chronic. So kidney compensation causes some acute rise of the bicarbonate level. And this bicarbonate, there is retention of the bicarbonate, and this bicarbonate is actually excreted by the kidney in the daytime. But in OHS patient, they have a very low time constant for excretion of bicarbonate. So that is a limiting step in OHS. Because they have a very low time constant for excretion of bicarbonate, or bicarbonate excretes very slowly in them, they have a gain or more retention of bicarbonate even during the awake time. And this bicarbonate, what it does, it actually depresses the controller gain. This, if you remember, increased bicarbonate decreases the ventilatory response to carbon dioxide. So what if the carbon dioxide rises, we should raise our ventilatory response. But if you have an increased bicarbonate, that actually depresses this increased respiratory drive. So it depresses the controller gain. And that actually leads to acute hypercapnia during sleep. So there is net gain of bicarbonate, and that depresses the respiratory drive even during the daytime, and patient usually progresses to acute hypercapnia. Now, how obesity hyperventilation syndrome is treated? First, you have to assess whether it is a predominant OSA, that means AHI of more than 30 or not, or a predominant sleep hyperventilation, which is present in 10% of the patient. We start with a CPAP only. If OSA is predominant, that means if the AHI is more than 30, but we shift to NIV or BPAP if the CPAP pressure requirement is more than 15 or PaCO2 is high even after 3 months of use of CPAP, and we prefer NIV with a backup rate if there is a frequent central apnea or bradypnea or low respiratory rate or low minute ventilation. Advanced NIV mode like AVAPs, average volume assured pressure support, have shown to actually increase the sleep related quality of life and 6-minute walk distance. And apart from that, this advanced NIV mode and the fixed NIV mode are similar. So this is the algorithm. We suspected AHS. We see what is the AHI. It is less than 30, more than 30. We start CPAP and we see the compliance. If the compliance is poor or the response is poor, we shift to NIV. And if the AHI is less than 30, from the beginning, we start with the NIV. Now, what are the important other therapies? Medical therapy is important sometimes. Respiratory stimulant, before administering medical therapy, we must ensure that patient is able to hyperventilate or reduce PaCO2. We used to previously use 2 therapy like the medroxyprogesterone and acetazolamide. These are the respiratory stimulant, but respiratory stimulant should only be used if the patient is able to hyperventilate. That means he is able to lower his carbon dioxide by raising the respiratory rate. If there is a functional obstruction, he will not be able, and actually there will be increased gain of carbon dioxide. So limited ventilation due to mechanical impairment may worsen our effect of respiratory stimulant. 2 drugs were previously tested. Medroxyprogesterone was very controversial and not used nowadays. And acetazolamide, in some cases where we suspect a loop gain, may help in this kind of patients. There is a role of metabolic surgery. Previously used to call it a bariatric surgery. Now the new name is the metabolic surgery. Few patients meet this criteria. If the patient has a BMI of more than 40 or more than 35 with obesity related comorbidities, or ineffective surgical weight reduction attempts, or concomitant to adhere to post-operative care and lifestyle changes. And few patients are excluded always. There shouldn't be any reversible endocrine disease like hypothyroidism, or current drug or alcohol use, or uncontrolled psychiatric illness. So if the patient matches this criteria for metabolic surgery, this is always preferred. And as has been seen, that if the patient can lose a weight of more than 45 kg, he may reduce his obstructive sleep apnea part to quite a significant degree. So what is the prognosis in OHS patient? So OHS patients always have a 2-fold increased mortality, and untreated OHS always has a higher healthcare utilization, and there is poor adherence to PAP therapy increases the mortality. The strongest predictor of mortality is poor adherence to NIV, and use of NIV less than 4 hours is strongly associated with mortality. Now, coming back to our cases, this was a sleep hypnogram of the first case of the first lady who was admitted in ICU with features of some LRTI, sleep disordered breathing with acute and chronic respiratory failure. So you can see this is a sleep hypnogram which is showing some obstructive apneas and hypapneas, and AHI was less than 30. So probably this patient was having a sleep-related hypoventilation mainly, and we have done this PSG not during her admission, but at least after 2 months after discharge. And this is HI was around 27, I think. And another particular feature is present in this sleep hypnogram. If you can delineate, this patient has a HI of 28.8 when she is lying on back. But in the right side, this is decreasing to 10. So this patient is having a positional apnea in the back also. And this is the sleep hypnogram of the second patient. If you remember, he presented to OPD with features of pulmonary hypertension. And this is a very busy slide sleep hypnogram. There are a lot of events, a lot of obstructive apneas. There are mixed apneas, hypoapneas, few central apneas, and a lot of desaturation. And the patient is saturated to less than 50%. So this patient have a very severe obstructive sleep apnea. So it's a mainly obesity hyperventilation or mainly obstructive sleep apnea type. So coming back to our cases, if we refine our diagnosis based on this current knowledge, the first patient has a bronchopneumonia, acute on chronic type 2 respiratory failure with hypoxemia, obesity hyperventilation syndrome, mainly sleep-related hyperventilation type. That means she belongs to the 10% of the group. And the case 2, obesity hyperventilation syndrome, pulmonary hypertension, both group 3 and group 2. That means both precapillary and postcapillary. And it is an OSA predominant of obesity hyperventilation syndrome. And before I say thank you, I like to invite you all in December in Bishwabangla Convention Center for our Calcutta Sleep course, where we'll have fantastic international and national faculties, and it will be an absolute academic feast, mainly based on the obstructive sleep apnea only. Thank you.
Thank you. May I now request Dr. Roy to give his comments?
In fact, I'm sorry I came late and I couldn't hear Orup's total deliberations. But a few questions, just informations rather. Orup. What are the different atypical presentations of OSA that may include OHA, obesity, hyperventilation syndrome, and others? So I just mean to say that what are the atypical presentation? That means the patient is a patient of OSA, but has a different way of presentation and has been admitted for a different thing.
So I think that is a very important question. We say that OSA patient can present to any department of medicine or even surgery. Typical symptoms we all know: snoring, daytime sleepiness, fatigue. But sometimes patients also develop some kind of atypical symptoms like insomnia, especially in those patients who are having these respiratory effort-related arousals, young female, they often present with insomnia. Few patients may present with psychiatric disorder like mood disorders. Few patients may present to urologists as frequent nocturia, but they are actually suffering from obstructive sleep apnea. Obstructive sleep apnea patient even present to orthopedic department with road traffic accidents. So obstructive sleep apnea has a varied presentation. It can present to all department of medicine and surgery. And the main presentation, snoring, daytime sleepiness and fatigue, insomnia, mood disorders, or lack of concentration, all these are features of obstructive sleep apnea.
So if we can add to that, some of the patients with refractory hypertension requiring 4, 5, 6 drugs is one of the reason could be obstructive sleep apnea,
very important,
or obesity.
JNC7.
Very important.
And diabetes, which is very, very labile to control. That is also one of the
In fact, one important cause is impotence also.
Yes, even the gynecologist can present.
And a good number of couple, newly married couple, come to the clinic with a different symptom but the patient actually has obstructive sleep apnea.
Yes. Recurrent
un-
atrial fibrillations.
But unfortunately, correction of this sleep apnea does not always revert to potency. That is the unfortunate thing. I would ask Arup that whether the carbon dioxide elevation in obesity hyperventilation syndrome, which is the hallmark daytime elevation of this carbon dioxide, is it only due to a time factor? That means that it gets less time to hyperventilate to wash out carbon dioxide. Is it that only? Or something more?
Yes. So I have mentioned 3 theories. The theory you have mentioned, the inadequate interapnea hyperventilation, that is one theory by Norman. That is called Norman model. 2 other theories are, if the CSF penetration of leptin is less, leptin is one of the important protective factor in by increasing this respiratory drive, they eliminate more carbon dioxide in obese patient. If the CSF penetration of the leptin is less, that is another cause, and low bicarbonate constant excretion of by the kidney. The kidney is not able to excrete bicarbonate adequately in this obesity hyperventilation syndrome. So these are the checkpoints where this obesity hyperventilation syndrome develops, and that differentiates between eucapnic morbid obesity and this hypercapnic obesity.
Any question from the audience? If a patient of suspected OSA develops heart failure, pedal edema, is it very natural?
So that may be due to a congestive heart failure, because OSA patients often have hypertension. They have often systolic and diastolic dysfunction, and that may also be, maybe a sign of pulmonary hypertension. So we have to differentiate between these two, and always we have to suspect a severe OSA or OSA related complications in them.
So you have to consider heart failure also.
Yes, heart failure and pulmonary hypertension both.
Any questions from the audience?
Okay, if
I'm
there are
sorry.
no questions, I think we can close the session. Thank you, Dr. Roy, for chairing the session. And thank you, Dr. Haldar and Dr. Abhishek for wonderful presentations. We had good informing session on sleep disorders. With this, I think we move on to tea, and then Dr. Partha will take over for the next session.
Thank you all. We will begin our inauguration ceremony from 11:45. I request all of you to please be seated so we can witness the inauguration ceremony. Thank you. Welcome back. Now we'll begin the inauguration and award giving ceremony. And to give the introductory speech, I would like to request Dr. Bhattacharya on the dais. Over to you, sir.
Thank you very much. Good morning, and I welcome everybody to Pulmocon 2022. It's my honor, my pleasure, and my privilege to welcome you. I have to brief about my institute and Pulmocon. My institute, Institute of Pulmocare and Research, was born in this city in the year 2000, and it is 22nd year. And this Pulmocon is 20 years old. This is our annual program. Pulmocon 22 has been framed with the postgraduate students in mind. So we hope that the things will go well. We have been trying in our small capacity with a lot of logistic problems as best as we can for research, innovation, patient care, and education. Those are our motto as a non-profit institute. So today in the inauguration session, at the outset, I will request our organizing president, Dr. Dhiman Ganguly. Dhimanda has been a constant source of inspiration to come and take the chair. He will welcome the awardees today. And Dhimanda, please. So we would try to run in time. Our chief guest is blocked in a meeting. He will be coming late. One of the guests of honor, Dr. Guleria, has landed late because of his flight being delayed. And we have got another guest of honor, Professor Shivaji Chakraborty is with us. So it is in this Pulmocon customary for us to have eminent personalities been given felicitations. Today we'll felicitate Dr. Randeep Guleria with Professor S.N.D. Memorial Award and Professor Shivaji Chakraborty with Acharya Prafulla Chandra Roy Innovation Award. So since Dr. Guleria hasn't turned up yet, I'll be going straight to the Acharya Prafulla Chandra Roy Memorial Award. Everyone knows his name. He happened to be a doyen, the father of chemistry in India. He's a father of the pharmacological industry, and he started his Bengal Chemical in this city only. And you will be astonished to know what was the first thing he manufactured in India is sulfuric acid. Even that was not manufactured in India at that point of time. So he was a constant inspiration for a lot of people. Sir has already, welcome, sir. So a lot of people in Bengal and outside across the country. So to commemorate his memory, you have started this award. This year, Dr. Shivaji Chakraborty will receive this award. My duty is now to introduce Dr. Chakraborty. He is an engineer by profession and is a professor of Jadavpur University. He is, to my mind, a great teacher, an organizer, a leader, and an innovator as well. I'll start one by one. As a teacher, he has got a huge host of students. He has already mentored over 22 PhD theses. He has got books published by international publication house like Springer Verlag, Francis Taylor, etc. And he has a department, in his department, he has got a lab, which is high voltage lab in Jadavpur University. You may wonder why a person with a high voltage lab background been brought here. I'm coming to it, but before that, I will speak a little about his leadership. He happened to be the director of NIT Calicut in 2015 to 2017. After that, he was a mentor director of Indian Institute of Information Technology in Kolkata. During his stay in those institutes, the shape of the institute changed. The position in the NIFR ranking has been up from say 50 to 102 to from 50 to 28, kind of that. And number of PhD work increased more than double. The very fact that his department is a ISO 9000 and NABL accredited lab is a sign of quality work in that lab. I know how difficult it is to get this accreditation. I feel that all the labs, it's very rare to see academic labs being such accredited. So that shows the quest for quality in him. He has been awarded many times. He happened to be member of many societies as it happens for the personalities like him. He remained the chairman of IEEE Council in 2017, 2018. He was vice president of the National Academy of Engineering in 2021. And he has been awarded several awards, including Alexander von Humboldt Foundation Fellowship, INSA Fellowship, and US NSF Fellowship Award. But let me come to the innovation part of it. I was talking to him, and what I thought that I would come with a small story. Once a car mechanic met a doctor, and he told the doctor, see, you charge 500 rupees fees by seeing a patient, and I charge 50 rupees. That too is too small. I am a doctor of the car, and you are a doctor of humankind. Then the doctor smiled. He said, yes, you are correct. But the thing is that you stop your engine before you repair the engine, the car. But I have to try repairment while the engine is on. So with this simile, I would say these high voltage instruments are very precise and very sensitive to moisture. A little bit of moisture kills these instruments. And there are such instruments, the most commonly that we see, the big transformers, all across the country, all across the globe. Without that, no electricity can come to light our houses. And these instruments, they have a decay from moisture. He has innovated a method, sir, if I'm wrong, please correct me, that detects the moisture and corrects it, and the transformers are not, discarded. The transformers are in situ, they have been repaired by that, and that innovation might have saved crores of money for the country. With this small introduction, this is my proud privilege to request him to come to dais, and I will request our organizing president, Dr. Ganguly, to robe him and hand over the memento. Sir, which one? Sir. Oh. Please take a chair here on the dais. Now I will pass on to the Professor S.N.D. Memorial Award. All of you, those who have attended Pulmocon earlier must be knowing his name. Dr. Shomunath De happened to be a doctor in the city. He was a professor of pathology, and he died absolutely unsung in this country. The beauty of his innovation was that that requests to narrate another small story. Everyone knows cholera was havoc, and it killed millions of people across the globe. And the father of the modern microbiology, Robert Koch, he was looking for the answer of pathogenesis of cholera, how the cholera occurs. Koch had a hypothesis. He tried that hypothesis for cholera, but he failed. He came to Kolkata also. Professor De, he took up this challenge, and with a minimum facility, he made very innovative innovations and actually invented that it is the cholera toxin. The toxin liberated from the Vibrio cholerae actually causes the diarrhea, and that is the cause of death. That discovery actually was not acknowledged very well in this country. He didn't get that acknowledgement, but from abroad, he was nominated for Nobel Prize more than once. He died absolutely unsung. And after his death, maybe 22 years back, I read an article in a popular newspaper about him. And after that, once we started Pulmocon, we thought that we must start an oration in his memory. To my good fortune, the dignitaries, Doyens came and gave that oration. And this year, I am very privileged that Professor Padma Shri, Dr. Randeep Guleria has taken the pain to come to us to deliver the Professor S.N.D. Memorial Oration. Let me brief about Professor Guleria. This will be a little personal note, and because I've been associated with him for quite a long time. And he graduated from IGMC Shimla, and he did it post-graduation from PGIMER Chandigarh, where he did his postdoctoral fellowship also. He's the first TM in the country with Dr. Talwar. He has the beauty of a personality, which is always productive and progressive. His temperament is kind and he's unperturbed. I have seen him like that. This is my personal impression, which I'm expressing. And his mind is always scientific and with full of rationality. But with all that, his feet are always placed on soil. He's never flying. You have seen him in the COVID time, and everyone in household may be able to identify him. And he added his shoulder to the COVID fight of country. And he also wrote a book way back in the December 2020. That was a popular book on Till We Win, jointly with Chandrakant Laharia and Gagandeep Kang. Academic excellence, pursuit of teaching and research, mentorship of the next generation, leadership in public health, stewardship in policymaking, and academic publications. He has got more than 400 publications. They cannot actually fathom the quality of his persona. A list of achievements I can read out. These are all available in our souvenir. You can go through. He is a tireless worker, a loving teacher, a cherished well-wisher, and a friend, and a successful man in personal level. I know that out of his very difficult schedule, he supported many of our colleagues in different troubles with different patients and other problems. What I mean to say that as an organizer also, he has been very successful. He started the first EM course of pulmonary medicine in All India Institute, the first sleep lab in the country in that same institute, and so many other things he had initiated there. I'm personally lucky because I have a long association with him. He happened to be my senior resident. And when I was trying for my fellowship, then he offered me a book, gifted me a pulmonary physiology book that helped me a lot. I still keep this book with me. And later I got him as a co-investigator and of course as a colleague and guide. He has been a scientific advisor to my institute for the last 10 years. So I'm deeply honored and fortunate and happy to felicitate him today. Sir, you have taken so much of pain. Yesterday only he was supposed to come, but there was a tremendous official pressure. He could manage to come today, and he has just landed and straight away come to this venue. Would you please come to the dais? May I request Dr. Ganguly to row him? Sir, please take a chair, sir. Since the Director of Medical Education couldn't come and we'll start the inauguration program, before that, I'll request my people to welcome our guests with flowers. Wonderful. Now we'll light the lamp. So I'll request Professor Ganguly, Professor Guleria, and Professor Chakraborty to come down and light the lamp and officially inaugurate Pulmocon 2022. So thank you very much. This is a rendition from Tagore to make this occasion successful. Shafalo Karo He Prabhu Aji Shabha. So it's my pleasure and honor to see my senior teachers, my senior colleagues, my mentors in front of me. So I'm really overwhelmed. With this, may I request our guest of honor, Dr. Guleria, to say a few words.
Thank you very much. Good afternoon, Dr. Ganguly, Dr. Chakraborty, Dr. Parthasarathi Bhattacharya, all my senior colleagues, faculty for the conference, delegates, ladies and gentlemen. First of all, let me really take this opportunity to congratulate Dr. Parthasarathi Bhattacharya for his passion in doing Pulmocon every year with such a lot of enthusiasm and really taking it to new heights in terms of academics and newer innovations in teaching and how to really get the residents, postgraduates and young faculty upgraded as far as knowledge is concerned. Unlike what we were seeing or during my time, we are living through revolution as far as knowledge and change in science and technology is concerned. And therefore, it's so important for us to stay updated into the new developments. Many areas of medicine which we thought we had reached, let's say, the end of treatment, and there was nothing else available. New strategies have come into place. New methods of teaching have come into place. We talk of now flipped classrooms, virtual teaching, learned a lot about webinars and how we could have teaching even in remote areas using the internet, and even teleconsultation became something that we were able to do during COVID time. So I think it's important for us to continue to learn, no matter what be your age. And Dr. Partha Bhattacharya really puts in such a lot of effort in all of this conference, Pulmocon. I am really grateful and honored to be here today. And I would really like to take this opportunity to congratulate him and wish him all the best as far as his organization is concerned and for future Pulmocon. I'm sure it'll be a great success. Thank you very much.
Thank you for your kind words. So may I request Dr. Chakraborty now to kindly say a few words.
So warm greetings from my side to everybody present in this very special occasion. At the very outset, I convey my sincere thanks to Dr. Bhattacharya for inviting me in this program and giving me this very well-known award for which I don't think I am duly qualified. But anyway, it is the decision of the organizers and I'm humbled to accept that. Now I am being told to say a few words. I am not very sure what to say. For tomorrow, I have prepared something to say because this is an audience I have never addressed in my life. Typically, I address where we have particularly engineers or physicists, sometimes a little bit of chemists, but I have never addressed an audience which is full of medical practitioners. So it's very difficult for me. But let me take a clue from what Dr. Bhattacharya started with, that a car mechanic and that particular doctor story, which is said. But I think there is a, with due apology to everybody. Let me add to that, because this joke actually is extended in the engineering community. It is stated that after what he said, there is another part to it, where the car mechanic said that, yes, thank you, doctor, whatever you have said, but I can make a dead engine alive. Can you make a dead man alive? So that's the final part that goes in the engineering community. So I thought that I would like to say that here. But indeed, it was a great journey for me. I am in 37 years in the engineering profession, and I don't think that I am a brilliant person, but I am a consistent person. That I personally believe. So for all these years, what I have tried is very consistently work towards the development of technology. And for that, once again, I would like to say that Dr. Bhattacharya said I am a scientist. I'm not a scientist. Honestly speaking, there are scientists here sitting. I can see Professor Partha Majumdar and others. They are scientists. I am a technologist. So I work with that mentality. That means trying to develop something which could be used in practice, which could be used for the benefit of the society, benefit of the people who work in the laboratory, work in the workshop, and like that. And in my life, I have tried to develop a few things. Tomorrow, I'll speak about one of those. And there are certain small things but once again, let me tell you, I have not done it. All these things have been done by my students, scholars. Of course, I was associated with them. So once again, my very sincere thanks and deep gratitude to Institute of Pulmocare, IPCR, as well as Dr. Bhattacharya, and I'm deeply honored to sit next to Professor Dr. Guneria, a very eminent medical practitioner of India, and Professor Ganguly, one of the very senior most people. So I am honored to share the dais with you. And once again, thanks for inviting me here. Namaskar, have a great evening.
Thank you, sir, for your kind words. A small part of my inauguration program is left with. We decided that we'll hand over the certificates to our students in this program from the DME, but he is somehow absent. We, as a part of our academic venture, thought of starting 2 courses for paramedical support to practicing pulmonologists. And these are all certificate courses. They have been granted by Netaji Subhash Open University, and the university has provided the certificate for the first batch. So may I request my honored guests to hand over those certificates to our candidates. It will be a great occasion of encouragement for them. So Dr. Ganguly, sir, you also hand over them. Get the certificates, please. I'm calling them one by one. No, sir, you can call and give it. The students are requested to come forward. So you can call. You can, yeah.
You announce the name, they will come and
Shayon.
Shayon Bej.
Oh, Shayon is outside.
Connolly Chatterjee.
By virtue of staying with us, they have learned how to do pulmonary function test, 6 minutes walk test, 2-chair test, and basics of dealing with patients, how to do oxygen therapy in a sick patients, how to identify a sick patient. These were the primary area where we stressed regarding during the duration of the training. So please ask. Please call the second person and
Shivaji Chakraborty.
Not present. Next. Not present. शिव शंकर नहीं सर, नहीं है. Achinto Ghosh is coming, sir. Diya. Motion Dana. ठीक है. Dr. Indra, please. Thank you, sir. Moushumi has come. Dr. Chakraborty may kindly hand over the certificate to her. Thank you, sir. We have reached the fag end of our inauguration session. We are on time. May I request our organizing secretary, Professor Dr. Dhiman Ganguly, to say a few words and give the vote of thanks.
Thank you. And mine is the pleasant duty of offering you vote of thanks. Pulmocon is now 20 years old. It's not easy to organize something like that almost single-handedly for 20 long years. So that tells a lot about Institute of Pulmocare and Research and its director, Dr. Parthasarathi Bhattacharya, and his research associates. So we are happy that we could do this physically this year because last 2 years we were not seeing each other's face directly. I feel grateful that so many of you have taken the trouble of traveling to this place today, and it's a great honor for all of us. I thank all the delegates, Professor Chakraborty, Dr. Rondip Guleria, and the delegates, and the other supporting staff who may be in the background, they are not seen here, but they must have contributed largely to the success of the conference. Thank you.
So I actually forgot to mention a small part of my duty to request my guests to inaugurate the souvenir. ठीक है सर. So thank you, sir. So we declare the inauguration closed. We are just on time. We'll start the session. I hope that you will be able to enjoy the program. Thank you very much. Now we are going for the oration for which you have been awaiting. This is a 15th Professor Sende Memorial Oration. Before that, a lot of dignitaries have addressed the audience out here from this podium and other podiums. And this time you have been already introduced to Professor Guleria. He will be delivering the oration today. So now the stage is ready for you, please.
Thank you very much and good afternoon. At the onset, let me take this opportunity to really thank Dr. Partha Bhattacharya and the Institute of Pulmocare and Research for honoring me with the Dr. S.N. Deo Memorial Oration. I'd like to say that the Institute of Pulmocare and Research not only is holding this conference, Pulmocon, but has been doing a lot of good academic and research work. I know Partha has been working hard, not only in his own department in various diseases like COPD, but collaborating with various institutes like IIT Kharagpur for a lot of research projects. So it's not only Pulmocon that the institute is doing for the last 2 decades. They are involved in a lot of translational research, which could be useful as far as our country is concerned, as far as patients are concerned. Therefore, I'm deeply humbled and I feel honored to be giving the S.N. Deo Memorial Oration, because as was mentioned, he was in himself, Dr. Deo was himself a great stalwart, worked on cholera, enterotoxin, also showed the importance of oral rehydration in saving lives as far as this disease is concerned. And today I'll be talking on another infection, which also has created havoc like cholera did in the 50s and 60s. And that is basically the coronavirus or COVID-19. So I shall basically be trying to tell you the lessons we learned, how did we tackle COVID-19 as a country, and what can we do for the future as far as pandemics are concerned. Now, COVID-19 has been the largest pandemic of our lifetime. If you look at outbreaks and pandemics, this has probably been the one which has caused the most havoc. What started off as a small outbreak in Wuhan, China, and then everyone thought this is just something which is causing pneumonia, became a huge problem. And for the past 2 years, it has infected more than 617 million people worldwide. And I think this is an underestimate because the number of people infected are much more. Many never got tested. Many actually now are getting tested, but not reporting because of the rapid antigen test, which is home-based, and you can get it done at home. It has caused at least 6.5 million deaths. And we as a country has suffered 3 waves, with the second wave being particularly devastating. It has also really laid open the vulnerability of the healthcare system, not only in our country, but globally. If you look at what happened in Italy, what happened in New York, or in various other parts of the developed world, one realizes that this pandemic actually brought the healthcare system of even great nations, including UK, literally on their knees. This pandemic is now coming to an end. We are seeing that it is becoming endemic, but it is a warning that pandemics are likely. It's also important to understand that pandemics is not something which is only health related. It will affect every strata of life. It affected livelihoods. We saw a food and economic loss, especially those who were marginalized. And we saw what happened during lockdown, especially in the sector, which was the migrant laborers. We saw how it affected human health with high illness and potentially higher death rates among the marginalized population. It overstretched the health system. It caused a huge challenge as far as governance and security was concerned. And then there was social and humanitarian needs also, which rose as far as this pandemic was concerned. And then the economic system was affected, sports was affected, a lot of cultural activities got affected, and therefore it affected every part of society in one way or the other. So what is the current status of this pandemic? If you look at what was reported about a few days ago, India has the second highest number of documented cases at around 4.45 crore, behind only China. And we have the third highest number of documented deaths, around 5.28 lakh deaths. However, if you were to translate this into cases per million population or deaths per million population, our numbers are much lower, and we are better off than even many of the developed countries. So the numbers seem high because of the size of our population as far as the cases are concerned. But still, it's a huge number in terms of the number of cases and the number of deaths that we had to have over the last 2.5 years. It all started on the 30th of January 2020, when we reported our first case of 3 medical students who had returned to Kerala from China because of the restrictions that were raised, and they tested positive. Luckily, they became all right. But that was the first warning sign that we had in our country. And on the 25th of March 2020, we had a national lockdown imposed to curb and spread COVID-19. We had the first wave in September of 2020, the peak with over 90,000 cases per day. The vaccine got launched on the 16th of January 2021. And this is a time when many felt that things are now going to be over. We're getting vaccinated. We've had one wave, but that was sadly not true. And we were hit by the Delta wave, which caused a huge strain on the healthcare system. Many people lost their life, and we saw more than 4 lakh cases a day. This came down, and then in December, we had Omicron variant, which was a milder variant, both because of the fact that we were vaccinated, we had some degree of inherent immunity, and the virus also evolved into a milder strain, causing more of upper respiratory problem rather than low respiratory problem. January to February, we had the Omicron wave, which has now died down, and this is how it looks like. And if you look at the second wave, the reason why it was devastating is not only because of the number of cases, but the rise in the number of cases. The wave was very, very steep. And for us who were as clinicians working in the hospital, we did not have enough turnaround time. The first wave did give us some time. You had a patient who was admitted, he became all right on the 5th or 7th day, you could send him home. But in the second wave, you just had patients piling on, one after the other, and you could not have a rapid turnover, and that led to a huge strain, both in terms of oxygen, in terms of hospital beds, ICU beds, and this also led to a higher mortality. We had the third wave, which also was pretty high, but like I said, it was something which was milder, more cases, less admissions. I look at three waves in a different way. The first wave was the unvaccinated wave, which was milder but raised a lot of apprehensions. The second wave was the wave of pneumonia, low respiratory tract infection, florid fall in saturation, classical CT pictures. The third wave was the wave of comorbidities. We didn't see deterioration of lung findings, but we saw huge worsening of the underlying comorbidities. And I saw that we had a shift in our management strategy. The second wave, we were looking at critical care specialists, pulmonologists. The third wave, we were looking at associated specialists. Patients came with COVID, went into hepatic, who had chronic liver disease, went into hepatic encephalopathy. Patients who had chronic kidney disease suddenly required increasing dialysis. COPD patients worsened. They worsened because the virus caused worsening of the comorbidities rather than causing the pneumonia that we saw in the second wave. What are the causes of the repeated waves and why did India have the third wave? So I think it's pretty obvious that one was the waning immunity, which occurs as part of people who are exposed over a period of time. The immunity comes down and they become again susceptible to infection. The variants that we are seeing, the Delta, the Omicron, the sub-lineages of Omicron are developing the ability for immune escape and therefore are being able to cause more and more infection. And they are becoming more transmissible. The virus is also evolving so that it is able to continue to spread, continue to find more hosts, and that is also causing more cases. Also, of course, there is a relaxation of COVID-appropriate behavior, which is leading to a higher chance of spreading of the virus, which was not there in the past. So all of this are contributing to repeated waves. So what are the key aspects that we had as far as the fight against the pandemic was concerned? We had a lockdown, we had government packages, testing, vaccine program, and subsequently the genomic surveillance, which was set up as far as INSACOG was concerned. So we had an early national lockdown on 24th of March 2020, and this was then in a phased unlocking. This went on for weeks, and I think most of you will remember, especially me as a pulmonologist, that it really improved the air quality because there was hardly any traffic on the road. But this also gave us time to prepare. And we had multiple meetings where we looked at creating COVID centers, COVID hospitals, COVID ICU. Hotels were converted into COVID centers. Even the railway bogies were converted into COVID centers so that in remote areas, if you needed to have a facility to manage patients, a train could be sent there and that could be used as a COVID care center with oxygen tubing being put inside the railway berths and having one berth with all the equipment for a doctor or an emergency room being prepared. Subsequently, we had local containment zone policies during the second wave, but this also led to many hardships, especially as far as the lockdowns was concerned in the unregulated sector, and this is something that we must really accept. The government put in a lot of package. 15,000 crore was actually announced on 22nd of April 2020 as India's COVID-19 emergency response and health system preparedness package, which was for procurement of medical equipment, drugs. This allowed us to really get PPEs, N95s, ventilators, oxygen. There was also a lot of support to really prepare for future outbreaks. We had less laboratories at that time, so a lot of money was put in to really try and see how we could get more and more RT-PCR testing being done. And there was also an issue of trying to have risk communication activities. On the 14th of March 2020, NIV Pune isolated the strain of the novel coronavirus. India was the 5th country to successfully obtain a pure sample of the virus. And this helped us to develop our own drugs, vaccine, and rapid diagnostic kits. If you remember at that point in time, the cost of doing an RT-PCR kit test was even more than or close to about 4,000 rupees. Because of the indigenous and our own kits, it came down to less than 1,000 rupees, 500 rupees, 800 rupees, because we were able to make our own indigenous kits as far as testing was concerned. And this was because we were able to isolate the virus. The virus was also given to industry. Bharat Biotech got the virus from NIV, and they were therefore able to start research in preparing the whole viron inactivated vaccine, which is what Covaxin is. So in May 2020, NIV released the first rapid diagnostic testing kit. And this led us to start from what we had as 52 labs or even less of labs for testing COVID-19. And these were all labs which are part of what was a flu network. Remember, we have had one more pandemic before this, which was H1N1, which is also known as swine flu. Post swine flu, there was this whole issue of setting up a flu network lab system. And the plan was, of course, to do much more, but as unfortunately happens, you start off with a good intention, but as the pandemic wanes, the support in terms of financial support and interest wanes. So we had 52 labs at that point, part of the flu network, but these were insufficient. And there was a lot of effort that was done to increase these labs. Now we have close to 4,000 labs, and we have the capacity to do more than 20 lakh tests a day. As a matter of fact, if you look at the graph, we've touched even more than 30 lakh tests a day. And now with the rapid antigen test being available, testing is no longer an issue as far as India is concerned. But if you go back and remember the days of 2020, getting tests was a big issue. At that time, I had actually had the opportunity to visit a few states, and most doctors argued with me that I'm diagnosing COVID, but I'm not getting a positive report. It's taking 3 days to get an RT-PCR report. When I start remdesivir on a presumption of COVID-19, and that became an ethical dilemma. Can I start anticoagulants early? I remember one group of physicians I was addressing who were practicing, and they said we can diagnose it more based on a CT scan, which we can do faster than getting the RT-PCR report. So we have evolved over a period of time, but that was the time when it was a huge challenge because of testing being not available to that extent. It was a new virus. We really didn't know how to treat it. There was the National Clinical Management Protocol, which was therefore developed. We started off with whatever knowledge we had, even started off with anti-HIV drugs. In the beginning, people started looking at drugs like ritonavir, lopinavir, and then of course, hydroxychloroquine came in, ivermectin came in. Then there was a study on remdesivir, and subsequently, the recovery trial showed the role of steroids. So guidelines were made, and this was part of a group which was there, ICMR, Joint Monitoring Group, and the All India Institute of Medical Sciences. And we came out with these guidelines. These were this is in January. The latest guidelines, which is the AIMS ICMR COVID-19 National Task Force and the Joint Monitoring Group. These guidelines were made by looking at all the evidence very critically and seeing whether it fits into our treatment strategy or not. And we had a lot of sort of discussion, especially when it came to monoclonal antibodies, because they were coming into the markets, but they were very, very costly. And the data was not that strong. It was an issue whether we should really push in for a lot of monoclonal antibodies as a part of treatment. As far as the vaccine program is concerned, and I think this is something that we as a nation should be proud of, because I remember I was involved even during the H1N1 pandemic. And when we had the H1N1 pandemic, one of the problems that we had was we had no vaccine. And there was a huge issue. I don't know how many of you remember those days, because we had a young girl who died in Pune during the H1N1 pandemic. And there was a huge issue. Why don't we make our own vaccine? We even got after Serum Institute to make a monovalent H1N1 vaccine. But by the time they could make it, the pandemic had waned and there was no uptake for the vaccine. And we had to rely on donations from WHO in 2009 and 10 for the vaccine. So this time it was felt that we should actually be more proactive. And the NEGVAC, the National Expert Group on Vaccine Administration, was formed as early as April 2020. Multiple meetings were held, and we were asked to look at state level mechanisms, including cold chain, and even everything from the syringes that we would need, the swabs that one would need, how the cold chain would be maintained, how districts would be involved, and how we could reach more parts of the country was discussed. And this led to money also being pushed in as far as the COVID Suraksha mission was concerned. And we were very happy that the COVID vaccine got launched, both Covaxin and Covishield. Covishield, of course, is the AstraZeneca vaccine, and Covaxin is from Bharat Biotech. And now we have a whole array of vaccine. I think we are one country where we have multiple vaccines available, from Covaxin to Covishield, to the Sputnik, which is again an adenoviral vector vaccine, to the Johnson & Johnson vaccine. We have a plasma DNA vaccine, the ZyCoV-D. Cobrivax is also a VLP vaccine, which is also available. So different platforms of vaccine delivery are currently available, from inactivated. And now we have also recently got a mRNA vaccine, which can be kept at 2 to 8 degrees centigrade. So I think our vaccine story is something that we should be proud of. And because of that, number of people vaccinated has been huge. We started off in January with vaccinating healthcare and frontline workers, and moved on then to the elderly, with those with comorbidities. And as of 19 September, 102 crore Indians have received at least one dose of the COVID vaccine. That is a huge number for a country like ours. And 94.7 crore Indians have received 2 doses, which is close to almost 70% of our population. So our vaccine drive has been so smooth and successful that is something that we need to be proud of. This is a trial that we were involved in the early stages of the vaccine, where we looked at the immunogenicity and safety of the inactivated SARS-CoV-2 vaccine, which was a double-blind randomized trial, which was done by Bharat Biotech. And then there was a lot of issue as to the utility of this vaccine in terms of it being effective. And this is a study that we had done during the Delta wave, where we looked at the efficacy of these vaccine as far as healthcare workers were concerned. And this supported the ongoing rollout of the vaccine to help control spreads of SARS-CoV-2. We also did another study where we looked at reinfection rate and to estimate the efficacy again of our own indigenous vaccine, which was the inactivated whole virion vaccine. And we showed that its a protective association of 86% against reinfection was observed among healthcare workers who completed the 2 doses of the scheduled vaccine. So there was a lot of robust data done, which was not industry sponsored. This was data which was done by our own institute, by ourselves, to show the efficacy of the vaccine, and published in good peer-reviewed journals to show that the vaccine that we were making was something that we should be proud of. Then in January of 2021, when we started having new variants coming in, the INSAGOG was started, which was the Indian SARS-CoV-2 Genomic Consortium. This consortium was established to try and see what new variants we are getting in our country and how should we interact. I would say, if you want me to be really honest, we were a little bit slow off the block. We should have done this much earlier, but this helped because we were able to then pick up the variant that was picked up in Pune in 2021, which was what was that time known as a double mutant, because it had 2 mutations at the spike protein which were of concern. This led to the Delta variant, the B.1.6.1.7.2, which was then declared a variant of concern by WHO. What we were not able to do was link the new variant with the type of cases that we were seeing, and therefore be able to have an early warning that this new variant is going to be more lethal and cause the type of destruction that we saw with the Delta wave. So I think the importance here is the importance of the lab talking to clinicians and epidemiologists and public health experts and developing a comprehensive mechanism of coordination rather than working in silos. In July of 2021, the second COVID emergency response and healthcare package was released, and this was done after the second wave, and this was again to prepare for any future waves. And then there was a concern that the next wave will affect children more. So importance on pediatric care was given, setting up 20,000 ICU beds, more of liquid oxygen storage facilities. And all of this was funded along with telemedicine facilities and the COVID portal, which was very, very successful. So I'll just briefly mention in the next few minutes what we did at the All Institute of Medical Sciences. We got prepared very early, and as early as February of 2020. And I remember at that time, many people coming and telling me that this is just going to be a common flu. Why are we putting in such a lot of effort? Because we converted a lot of our areas into COVID areas. And in the first few weeks, we had a whole hospital which we made into a COVID hospital, and we had only 5 or 6 patients admitted because the wave was just starting at that point in time. But we formed various committees, human resource management committees, to look at posting residents, posting people into COVID areas, making sure that the supply chain was maintained, both in terms of equipment, both in terms of testing. And every day in the morning, I would have a meeting with the entire staff, that is faculty, residents, nursing officers, technicians, and we would have new problems every day, and we would discuss solutions for that. I remember one day we had an issue of a resident whose wife was 9-month pregnant, turning out to be COVID positive. Overnight, we had to work on developing a COVID labor room. And I was discussing this with the head of obstetrics and gynae in our institute, and she said, I don't think it will be much of a problem, but the next day we had a positive patient. So we had to keep evolving. How do we do that? issues which came up. Residents raised the issue of fogging while they put on their goggles and go into the COVID area, that they are not able to see while operating. And then in one of the morning meetings, the resident came up with a fan that he had fitted inside the goggle, which was able to get away with all the mist that occurred. And he patented that. He had a small fan, a wire, and which went onto a small battery. And that fan would make sure that there was no misting as far as the goggles was concerned. We had an issue of shortage of PPEs in the early days. And we were wondering, what should we do? And then we thought, can't we recycle our PPEs? So we did an experiment where we looked at PPEs which were in good condition, put them up in a fumigation room, put bacteria, spores, which are more resistant to dying as compared to the virus, and developed a strategy which is now there in the WHO guidelines also, that you can recycle PPEs if you want, if there's a shortage. And we had a whole storage of recycled PPEs which you could use in the early days. Of course, after that, there was no PPE shortage. But what I'm trying to tell you is that there was a lot of interaction with residents, nursing officers, staff, which helped us to innovate and develop new strategies. We converted our National Cancer Institute, which is a 700-bedded hospital only dedicated for cancer in Jhajjar, which is around 50 kilometers from main campus, into a COVID care center, a ward, and an ICU. The trauma center, which had less patients because of the lockdown, where there was no trauma occurring during the lockdown, was converted to a COVID hospital. And we created 1,700 COVID beds. And in the beginning, 125 ICU beds, which went up to 250 ICU beds. And we had, during both the peaks, about 1,000 patients admitted in our care. And you can imagine there was no increase in our staff. There was no increase in our overall human resources. And yet we had to manage these 1,000 patients. This is a picture of our National Cancer Hospital in Jhajjar, which is a 700-bedded hospital. It's a hospital, it's a OPD, it's a research block. It also has hostels, residential accommodation, and an auditorium and an academic block. This is a trauma center, which is also converted into the COVID care hospital. We also realized the importance, and this is what we realized in the early days, of the importance of training of our staff, because there was a lot of panic among the staff in terms of if we get the infection, what will we do? I can't tell you the number of times I've had to talk to nursing officers, residents, because if they had an exposure to a COVID positive patient, at times they would refuse to go home. They would say, if I go home, I'll take the infection to my family members, and I have elderly parents at home. So we started webinars, teleconferences, online modules, and more than 33,000 AIMS employees were trained by modules that we made, and we used to run them in morning and afternoon shift of 3 hours each. And we made sure everyone went through the modules of hand washing, donning, doffing, the infection control practices that are required. And then we put this on our Saral platform, which is an online platform which we use for undergraduate teaching. And we use that platform to really teach doctors and nurses on a regular basis as far as hospital infection control practices are concerned. We got also involved in a lot of national-wide activities, mentorship, grand rounds, EICU, centers of excellence, web-based programs. And we also, in our guest house, started what we called a contact facility, so that doctors who had any issues in terms of diagnosis could call us 24/7 in terms of COVID-19 management. This is the issue that we did to enhance RT-PCR testing. This was something that we were asked to do by the Ministry of Home Affairs, actually. And in April 2020, with ICMR, we set 14 mentoring institutes across the country, AIMS, JIPMER, KGMU, NIZAMS, NIGRIMS. We supported them in terms of developing RT-PCR testing labs in that area, especially in medical colleges. All private and government medical colleges were pushed to have an RT-PCR lab. And there were private colleges which were not willing to do this. So I was at that time also part of the board of governors in the MCI, got letters written to them that your college will get de-recognized if you don't start an RT-PCR lab. And we had this dashboard, and it would you mark it green if the lab had the equipment, they had the manpower was trained, and they had got the accreditation in terms of the lab having been properly tested for quality control. By this, we were able to get all medical colleges in 6 to 8 weeks having an RT-PCR lab. We moved to universities then, veterinary labs, and got veterinary labs in universities which had a science department to also start doing RT-PCR testing, and then attach them to various institutes because they didn't have a medical microbiologist. So we needed a medical microbiologist to support them And that was how we were able to get so many labs doing RT-PCR testing. In 2020, we started doing webinars as part of what was asked for us to do. And we did 6 webinars on management and site preparation. Huge uptake. We had more than 3 lakh views, and this was very popular. We did a webinar for nurses, and this was also very popular. This was done by a College of Nursing. And we also did webinars for SAARC countries in terms of COVID management. And this was very interactive with the doctors from Nepal and from the Maldives in terms of how to manage COVID-19. Then during this time, one thing that we realized was that we were not able to get, there were a lot of issues which people had in patient management. And then in collaboration with Niti Aayog, we started what we call the National COVID-19 Grand Rounds, where it was a case-based discussion. We would discuss a case and then discuss the issues in management in that COVID-19 case, discuss it as a topic, and answer questions which would come through WhatsApp. This was very popular, and the viewership here also went up to almost 3 lakhs as far as these programs were concerned. We did it with international universities. This is one that we did with University College London, where we learned from their experience in terms of COVID-19 management. And these were various activities that we did. We then started our eICU program. This we used to do twice a week. And here again, we would talk to hospitals which were having more than 500 beds on managing COVID-19 patients and discuss management strategies. And I realized the huge diversity in treatment that was there. People who were giving remdesivir on day one, there were people who were giving methylene blue as a part of treatment. And the doctor argued that he found methylene blue to be very useful. There were others who said we are giving steroids on day one. So there was no consensus in terms of treatment. And that's why this eICU program has started. And I interacted with, I think, more than 500 institutes across the country in terms of trying to see how we could manage COVID-19. Then we were asked by the ministry to set up centers of excellence in various states and regions, and we used a hub and spoke model. We had phase 1 and phase 2 of setting up centers of excellence. This was phase 1 that we did as a clinical excellence program, where we started getting states to be involved and then starting a training of trainer program. Phase 2 was done in the second wave, where we created 13 centers of excellence, again through webinars. And then subsequently, it was felt that the pandemic will go to rural India, to smaller towns. And therefore, in June of 2021, we collaborated with the Indian Medical Association to really start the training for general physicians to manage COVID-19 as far as this was concerned. And this was then converted to online training modules. So this is all that we did, and just in a nutshell. But what are the lessons that we've learned? I think one thing is certain, that there's no going back to the pre-pandemic as far as healthcare system is concerned. And therefore, we must learn and move forward in terms of what we can do. So what are the issues that we need to look at? One is the Indian healthcare system. What are the major challenges that we have? How can we prepare in the future for emerging public health crisis? And why is it needed? And I personally would say that I think this is a century of outbreaks and pandemics. If you look at the last 22 years of this century, we've had more outbreaks than we've ever had before. We had SARS, we had H1N1, we've had H5N1, which is known as bird flu, we've had MERS, we've had Zika, outbreaks of Ebola, and now we have monkeypox and so many others. So we are now living in an era in this century where we will see multiple outbreaks and new viruses. And I'll come to that as to why we're seeing that. So Indian health system is something which has evolved over time. We have a public health system and a private health system. The public health system predominantly focuses on delivering primary health care through community level health programs. It follows a tiered system where you have the primary health centers, the secondary and tertiary centers are starting from district level, going all the way up to state headquarters and a tertiary hospital. The private healthcare comprises 60% of all inpatient admissions. And this, unfortunately, is concentrated predominantly in Tier 1 and Tier 2 cities. And we don't see a lot of private healthcare in Tier 3 or cities or rural India. So Indian healthcare system, to some extent, needs a revamping. It is dysfunctional. And some problem that we are seeing is awareness. There is lack of awareness among the public on health issues. Second is access. There are geographical inequalities in healthcare providers, facilities, and medication. There's absence of manpower and resources in certain areas, and affordability is another major issue. So these 4 A's, awareness, access, absence, and affordability, are something that we need to really work aggressively on. And this is what the COVID-19 pandemic showed us. Lack of awareness, there's low educational status, poor functional literacy, and lack of importance given to health education. A lot of illnesses are preventive if there is good health education. Hygiene, hand washing, something that we should routinely do, is not followed as sincerely as should be. And there are a lot of papers on this. There is, for example, knowledge regarding breastfeeding practices was found only in 1/3 of antenatal mothers in our country. Only 11% of adolescent girls knew correctly about key reproductive health issues. So there is a lot of basic things that we need to focus on when it comes to awareness as far as health is concerned and preventive measures for health. Access to healthcare. There is a huge inequality as far as access to healthcare is concerned, and that was something which came out during the pandemic also, that this led to the vulnerable population being affected more as compared to others. If you look at the data, in rural areas, only 37% of people were able to access inpatient facilities within a 5-kilometer distance of residence. The further one lives from a town, the greater are the odds of disease, malnourished, weakness, and premature deaths. This is something which is there as far as India is concerned. We did a study, which was a simple study long time back, where we looked at patients coming to our own hospital, AIIMS, and looked at their residence, the distance of their residence from the All Institute of Medical Sciences, and the gender. And we found that the further they were from AIIMS in terms of their residence, less and less women were coming for health, for treatment as far as health is concerned. Suggesting that if you are in a far off area, men will get preferred and would come for healthcare treatment. Women will still have to suffer. And that is why we need to look at all these biases that still exist in society. Then there's absence of sufficient manpower and resources, and we all know this. We have roughly 20 health workers per 10,000 population. But I think the most important thing here is that this is not equally distributed. We have at times surplus of healthcare in Tier 1 cities, but as you go down to Tier 2 and Tier 3, there is a shortage of healthcare. And we really need to see how we can really change this as far as the rural health statistics is concerned. Third, the other important part is affordable healthcare. Almost 75% of healthcare expenditure comes from out of the pocket. And that again causes a huge problem, because many people, especially the lower middle class, if there is an ICU admission, they go below the poverty line. And that is again something that we need to look at in terms of how can we support health as a social responsibility, irrespective of socioeconomic status. So what did the pandemic do? The pandemic really hampered the public healthcare delivery of services to treat illnesses other than COVID. And this is something that is the I would say, acknowledged mortality and morbidity that we had. The non-COVID care suffered tremendously. Private hospitals and labs witnessed a sharp decline in revenue due to delay in medical tourism, elective procedures, and they had a problem as far as this was concerned. OPDs were closed for a long period of time during the lockdown and during the outbreaks. This also led to problems in terms of healthcare delivery. And if you start looking at data, it suggests that there was a significant increase in HIV, TB, and malaria during this period of time, because we were not able to focus properly on care for these non-COVID diseases. If you just look at the data from tuberculosis, there is also a paper which is published in the International Journal of the Union, which has looked at both the benefits of the lockdown, because of course, infectious diseases had some benefit also because of masks and things like that. But the fact that the program suffered a lot, DOTS program suffered a lot, case finding suffered a lot. And this led to increase in mortality, which went up from 17% to 20% in 2020. And therefore the death toll rose. And we have a lot of catching up to do as far as TB elimination program is concerned, if we are going to look at it from that point of view. What are the lessons that we've learned as far as preparing for future pandemics or emerging diseases are concerned? So I think we all should agree that there is a need for a major overhaul as far as the health crisis is concerned. We are seeing more and more infectious diseases, natural disasters, bioterrorism will also be there. And therefore, there is a need for all of us to develop strategies to be able to tackle this whenever this happens. And like I said, we are seeing outbreaks. We have Nipah virus outbreak in Kerala. We had monkeypox, which was declared a global public health emergency, tomato flu outbreak being reported in India, and many more. And I just counted another almost half a dozen outbreaks that we've seen in the last 20 years, which have been a cause of concern. Therefore, I think pandemics and outbreaks are here to stay. And why is this happening? Why is there an increase in new infectious diseases? And I think it's because of travel, trade, connectivity, growing urbanization, encroachment into new environments, and global warming. All of this is contributing to new emerging diseases. Remember, all of these outbreaks that we mentioned are zoonotic in origin. These are viruses which have jumped species and then developed the ability to have good human-to-human spread. COVID also came from a non-human source and then became a human virus. SARS also came from a non-human source, and so did H1N1. So why is this happening and why is it spreading so much? One, of course, is more travel, trade, and connectivity. We have become a global village. For a long time, humans lived in small bands and remained relatively isolated. Ebola stayed in Central and Western Africa because people really didn't travel out from there. But that all has changed. And therefore, if you travel, especially if you take air travel and you're in the incubation period, the virus will travel with you and will cause an outbreak in a new area where that disease does not exist. We saw this with MERS. MERS is Middle East respiratory syndrome, which happens in Middle East, in Saudi Arabia. And if you look at what happened in 2015, many people came there from Europe and even from South Korea as part of Hajj. And when they went back and they visited someone in hospital, they carried the virus with them, and we had an outbreak of MERS in various parts of the world, including that South Korea, where we had a huge number of cases. SARS traveled all the way from Hong Kong to Canada in 2002 and 2003. And here also what happened was, if you look at the epidemiological history, one Canadian citizen crossed another person who was having the virus in the corridor of a hotel, and that person was coughing a lot. This person got the viral infections, caught a flight in the evening to Canada, landed there, and people didn't realize that this is a novel virus. Many healthcare workers died out there and created a huge problem during the SARS outbreak. So we are going to see more and more viruses traveling globally because we are now traveling a lot and the world has become a global village. Then there's a growing challenge with urbanization. Close proximity, we are becoming more and more urbanized, and that is also leading to decrease in sanitation, more breeding, more vector-borne diseases happening. All of this is of course also causing a huge strain on the healthcare system, and this is something that we need to be aware of. And of course, like I said, cross-species transmission has started happening more frequently than what we were seeing. And therefore, SARS, MERS, COVID-19, all of them are viruses which have jumped species because of the encroachment that has happened. If you look at a market in China, especially if you go to South China, the encroachment is such that you will have live animal and humans in the same market, because the philosophy there is that if you're selling animals or even fish or other non-vegetable, non-animal products, it has to be live rather than dead, because they feel that then only you know it's a fresh product. And therefore there is going to be overcrowding of animals and humans, and that's why wet markets, bush meat, and animal trade all are contributing to cross-species transmission, and this is what we're seeing. And that is why the concept of One Health becomes more and more important. Human health, animal health, plant health, and the health of animals are all linked. And therefore, we need to start working on interdisciplinary or interdependent health and started looking at health as one concept rather than only human health. And the interconnection of human health and animal health has become more important today than ever before. And I think this is now being recognized. There are institutes being set up in our country also, One Health institutes. And it is a need for us as clinicians to start talking to veterinarians and others to develop a strategy as far as One Health is concerned. And this is also important as far as the planet is concerned. Now coming to future preparedness, and this is the last part of my talk. So what are the potential avenues for the healthcare policy? One is public health awareness, which we discussed needs to be looked at. Upgrading manpower in medical institutions in Tier 2 and Tier 3 cities, because we knew that human resources. We need to develop good health insurance schemes and awareness so that people don't get pushed below the poverty line. And I think what COVID taught us is the use of technology is something that we were not doing as much as we could, especially telemedicine. And then we have to have investment as far as government policy is concerned and public health measures and vaccination programs. We need to invest in all of this. Lack of public health awareness, public health education can improve health status of our population. And I think this is something that can be done as far as preventive health is being concerned. And this has been shown in number of studies as far as reproductive health is concerned, nutrition practice is concerned, child health is concerned, environmental health is concerned. And we need to focus on the younger generation. And this is something that we need to keep continuing to do even post-COVID. COVID, there was a lot of active risk communication strategies, whether it was wearing your mask, regular hand washing, do gaz ki duri. But more than that, now we need to make it into a movement, because preventive health will help in decreasing a large number of diseases and also be able to focus even when we talk of not only infectious diseases, but non-communicable diseases. They are also very important when we start looking at preventive health. Then we need to upgrade manpower infrastructure in tier 2 and tier 3 cities. What COVID pandemic showed us that there was a huge shortfall as far as beds were concerned, accessibility for oxygen was concerned in these smaller cities, and they suffered the most. And therefore, there is a need for us to develop strategies to improve that. We need to have more beds. We need to have more support as far as rural India is concerned. And this is being done by setting up more medical colleges in underserved areas. But I think there is a lot more that we need to do. And I already mentioned we need to look at health insurance schemes and awareness. Health for all is something that we must feel is a right for our citizens. And we must develop a strategy that health for all is something that should be there. Ayushman Bharat is there for people in the lower socioeconomic status, but I think it needs to be expanded to really cover all citizens, even in the middle class, because many of them have huge problems when it comes to paying the health bill. The use of technology was something that we were able to do aggressively during COVID-19. We had the Arogya Setu, which you could tell you whether you were COVID positive or negative, and if anyone around you was COVID positive or negative. We had a very successful COVID app. I remember a lecture I was attending with a person from the US, and he said, you have such a beautiful app, you can print out and you can take it on your phone, the report of your vaccination status. I have just this piece of chit, and for the booster dose, it is written, scrawled on the back. There is no printout also, just the signature and someone writes it on the back. I don't have anything which is available digitally. We were able to do that so well that when you go out and show your on your phone that the fact that you've been vaccinated and the day you got the vaccine, the booster dose, it's something that makes you feel very, very proud. But I think this app did very well because it covered such a large population. More than 1 billion people are on that app. And sometimes I tell this to the people who are involved in that, this is a huge database that we can use for various other researches if you would want to do that. Telemedicine became very, very important. In the early stage, telemedicine was very useful when we were trying to look at our non-COVID cases. How do we manage them? Because they were scared to come to the OPD and they were not willing to come to the hospital. So a lot of diabetics, hypertensive, COPD patients were managed using telemedicine and teleconsultation. And then when it came to home isolation, then telemedicine and teleconsultation was used to manage patients who were isolated at home by looking at their pulse oximeters, seeing how breathless they were becoming, what symptoms they were developing, what was the type of fever they were having, and treatment strategies evolved around that. So telemedicine, I think, is something that we really need to work on. It is something that has a lot of future and it has been there for a long time. We were pushing very hard for this even before the pandemic. I was a member of the board of governors and we were trying very hard to get telemedicine on board, but there was a lot of resistance. But the government then approved it in March 2020. It was notified and we had telemedicine practice guidelines, which is work in progress. I think we need to improve it further in terms of the telemedicine guidelines because it needs to have a legal status when it comes to prescribing drugs through telemedicine. And this became part of what was known as the e-Sanjeevani OPD, which the government of India launched, which is very, very popular and connects doctors to patients through telemedicine system across the country, even in rural India. So I think telemedicine is something that is going to stay with us and we need to use it optimally, both in terms of managing outdoor patients, but I think even in terms of helping doctors in, as far as e-ICUs are concerned. As we move ahead, what are the challenges? I think one more very important is that we have to have an aggressive surveillance system. We have to have a network of laboratories which can pick up any new variant which comes, whether it is related to COVID or it is a non-COVID viral pathogen. It could be influenza or it could be any other new virus. And therefore, there is a need to develop a system, a network of labs which are available with biosafety facilities and are able to do these testing for any new emerging disease. But at the same time, we also need to train public health officials to be able to deal with this and have the suspicion of an outbreak. Unless both of them talk to each other, we will not be able to get an idea of what is happening and what is the consequence of what is happening. You may see an outbreak, but what it is leading to in terms of clinical outbreaks will only happen if the public health officials, the clinicians start talking to the lab. And we need to develop capacity for developing new vaccines and new medicines. So we need to have a surveillance and response team, rapid detection of unusual pattern, track and exchange information, real time, quick response at a larger level, and contain transmission swiftly and decisively so that the outbreak is limited to one area alone. A lot of investment needs to be put on applied research, especially when it comes to developing broad spectrum therapeutic approaches from zoonotic pathogens with potential of emerging in humans. And that's why the concept of One Health is very important. Before talking of therapeutic strategies, I think we must understand that hand hygiene, mask, and social distancing is something that is very effective as far as respiratory pathogens is concerned. And not only now, it was shown way back during the influenza pandemic in 1918. Clearly, data from various countries during that time showed that the mortality and the return to work was much faster in those areas which had stricter policies as compared to more lenient policies. So if you have strict policies in place, you will have decrease in mortality and you will be able to bounce back faster rather than having a more lenient approach. Also, we need to have preemptive therapeutic strategies for emerging pathogens. COVID-19 showed unequivocally that there was a need to anticipate and prepare rather than merely react. For example, newly developed therapeutics for COVID-19 were not approved till November 2022. We had broad spectrum antivirals, which were like remdesivir, approved in May 2020. And therefore, there is a need to be proactive rather than reactive as far as new viruses are concerned. Just to highlight this point, that if you are going to really look at some drug where you are going to wait for an outbreak to happen, then test it and then get an FDA approval, is going to take a huge time. But if you're proactive in the early part and you start looking at developing early, even before the outbreak has really reached a stage, you would be able to get a drug much faster. And therefore, there are two approaches. One is repurposing drugs, which is drugs like remdesivir, which is repurposed, and novel drug developments, which we need to start working on in developing and doing research, looking at what is emerging as far as the animal environment is concerned. And here again, I think we have to look at broadly active antivirals. A highly effective but highly specific therapeutic agent may not be efficacious against the next emerging virus. You need to have a broad acting antiviral, and the research needs to be done on that. So it's vital to develop and identify family-wide or group-specific therapeutics and vaccine rather than only for one virus, because like I said, we are going to see multiple outbreaks, and this is something that research is urgently needed as far as the future is concerned. And therefore, we need to look at direct acting antivirals, which target the virus itself, or host factor antivirus, which sort of look at the host. And we have direct acting like remdesivir or host acting like baricitinib. Both were used during the COVID-19 pandemic. So I think in the end, we have roadblocks which we must acknowledge and see how we can overcome them. We are looking at in the future what we could call an unknown pathogen. So how do we develop strategies for that? There is lack of in vitro and in vivo models for screening. If you talk to industry, they say we don't know what the marketing potential is. If you're making a vaccine, how do I know it will be used in the near future? I will invest millions and then nothing will come out of it. So there has to be government support. For COVID vaccine, the US government pumped in a lot of money in the beginning to get the vaccine out when, as far as industry was concerned. And then we need to look at how we can have new drugs which could be useful. So these are all important issues, but sad part is this is something that has been highlighted for a long period in time. way back in 2018, I wrote an editorial, which was that 100 years after the 1918 pandemic, we are still vulnerable and we still need to prepare for pandemics because there are going to be future pandemics. But like I said, we are more sort of reactive rather than being proactive as far as outbreaks and pandemics are concerned. And also there's a need to change as a pandemic evolves because our strategy and knowledge will change and we need to evolve as far as that is also concerned. So I'd like to end here by saying that there are many lacunae in our healthcare system which hamper the ability to deal with current and emerging challenges. We did very well as far as COVID-19 pandemics are concerned, and our healthcare system has emerged stronger. But I think there are lessons that we have learned, and we really need to focus on that. We also need to remember that when we're dealing with the pandemic, we should not forget the non-pandemic illnesses or the non-COVID or illnesses that we saw during this period in time. There has to be more awareness as far as public health systems are concerned, upgradation of manpower and resources is concerned, and equitability in healthcare is very, very important. We need to develop emergency response and healthcare preparedness, good surveillance, good data sharing, so that we are able to pick up an outbreak early and act rather than act later when it is spread all over. I think these are very, very important things. And I'll just conclude by saying by Mahatma Gandhi that the future depends on what you do today. Thank you very much.
Thank you, sir. It's been wonderful, spellbound. Everyone has enjoyed it. Thank you very much for coming and delivering this lecture. So before I declare the lunch break, may I announce a few small things. After the lunch break, now we'll go for lunch break. After that, we have got very interesting programs. There'll be case presentation on pleural diseases, followed by a workshop for preparing for the final PG exam. These I have tried as a unique effort to replicate an examination hall out here. And I believe the PG students will be enormously helped from this particular effort. At the same time, there is a symposium on the other hall that is about career options for the young pulmonologists. So people from different expertise will be talking on how to make career according to the sweet will and the capability of a particular pulmonologist who is grooming and going to choose his career. There are other programs as well. I hope all of you join us to lunch now and then come back before 2 p.m. to the respective halls. The hall 2 after the session has a quiz. First day is for the elimination round. And the second day will be out here tomorrow at the quiz show in the noontime tomorrow. Thank you very much. Good afternoon. Now, post-lunch, we are going for the next session. This is on pleural diseases. We have got two consultants and a few cases of interesting cases on pleural diseases. I request Dr. Shoibal Ghosh and Dr. Arunabu Datta Chaudhary to chair the session. Dr. Ghosh and Dr. Datta Chaudhary, please.
Good afternoon. Welcome back to the post-lunch session. I hope everybody enjoyed the beautiful lunch and everybody is ready for the session. So this session will be on the pleural disease. There are two speakers. The first speaker is Dr. Lakshmikant Baburao Yange. He is MBBS, MD in internal medicine, DM in pulmonary and critical care medicine. His specialization is on the respiratory medicine. Current place of work is in Pune, Maharashtra, and his status is consultant at Dinunath Mangeshkar Hospital. May I request Dr. Lakshmikant Baburao Yange to come and to start your presentation.
Good afternoon. First of all, I would like to thank Dr. Partha for giving me this opportunity to travel back to Kolkata. I was here for 6 months for a fellowship in GI endoscopy. That is different topic we can discuss if time permits subsequently. So I have been given a task to discuss about pleural diseases, and we are keeping it case based so that it is useful. So, and this talk is going to be followed by a session how to prepare for exams. So largely I'm going to start the preparation for exam from now itself. So this case will have a lot of questions. So I request all the PGs who are present at the moment in hall to raise the hand, and if they can come to the central row. PGs who are still in PG. Okay, and those who are less than 5 to 7 years into practice, which is like my age, all of them to come into the center so that we can discuss. Okay. Okay, so I'll take you through two interesting case scenarios and we'll discuss different issues which we face during these two phases of managing pleural effusion, secondary to a common problem which we are going to see. So the first one is 18-year-old male who comes on 13th of September 22 with fever, cough, no sputum production, right-sided chest pain, and this is his chest X-ray. So with this, what do you think is going to be the next logical step which we are going to take? Okay, so I presume it is going to be a pleural tapping, and what are the investigations which we are going to order on pleural fluid? That is the next question. So basically what we are going to order is routine examination, LDH, ADA, culture, and if required, subsequently you may go for something like cytology, gene expert, and AFB culture. We can discuss the merits and demerits of individual tests subsequently when we come to the individual issue. So for this particular patient, the pleural fluid was exudative, by Lights criteria, sugar was 89, ADA was 12. Aerobic culture grew Enterobacter, which was sensitive only to colistin and phosphomycin, but of course the result has come little late. So not on 13th the result was available. So how do you proceed with such a effusion which presents with which is exudative on pleural fluid analysis? So the logical next step is to give antibiotics and possibly observe and consider drainage. However, at least from the routine examination criteria, there is no absolute indication for drainage. Plus the pleural fluid appears little small in size. So drainage at this particular point may not be a wise idea. So the patient was put on antibiotics as per sensitivity. And these are the serial chest x-rays that we have, 13th, 15th. Slight increase in pleural effusion. On 17, there is further increase in pleural effusion, and at this point in time, the clinician decides to put in a drain to facilitate the drainage. However, 2 days after putting in drainage, the fluid has not yet budged, and it is still there, possibly organized collection. And this is the CT which is done on the 17th of September, corresponding to the 17th chest X-ray when the ICD was inserted. Okay. So with this, what do you think is happening, and why the pleural fluid is not improving, and what are the options further? So anybody? So just think of these options: IPFT, thoracoscopy, VATS, thoracotomy. Which one is the preferred for which group of patients? All of them are valid options, I would say. However, there is some nihilism about IPFT, and that is what I am possibly going to try and allay over next few slides. Okay, so with these options, this is the result after 2 days of therapy. The tube is same, it is there in the same position. However, the fluid has disappeared. So what possibly is the intervention which has been done for this particular patient? The obvious answer is that the patient received intrapleural fibrinolytic therapy alone. So now there might be a logical, rational thought process which suggests or which could raise these questions. So why do I keep doing this? Why don't I know the latest evidence which has conclusively said that intrapleural fibrinolytic therapy doesn't help? Don't I have access to thoracoscope? Am I not confident enough doing thoracoscopy, or don't I have access to a surgeon? All these questions are absolutely valid questions. I'll try to answer those questions in few slides following, which are going to follow. So these are the observational studies. The first observational study about intrapleural fibrinolytic therapy came in 1951. Wherein they reported 25 patients, out of which 21 patients reported significant improvement in drainage. Only 4 patients had residual collection at the end of therapy. So these are the large number of observational studies. However, they are limited by the numbers. They are small in number. However, still more than 90% have showed improvement. This is regarding the urokinase. Similar, more than 70% success rate for most of the studies, though the numbers are small. The largest one is 210 patients. Now we might say these are observational studies. They are not acceptable as evidence for today's practice. So we move to the control trials versus placebo. Streptokinase versus placebo, 4 trials, largest 127 patients. Again, there was better clinical success, lesser surgical referrals in the streptokinase arm. Moving on to the urokinase, for that also we have 2 trials which have studied urokinase versus placebo. The 2 advantages of urokinase are: one is once a day dosing, the other one is it doesn't require plasminogen for activation. So it is effective irrespective of presence of plasmin, which is actually low in the pleural fluid. So if given the option, urokinase possibly is the agent of choice for me. I'll come to that, back to that later. So this is the largest study which actually tried to put in a nihilism in our brain that intrapleural fibrinolytic therapy actually doesn't help. So this was a 454 patients trial. Streptokinase versus placebo twice a day for 3 days. Inclusion criteria was empyema, positive fluid, gram stain or culture, pleural fluid pH less than 7.2. Chest tube size which was used was 12 French, which is similar to the practice which we are doing at the moment. Median duration of symptoms before randomization was 14 days, which was little odd. Possibly that is not the practice nowadays. None of our patients wait for 14 days with fluid in the chest, especially if it is a parapneumonic effusion. Empyemas were there in 83% of the patient documented. And these are the outcomes. And this is why the nihilism came in. The outcomes measured are proportions surviving without surgery was not different, and the proportions remaining hospitalized at the end of about 3 months was not different. So this is why it said that it doesn't help. But is it really true that it really doesn't it? Why is it not true? Because these two endpoints which have been considered, they try to look at more hard endpoints in this particular trial, which were actually not major concern in patients with parapneumonia effusion. To have a trial which can give adequate power for differentiating mortality benefit, possibly the numbers required is very, very high, which was not enrolled in this trial. If they had focused more onto the drainage and expansion of the lung and clinical effervescence of the symptoms, possibly they could have got different outcome. The other two important drawbacks which I would like to highlight are they included patients even without loculations. So the fibrinolytic therapy usually helps where we enroll patients with loculations. If you enroll patients without loculations, it is unlikely to give added benefit. So outcome measures of mortality and length of stay were not something which were very congruent or reliable ones. So to overcome these two trials and to test another molecule, the same group proceeded further to do a MIS2 trial, wherein they enrolled 210 patients, double-blind, double dummy trial, TPA 10 milligram twice a day for 3 days, plus DNAs or with placebo, and or DNAs alone, monotherapy. And this time they enrolled patients with loculated effusions. So more than 90% of the patients had loculations. Mean duration of symptoms prior to randomization was 14 days, and chest tube size used was less than 15 French in most patients. So these are the results in nutshell. The red ones are the ones which have been told to us loud and clear that the combination definitely is superior. And we don't have DNAs available. So for us, this trial has no meaning. So we cannot use drugs based on this particular trial. However, if you look beyond that, what the authors want to tell or what are the main conclusions, DNAs actually has got monotherapy actually has got worse outcomes as compared to placebo. And the TPA as a monotherapy has got slightly better outcome as compared to placebo, though it does not meet the clinical significance or statistical significance. So if at all we had to choose an agent, which one is actually helping in this particular trial, the agent which is possibly helping is fibrinolytic therapy. So is it over after this particular or these two trials that the fibrinolytics actually do not help? And this is the systematic review and meta-analysis, which was published immediately a year later, and which included both MIST-1 as well as MIST-2 trials, as well as other 5 trials. And the conclusions of this particular meta-analysis are that fibrinolytic therapy is potentially beneficial in managing parapneumonic effusions in adults, may be considered in patients with loculated pleural effusions. Further, RCTs with adequate power are actually needed to confirm these findings or to support this practice. So with this, I would just, and this is the final conclusion, wherein there is no difference in mortality if you look at the mortality as outcome, but surgical referrals, if you compare, there definitely is improvement in most of the trials. So with this, I would just take you to what do I feel about fibrinolytic therapy. My take is that you must try fibrinolytic therapy if thoracoscopy is not indicated for diagnostic purpose. If your diagnosis is in dilemma, if you anyway need a pleural biopsy, possibly going ahead and doing thoracoscopy and taking biopsy as well as doing adhesive lysis will be option. But if diagnosis is very clear, parapneumonic effusion, you must try a small bore catheter drain followed by intrapleural fibrinolytic therapy at present. And the agent of choice at present is urokinase over streptokinase over TPA. Because of the obvious cost reason, I don't see or feel that there is definite advantage of TPA over urokinase. If 2-3 doses of IPFT fail to improve the drain, proceed with surgical options, which is usually a 2 days time. And even if you sort of ask for a surgical intervention, the 2 days time is anyway required for a surgeon to prepare the patient for surgery. So in that time, you can use that window and try and achieve drainage. So this actually improves outcomes for all. It gives you sense that you tried all before resorting to invasive, aggressive interventions. It also gives confidence to the patients and relatives that you have tried non-invasive measures before going with invasive. And it also allows the surgeon time to prepare for surgery. So everything is achieved in optimized manner. That is what I feel. So with this, we'll move on to the another delayed problems which we face in pleural effusions. So this is another patient, 19-year-old male, presented in January 22 with fever, cough, right-sided chest pain again. Evaluation at that particular point in time was suggestive of right-sided pleural effusion, which was exudate, lymphocyte predominant, ADA of 102. Baseline AFB culture was not done for this particular patient. And these are the questions which strike our mind. What is the level of confidence in the diagnosis of tuberculosis? Can we start antitubercular treatment based on these reports? Should we go beyond this in all cases? If yes, what are the options? And sensitivity of the various tests for the diagnosis of tuberculosis. So I'll try to answer one by one. The level of confidence in diagnosis of tuberculosis for this scenario is largely very good. So I will be very, very confident starting antitubercular treatment for these patients if it is just for the sake of making a diagnosis and starting antitubercular therapy. However, if I really want to know the sensitivity, possibly I would send the AFB culture at baseline for all such patients. Should we do further test for all such patients? It depends on the circumstances where we are practicing and how the patients are presenting to us. So if it is a peripheral setup where most of the things are not going to be available, starting with treatment and observing closely for the response for next 1 or 2 months is a reasonable option. If it is feasible, go ahead with gene expert and AFB culture as well as cytology to rule out lymphoma, because a very high ADA is seen falsely positive in patients with lymphomas also, especially if you are getting ADA more than 150, 200, 250, 300. Always be suspicious that possibly you may be dealing with lymphoma and you have to look for that. Now coming to the sensitivity of various tests. So the sensitivity of acid-fast smear on the pleural fluid is to the tune of 10 to 15%, slightly higher in patients with HIV. Sensitivity of gene expert is to the tune of 20-25%, varying up to 65-70% in different studies. On an average, you can take around 35 to 40%. So the sensitivity of ADA is actually 90%. And the sensitivity of gene expert is 40%. So if you have a situation where ADA is positive, but gene expert is negative, that actually does not rule out the diagnosis of tuberculosis. If it is positive, it only confirms the diagnosis of tuberculosis in the sense that the specificity or the positive predictive value of gene expert is higher than the ADA. However, the negative predictive value of ADA is definitely much, much higher than even AFB culture. Now coming to the AFB culture, what is the sensitivity of AFB culture? The AFB culture sensitivity again varies from the center to center, depending on the expertise in the microbiology and the meticulousness with which the culture has been processed. At my center, I am fortunate enough to get a sensitivity of roughly 70% in pleural fluids also. Even for tissues, I'm getting a sensitivity of roughly 70%. So around 50 to 60% is what literature says if it is not empyema. If it is empyema, slightly higher. So most sensitive test for making a diagnosis of tuberculosis is ADA and not gene expert or AFB culture. However, the most specific ones are the AFB culture and gene expert. So with this, he was started on antitubercular treatment with based 4 drugs, which he tolerated very well. Serial chest X-ray showed improving trend. Clinically also he improved, gained weight about 4 kg. However, in June 22, he continued to have mild chest discomfort, and this is what his chest X-ray was showing. So how do we proceed for this particular patient? So we might be inclined to think that we are possibly looking at MDR or alternative diagnosis or trapped lung. So all these are possibilities. How do we proceed? So we just proceed with a diagnostic pleural trap, which actually yields frank pus. Now, what do we do now? Since we have absolute indications to drain frank pus, we proceed with putting in a 12 French pleural catheter. And this is what we get. The pleural effusion actually goes down a little bit, but it doesn't expand. The lung doesn't expand completely. So as the lung doesn't expand completely, what all options we have? So before that, moving on the diagnostic, what can be done to confirm the diagnosis? So at this point in time, I sent a gene expert to look for MDR. If resistance was not detected, So at this point in time, detection of Mycobacterium tuberculosis on GeneXpert doesn't mean that the patient has not responded to treatment again, because GeneXpert can detect the dead bacilli as well. So for diagnosis at this point in time, GeneXpert is not a valid test. The only reason for doing GeneXpert at this point was to look for rifampicin resistance. If it is there, if we can find the MTB DNA here. Then we also send the pleural fluid for bacterial culture as well as tubercular culture to be really sure that we are not dealing with secondary empyema, which I felt I am not dealing with. And of course, tubercular empyema we had to rule out. And if we could find viable bacilli, that would guide my further therapy. So with this, I resort to applying negative suction for this particular patient, which helped a little bit in expansion of the lung. However, lung could not expand completely. Aerobic culture, as expected, did not grow anything, and AFB culture is still awaited. This is over the 23rd to 26th of June 22. What do we do next? So at this point in time, the CT scan was done and the surgical opinion was sought. So this was the CT scan, which suggested trapped lung with significant volume loss on the right side, relatively benign looking or no significant pathology in the lung parenchyma. So with this, I was very reluctant to subject this particular patient for surgery because I felt that this such a small pneumothorax or a sterile cavity, even if it remains, it is not going to cause much problem to him. However, the patient being young, family wanted anatomical correction. So we had to go for surgery. Decortication was done by a surgeon. Post-operatively, this is the chest X-ray. Immediately, day one post-operative, I got a call from operation theater itself, surgeon saying that the lung is not expanding. I have done a decortication, but the lung is not expanding. I said we are not going to go for resection for him now. We'll see what happens. We'll just wait for the lung to expand slowly. Maybe it will take some time. On top of that, there was small air leak. What do? Again, we resort to going to a negative suction, which actually results into a persistent air leak. Over 2 weeks, he continued to have negative suction. What to do in this particular scenario? Lung is not expanding. It is actually worse than what it was before surgery. Air leak is there, and even despite negative suction, the lung is not coming up. So at this point, I decide to clamp ICD for 24 hours and see whether it actually worsens. It didn't worsen much, so I removed ICD. Moderate loculated pneumothorax is persistent. There was no worsening of pneumothorax on serial chest X-ray for about 2 days, and with that, we kept him under observation. No worsening over 2 weeks, kept on follow-up. At the end of 2 months of follow-up, AFB culture has grown nothing, so it is negative. Patient is asymptomatic. Antitubercular therapy is also stopped, and hoping that the cavity will heal on its own slowly. So thinking back retrospectively, when surgeon said, is the lung is not expanding, did we have any clues on the CT scan which will actually suggest that the lung is not going to expand? And this is the CT. I'll leave you with the images so that you can have a look and decide whether there were enough clues for the non-expansion of the lung in this particular case. With this, I thank you all. We are open for questions. Sir.
Thank you. Thank you, Dr. Babu Rao, for your nice presentation. Is there any question from the audience, particularly from PGTs? Yes.
Okay, I have been using it for about 7 years now. The dose which I have been using is 2.5 lakh units of streptokinase twice a day for 3 days. We usually end up using 2 vials of 1.5 million unit. 7.5 million unit was available for a very short period of time in between. Now it is not available again. So we have to use 1.5 million unit for 3 doses and then discard and use another for next 3 doses. That too, if required. If there is no residual collection and drain has completely gone down significantly, even with 3 doses, we stop at that. In between, when it was available, I used urokinase 1 lakh units once a day. for technical feasibility as well as the pharmacological advantage which we have. But again, urokinase is not available now. At present, it is not available, and 2.5 lakh unit twice a day is working wonders.
So what is your experience regarding the complication of using streptokinase or urokinase?
Other than fever, I have not faced any complications so far, sir. Only fever is the complication. Post instillation, some patients develop fever, not all. No bleeding at all. And even patients who have undergone surgery after trying fibrinolytic therapy, there was no excessive bleeding intraoperatively.
I have one question for you.
Yes, sir.
In this first case,
Mm-hmm.
you have diagnosed it to be a parapneumonic effusion.
Yes.
It was a complicated parapneumonic effusion.
Yes, sir.
My question is that when you have done a diagnostic test where you are getting an exudated ARDA, say your sugar is around 80 or 80.
90, yes, 89.
90, there is a growth of enterobacter
Yes.
in the EA. So why didn't you put the pigtail earlier?
So the patient was managed at other hospitals, sir. So the first other hospital, patient was managed at other hospital. So the patient came with ICD in situ, 2 days of ICD, still it is not draining. That time the patient came to me, and the reason for referral was possibly we are dealing with pneumothorax because they found hemorrhagic effusion coming from the tube, which I felt was likely related to ICD trauma, insertion related trauma. And after putting in streptokinase, it is not blood, it is a straw colored fluid which has come out. The second thing is that the diagnosis for that patient is actually not parapneumonic effusion. I was very skeptical of the culture itself. For the sake of time, I did not discuss that. But the diagnosis is not parapneumonic effusion. That patient's ADA I repeated at my center, and his ADA is 175 with pleural fluid LDH of 465. So the ADA to LDH to ADA ratio comes less than 4 or something. So this is going against parapneumonic effusion. It is going more in favor of tubercular. So that patient has already been started on ATT. I have sent his gene expert, and I have sent his AFB culture also. I have also repeated his bacterial culture at my lab, so that I am sure before stopping antibiotic, I have a negative culture.
So you have treated that case with anti-tubercular drug?
Yes, sir. So he has been started on antitubercular.
Second case, you have
first
started.
one also.
The
first one also
you have started.
Yes, first one also has been started on antitubercular treatment after I got an ADA of 171.
So do you think, for the sake of our audience, do you think that age-related ADA level cutoff, do you have any message for them? That how much ADA we should go according to the age? A 70-year patient having 60 ADA and then 20-year patient having 60 ADA. How does that help?
Age-related cutoffs I'm not aware of, sir. But what I have, I'm aware of is that there are 2 cutoffs which you can use. One is 40, one is 70. So the range between these 2 can be considered as a gray zone. Anything more than 70 is highly specific for diagnosis of tuberculosis, unless we have a rare circumstances where it can be falsely positive in lymphoma. So far, I can remember 4 patients who have had lymphoma diagnosis with ADA of more than 100. So that is one more point I take, wherein whenever I get an ADA of more than 100, I tend to think of lymphoma, and I try to get a biopsy for such patient to prove the diagnosis, or at least to rule out the lymphoma part of it. Less than 40 is definitely considered negative. You will have to look for alternative causes, but again, the sensitivity is 90%. 10% of the patients with tubercular pleural effusion also can have ADA less than 40.
So in that case, suppose you are having suspicion of tuberculosis,
yes, sir,
but the ADA level is say for 40. So is there a role of pleural biopsy?
Yes, sir, definitely. So either you can go for repeat ADA, like this patient, we repeated ADA. The first ADA which was done from the other lab was 12 to be precise. And when I repeated ADA after 5 days, it is 171. So repeat ADA is one if you have access to fluid. Since this patient was having tube in situ, it was easy for me to get a fluid and repeat analysis. So I resorted to that. If that was not the case, or if that was not conclusive, even if the culture was not showing anything, and if the intrapleural fibrinolytic therapy did not work well, this patient would have gone ahead with VATS And of course, we would have had biopsy at that point in time. So all this was a working diagnosis in process till we have a final microbiological or histopathological diagnosis.
So what do you think, what is the role of medical thoracoscopy in case of exudative pleural effusion, say normal ADA with gene expert negative? So
these patients should have medical thoracoscopy and pleural biopsy, especially if the ADA is negative on 2 occasions. And second time, I would repeat only if I have access to fluid easily. I possibly will not tap it once again, just for the sake of documenting it twice. So somebody with drain in C2 comes to me, I have access to fluid, I will possibly repeat pleural fluid investigations. If somebody comes with once pleural tap, which is inconclusive and comes to me, possibly will go straight away for thoracoscopy and pleural biopsy.
thank you. So in your first case regarding the use of fibrinolytic therapy.
Yes, sir.
So what is the highest dose of streptokinase? After that, you can tell that perhaps it is not working.
So we have not tried titration, sir, and none of the studies have done titration also. So what has been studied is 2.5 lakh unit twice a day, 3 times a day of streptokinase, or urokinase 1 lakh unit twice a day or once a day. So these are the doses, and TPA 10 milligram twice a day. These are the doses which have been studied. If it had to help, these usual doses help. Even there is a small observational study from India itself, from Bombay Hospital, where they have instilled 200 ml of saline and seen the response. With that also, they have found significant improvement in drainage, which is also congruent with the fact that the trials I showed you missed the control arm, almost 70-80% patients eventually improved with placebo alone. So some amount of mechanical adhesive lysis was achieved by the process of instilling some liquid there, so be it saline, be it placebo, or anything. So 200 ml of saline also under pressure or gravity. They have used gravity. They have not used positive pressure. They have used gravity just to allow the saline to go in, stay there for about half an hour, 1 hour, and then drain it. So that way also they have found that it helped. So mechanical adhesiolysis with saline basically.
Okay. Thank you, Dr. Babu Rao, for your nice presentations.
Yes, sir. Yes, sir, please.
In your second patient, the amount of the pneumothorax increased after the surgery.
Yes, sir.
Don't you think that while doing the decortication, probably surgeon has peeled off part of the lung? That was the cause for that.
Actually not, sir. That is why I have kept the CT scan open here. I did not go to the next slide, which was this. So the reason why I have kept the CT scan here is, if you look very carefully, this whatever appears to be a thickened pleura is not actually a thickened pleura. There is a thin rim of thickened pleura, and below that there is atelectatic collapsed lung, which is very rubbery. So even after removing the pleura, the surgeon said that the lung appears very, very rubbery to me, and it is less likely to expand. So that is why I said, retrospectively going back, do we have any clues that this lung may actually not expand? So this is the clue. If we look this portion, this is not thickened pleura. This is actually the part of lung parenchyma which is there. This is actually the part of lung parenchyma, and this is thickened pleura only. So the lung area or the parenchyma which is just immediately subpleural is actually sort of become thick rubber, which is not allowing the rest of the lung to expand. Possibly for this lung to expand, it will require wedge resection or something.
There should be no air leak then.
Air leak was in an attempt to try and drain that. So even if you look at the first chest X-ray, sir, after putting in a drain, here, even here we have air. This air is actually a pneumothorax ex vacuo and not the air which is coming from inside. And even at this point in time, when I had put him on negative suction, he still had some air leak on negative suction.
Regarding the first case, whenever we see unusual pathogen in the culture, unless patient has a history of hospitalization,
yes, sir.
Past, you should not believe that also.
Yes, sir. Yes, sir. So, and the sensitivity pattern was frightening. Enterobacter coming from pleura, sensitive only to colistin and polymyxin, and with pleural fluid sugar of 90. The things were not fitting in place. So the culture, in the emergency department itself, when I had seen the patient, I said, I don't believe this culture, but I would send a repeat culture and continue same antibiotic just to cover for the pathogen as per sensitivity.
Thank you. Thank you once again.
Yes. Yes. Yes.
बच्चे जो ये सोचते हैं ना कि माँ बाप जिद कर रहे हैं, वो एक्चुअली माँ बाप कंसर्न है, इसलिए उनके पीछे पड़ते हैं, इसलिए ऊपर एक ही बात बार-बार बोलते रहते हैं।
There is something called LDH to ADA ratio. If you have a LDH to ADA ratio more than 16, that favors empyema. If you have a LDH to ADA ratio which is less than 8, that favors tubercular empyema. So this ratio was less than 4. That is going, and for that reason we have already sent bacterial culture, we have sent tuberculosis culture, we have sent gene expert.
Okay, thank you. So, after the first session, nice presentation by Dr. Burao on pleural disease. Our next speaker is Dr. Saurabh Maji. He is MBBS DTTC and MD-DM from PGI Chandigarh. He is a dynamic pulmonologist trained in Premier Medical Institute in PGI Chandigarh. General specialization is managing complex asthma, lung cancer patient. Also specializes in the field of EPUS, thoracoscopy, bronchoscopy, and CPET. He has several publications in national and international journal. Currently, he is associated with Anand Tagore Hospital, Kolkata, and he is a very young, well-known face in the Department of Pulmonology in Kolkata. So, please.
Thank you, sir, for your nice introduction. Good afternoon, everybody. Now, I am presenting an unusual case of the proliferation. I have seen this patient this is the old patient. I have seen this patient in 2020. And she is suffering from 2018. From 2018, I will describe all his history and the event, whatever I have collected from history and radiology. And in between, I have some question for the resident. If the residents can actively participate, then it is very easy for me to continue. So this is my patient of 26-year female software engineer. No previous comorbidity. He is non-diabetic, non-hypertensive, non-smoker. For his routine evaluation, he was found to have the right-sided pneumothorax on regular health checkup. And initially, it was thought to be primary spontaneous pneumothorax as he was young and he has no comorbidity, no lung disease. And treated conservatively, there is no response. Then ICDD was given. This is the 2 X-ray in February 2018 and in March 2018. It is clear that there is a pneumothorax present in both the X-ray, that is right-sided moderate pneumothorax is present. This is the CT scan done on that time, which shows the right-sided pneumothorax. And my question to the resident. That is the diagnosis of pneumothorax. It is easy. And in the ventilated patient, what are the diagnostic method for the diagnosis of pneumothorax? Residents? Huh? Actual residents. And so I will proceed whatever I have seen.
There are some residents in the back of the. Yeah.
So the negative suction was applied at that time. There was a persistent yard leak. The VATS was done, and at that time the biopsy was done also. The biopsy report was suggestive of granulomatous inflammation, and she was put on ATD. There was ATD-induced hepatitis, and stopped ATD only after 14 or 15 days, and there was a good radiological response. This is the post-VATS, the radiology, which is lung expanded and ICDD in situ. And thus, as there was a ATD-induced hepatitis, the diagnosis was in dilemma, and patient has purely asymptomatic only pneumothorax on his routine checkup. So slide and blocked was reviewed in different lab, and it was showed that granulomatous inflammation, possibility of microbacterial infection was to be considered, but she refused to take ATD, and herself was followed up in a local physician, and she was doing fine, except some pain in the right side. This is the CT scan of the November 2018, which shows some fibrosis in the right, some pleural thickening in the right side. And this is the X-ray of 2019, which shows the lung is normal and there is no evidence of the pneumothorax and no fibrosis was needed in the pleural thickening was noted in the X-ray. So in January 2020, he presented with right-sided heaviness of the chest and the mild cough. There is no fever, no expectoration, no other constitutional symptom. X-ray showed right side proliferation, which I will show in my next slide. And he was reviewed by different doctors, and there is the opinion as the biopsy was, previous biopsy showed that the granulomatous inflammation. So opinion of the risk to restart ATD, but he was very much relaxed. He was very much reluctant to restart ATD again. She went to Bangalore and she was advised to either open biopsy or batch biopsy again. So after that, I have seen the patient and she came to my OPD. On examination, the patient is well preserved. There is mild cough, no shortness of breath, no constitutional symptom, the right-sided mild volume loss and dull note on percussion, no other organomegaly noted. This is the X-ray. What in the January 2020, that is right-sided pleural effusion or horizontal fluid level was noted. This is the, I asked her to give me the, if there is any old X-rays available or not. In the 2019 May or 2019 June, there is 2 X-ray was present and it shows the right-sided mild pleural effusion in the both the X-rays. So after the X-ray, we have done the pleural fluid aspiration, which is hemorrhagic in nature. The cell count was around 2000. It was, neutrophil was 55% and macrophage was 15%. It is exudative by protein criteria and ADA was low. There is no malignant cell was seen. This is the CT, which shows the right-sided pleural effusion, and in the parenchymal opacity, the left lung is more or less normal. So now what is the differential diagnosis and what to do next? Next, I have done the medical thoracoscopy and the biopsy done under the sedation. The pleura was very dull looking and there is adhesion noted, and biopsy was taken as much as possible, and the adhesive was done in my flexible thoracoscope. I have not the rigid thoracoscope. ICDD was placed and patient was discharged on the next day with ICDD and C2 and with proper ICDD care. So this is the post thoracoscopy X-ray. That is the ICDD in situ and lung has expanded. This is the biopsy report, that the evidence of the chronic inflammation, hemosiderin-laden macrophage, no granuloma and no malignancy. So after this biopsy, there is no conclusive diagnosis. Now what next? 2 to 3 days after, patient called me that at the evening, the patient presented at the emergency with the fresh blood coming through the ICDD, and there is a air leak also there, but there is no shortness of breath, no other bleeding manifestation. She has started menstruation 2 or 3 days prior to this event, and she was managed that time with conservatively. So this changed my clinical diagnosis again to rethink whether there is, because in the biopsy report there was a hemosiderin-laden macrophage and this is the fresh bleeding was noted. So I give this information to my pathologist, discussed, and he was asked for the old slide, old block and everything. We are lucky enough that we got the old block and the old slide also. We reviewed that, and this is the histopathology report, histopathology slide. That is that there is some, if I use the cursor, there is some abnormal tissue in this area. And there is some hemosiderin-laden macrophage is noted. This is the abnormal tissue area. It is a pleura. This is the abnormal tissue, and this is the hemosiderin-laden macrophage was noted, which shows CD8 positive, which is the marker of the endometrial stromal nuclear positivity, that is the CD10 positive. And these all are that area, that the abnormal tissue area is the ER positive, that is the estrogen receptor positive. And this is also the progesterone receptor, is this abnormal area is the nuclear positivity of the progesterone receptor also. So with this positive report, we have come to the diagnosis that it is the pleural endometriosis, probably it is the catamenial pneumothorax and it is the catamenial hemothorax. So after a few days, the repeat chest X-ray shows the lung expanded and the no air leak in the ICDD, and drain was less than 50 ml per day. After waiting for the few days, the fluoridation is done with the povidone and the ICDD was removed. Patient was referred to the gynecologist, and she had the pelvic endometriosis also, which was treated with the hormonal suppression therapy. After 1.5 years, she has conceived with IVF and give birth till girl child with cesarean section with no other complication. So this is the post-fluorescence X-ray, that is the September 2020 and the December 2020. That is the some fibrous band as noted, otherwise lung has expanded. Now come to the some literature review. That is it is the presence of endometrial like gland and the stroma outside the uterine cavity. It affects around 6 to 10% in the reproductive age group women, and 12% is estimated to experience the endometriosis in a non-reproductive organ. The most common site outside the pelvic cavity is the thoracic cavity. It can may be present in the lung parenchyma, on the diaphragm, on the pleural surface, and produce the variety of the symptom in the different site. Come to the pathophysiology, there are theories which are available. That is the retrograde menstrual theory, that is the coelomic metaplasia theory, that is the lymphatic and the hematogenous dissemination, and that is the prostaglandin theory. This is the 4th theory which are present. Sign and symptom mainly depend on the location. If it is endobronchial location, then present with the catamenial hemoptysis. If it is some present with the pleural nodule, many patients are asymptomatic. There is experience of constellation of the temporal symptom with the radiologic finding with the menstruation. And catamenial pneumothorax is the most common, that is present in around 80% of patient, and hemothorax is 14% of patient, and the hemoptysis is around 5% of the patient. So the diagnosis, as there is a variable presentation, so we have high level of the clinical suspicion of endometriosis, and the diagnostic modality depend on the whether the clinical presentation and the site of the involvement. Chest X-ray and the CT thorax for the pneumothorax for pleural effusion and MRI for the diaphragmatic involvement is needed. Some atypical presentation are the pneumomediastinum, pneumoperitoneum, ground glass opacity, bronchial wall thickening, thin walled cavity within the lung parenchyma, and the bullous formation. So for the diagnosis, the gold standard is the video laparoscopy or the video assisted thoracic surgery, that is the VATS. Interpretive finding are that is the diaphragmatic involvement in 38% of patients in this study, and the visceral pleural involvement is around 1/3 of the patient, and discrete lesion in the such as bulla, bleb, or scarring noted in the very few patients, and the imaging and the tissue sampling as some inconsistent result. That is the sometime in the as my patient, I have no clue in my thoracoscopy finding that the pleura is looking dull, no bleeding spot noted. But the diagnosis can be improved if the timing of the thoracoscopy or timing of the biopsy is done. It is the mid-cycle or versus the menstrual at the time of the menstruation. If we do the diagnosis or biopsy at the time of menstruation, then the diagnostic yield is increased. So come to the management. This is the medical management is the first line of treatment. Our goal to suppress the ovarian steroid hormone production, that is the GnRH analog as used for the first line. For the surgical treatment of the thoracic endometriosis, the laser, cryo, or diathermy can be used. And for the recurrence, we can use the chemical fluorisis. This is my patient, his husband, she, and his child. Thank you.
Thank you, Dr. Saurav, for a nice presentation of reproductive age group patient presenting with catamenial pneumothorax with hemothorax. Any questions from our audience? Can I ask you one thing? Regarding the recurrent pneumothorax, do you think the right-sided pneumothorax is more common than the left side, or it is equal the same, one side followed by the other, like lamb, what you are getting?
No, in case of the catamenial pneumothorax, the right side pneumothorax is more common. Right side pneumothorax is around 80%. Left side is around 10%, or bilateral is around 5%.
5%. And same site is recurrent.
Same site is recurrent. But if in the reproductive age group, it has now the suspicion is more. If the recurrent pneumothorax in the same site is the reproductive age group, then we have to suspect the catamenial pneumothorax whether present or not.
So nice case, Dr. Saurabh. So, and it was fortunate that patient himself, patient herself had not taken the ADD.
Yes.
Yes. And Dr. Maji, my question is, what is the right time of doing the biopsy in the suspected case of catamenial pneumothorax or pneumothorax?
Sir, it is, I have not such experience, but whatever literature I have seen, that is the biopsy yield is different, yield is increased if we do the biopsy in the mid-cycle, in the time of the menstruation than the mid-cycle. It increases because at the time of the bleeding, we can identify the bleeding spot or we can identify the spot which is abnormal. But the mid-cycle probably will get nothing.
In how many percentage of cases do you think that the endometriosis is present in presence of extra pelvic, other than the primary site? When you are diagnosing a catamenial pneumothorax, you are getting an endometrial tissue over there.
The
How many
diagnosis
percentage have primary in the uterus? It is abnormal tissue which grows there. So does they have simultaneously endometriosis?
The patient have the patient has the endometriosis prior to that. They have 5 to 7 year history of the endometriosis in the pelvis. Then after 5 to 7 years, it grow in the other organ, extra pelvic organ. Because they all have the pelvic endometriosis. Without pelvic endometriosis, we can't consider that is the endometriosis in the other organ. And it is the 5 to 7 years, it will take time to detect in the other organ.
But in your case, there is no gynecological history.
She has recently married. Because she had recently married and my patient was actually traveling to UK. And for the UK visa, they have did the X-ray. His husband and wife. That's why they have for the decide to settle in the UK, and they came to know that there's a pneumothorax, and after that they are going here and there.
No gynecological history.
No gynecological history. No, it is not menorrhagia. It is painful menstruation was there. Only dysmenorrhea was there.
Dysmenorrhea is there.
But no evaluation was done for the endometriosis. When the endometriosis was detected in the thoracic cavity, after that, I sent the patient to the gynecologist and found that it was the pelvic endometriosis also there.
Then it was detected.
It was detected.
Okay.
Thank you very much.
Okay, sir.
Thank you, Dr. Saurabh and Dr. Enge, for your nice. So the session is closed.
Good afternoon. We'll be soon starting our workshop. This is on preparing for final PG examination, oral and practical, with dummy examination. So this is going to be a very interesting session. We have divided this session into few parts. At the onset, there will be 4 small talks regarding 4 different examinations, the types of examination, the modes of preparation, and it will also take care of the expectations from a candidate at the examination hall. You'll be listening to 4 experts on different examinations, including MD, DNB, MRCP, and all for USMLE. So that is the first part. After that, in the second part, there is a valuable lecture for all the postgraduate students. It is on why the students flaw and how do they make flaws in examination. And this will be taken care by a very renowned, experienced professor of ours, Professor Arup Kumar Kundu. Following that, there will be dummy examinations. I told in the morning that we'll try to replicate an examination hall out here. We have got 2 cases, and these 2 cases will be presented by SSKM Hospital. The candidate will show the examination of the approach to the patients as he goes and approaches the patient. Approach means that, and followed by clinical examination. After that, the candidate will be open to be questioned by a fleet of experts, the examiners in the hall, and it will be a real examination. The candidate is not aware of the case possibly, and related investigations will also be discussed in the course of question-answer format of discussion. This will be followed by the examiners themselves speaking between them regarding the performance of the candidate, which is usually done in an examination, true examination. And the examinee never come to know what the examiners are thinking about the examinee. So this will be the unique part, that examinee will be able to understand what is the mind of the examiners. And this part is really kept unknown to us. So after that, this session will be moderated by Professor M.L. Gupta. And after there will be much carry home message in that. And after that, there will be OSCE session, which will be taken care by Professor Radha Munje and Dr. Animesh Roy. And following that, there will be oral practical, oral table. In the oral table, we'll project certain instruments, certain problems, a drug, maybe something else. And all the postgraduates here are to answer. So this is a composite program of today's workshop. And this will go for as long as it is possible, as long as you can withstand, and as long as our examiners can maintain that. In between, there will be a break for a high tea, because I understand keeping attention for a long time is nearly impossible. So with this small note, may I request my people to start projecting the talks or inviting people on dais to give their talks. We have got Dr. Subhashish Ghosh, who couldn't come today. He has sent his talk. He is supposed to talk on MRCP examination. So are you ready? Oh, there is, sorry, I missed. There will be 5 spot cases. Those have been carried by Dr. Kundu. And I'm looking forward to find a chance to see it and listen to, because this is an opportunity for me also. Although I may not have to appear in examination, but this is really interesting. I wondered if I could be an examinee by now, it could have been wonderful for me. What? Huh? No. So this is a preparation for a DNB examination. I invite Professor M.L. Gupta. Mr. Gupta doesn't require any introduction here. He happened to be my senior at PGI. He's a professor, retired professor from Shivaji Mansingh Medical College, Jaipur. And presently he's working as a consultant in a big corporate hospital in Jaipur. He's a wonderful teacher and he's my guide all along. Sir, would you please take?
Can I request those sitting on the last two rows can come forward? Come forward, seats are made. No, don't want to come, no problem. The different constitutions of the DNB examinations are 2 formative assessments, 1 thesis, 4 theory papers, and practical examinations that include long, short case, OSP, and viva others. That formative assessments are to identify the weaknesses of the student during training and to take the corrective measures if needed. First, I will start with the thesis topic selection. That is very important because a lot of time is wasted in that. So I will just give few thesis topics. Just decide which you will like to prefer. One is the prevalence and predictors of the primary rifampicin resistance among the newly diagnosed pulmonary tuberculosis patients. Second, comparison of the treatment outcome on daily HERZ or given for the 6 and 12 months duration in patient with primary sinus resistance. Third is the comparison of yield and safety of blind versus ultrasound guided pleural biopsy in undiagnosed pleural effusion. And last is the comparison of the demographic, clinical, radiographic, and functional parameters among the smoker and non-smoker COPD. Any guess, any idea, any preference? You see the first thesis topic, prevalence of primary drug resistance is hardly 3% in the newly diagnosed patients. So you should have at least 100 patients to pick 3 patients. And if you want to know the predictors, your sample size be very big. So the first topic requires a big sample size and that may not be possible in your training period. The second is the comparison of the 2 treatment outcome. And the follow-up should be for the 12 months. So after your last case, you have to follow the patient for the 12 months. So it's a longitudinal study. Again, the time factor may create a problem for your completion of the timely thesis. Third is the blind and ultrasound guided pleural biopsy. There's an extra cost is involved. Organization will not help you. Ethical committee will not allow you to give an extra cost to the patient for any thesis purpose. Last topic, comparison of the demographic, clinical, radiographic, functional parameters. No extra cost is required. It is in cross-sectional study. You do not need an extra study. So try to select such a topic which can be performed easily without much problems. So while in selecting the thesis topic, try to avoid any study which requires extra cost or investigation because that will not be feasible due to limited resources. Longitudinal follow-up studies you should avoid because otherwise your submission of the thesis will come, the date will come and you won't be able to complete the things. And you also see whether the available sample size is possible in my institution or not. That is very important. We take the study and then we found that no number of the cases are not there, then you are in a problem. So before selection of a thesis, you should take care of all these points. Second, how to prepare theory. In DNB, I don't know how many of you are in DNB students. There are short questions are there and they are to the particular aspect of a situation like the management of this thing, diagnostic flaws on this problem. So you have to read very exhaustively each and every corner of your textbook. So you should try to read regularly. So what I suggest you that whenever you see a patient with a particular disease, in your OPD or in the IPD, try to read for that particular patient on that particular day only. With that, what will happen that next day on the round with your consultant, like that. You have a patient with a PE, that particular night you read all things about the PE, whatever is possible in the textbook. So next day in the rounds, probably you will be the most wise and knowledgeable person amongst your colleagues. It will add to the management of that particular patient also. And study like this, case-based study, whatever patient has been admitted and you read about that, the study like this will last longer in your brain also. Lastly, you can make a peer group in your department only, among your colleague only. Just select some topic on the daily or a weekly basis. You just read and discuss among others. By this also, probably the things will last longer. And how to master about the chest radiology. Chest radiology is very important for the chest physicians. We have an history, we have clinical findings with us, and a reasonable knowledge about the radiology probably can make us equally wise at par with the radiologist. I agree, a thorough and complete reading of the radiology books is not possible because of the time constraint, but at least you can do that. You just read all the X-rays and CT images and MRI images from the books and read the ligands below that. With that also, you will get a reasonable knowledge about the radiology. You just read X-rays, you read CT scans, and just read the ligands below that. If you are not able to read exhaustively all the text from the textbooks, that will also give enough information, enough knowledge about the chest radiology. And before that, whenever you join your post-graduation, I will just suggest that whatever we read in the first year of our MBBS course, Cunningham Anatomy Dissector, you try to read that. That will be very interesting. If you have read that at that particular time, probably you will able to interpret the CT scan and MRI in a better way. You will be more familiar with the different anatomical structures. How one can answer in the theory papers, that is very important, because unless you clear the theory, you won't able to appear in the practicals. Time management should be there, because you have 10 questions, sometimes 10 questions have A and B part, so you may have 20 questions. Read the questions carefully before you answer that. I will just give you an example. In MBBS, in one batch senior to me, there was a question, how will you treat a patient with febrile conversion in an 18 years old child? And only few people write 18 years child do not have febrile conversion. They also got the same number. Well, those who wrote exhaustively wrote 3 pages, they also get small, they got smaller numbers. Whether it was a misprint or it was an intentional, I don't know, but it was like that. So always read the question, this one. About the chronology of the answer, I don't know that how to the extent it is correct, but what I feel that this is a practice among us, that what we know the best, we answer first, then what we know little bit less, we answer, and then poorly known or poorly knowledgeable question, we ask the answer in the last. Examiner also had this idea, so is answering number to questions becomes also in the descending orders. So just confuse the examiner also. You don't answer like this. You answer in the hybrid manner. Best question, then some average, then above average, then best, then above average. So that the interest of the examiner in reading your answers will be there, and probably you will get a better answer, better numbers. This is my feeling, may not be true, but try one time, probably it will work. And one more thing, that you do not answer in like in essay type answers. You try to answer in the form of the algorithm, flow diagram, or in the table form, whenever there is a possibles. This will save your time and examiner time also in reading the question, and it will give a better impact about your understanding. I will just give an example. There is a question about the bronchial thermoplasty. Just give 2 lines. What is the bronchothermoplasty? What are the patient selection criteria? Pre-procedural considerations, something about equipment, something about technique, post-procedural care, and point to the success, like that. Just write in the form of the points. Probably you will score better than if you write in the continuous text form. Viva. Answer should be to the point. You may request the examiner to repeat the question if you have not understood the question clearly. The answer should be in the structured manner. I will give you an example. Suppose the examiner asks in the Viva that how will you manage a case of malignant pleural effusion. Don't start with a story. Just answer it like that. Sir, the management of the malignant effusion depend upon how much patient is symptomatic, whether there is an endobronchial obstruction present or not, what is the underlying etiology of that, and what is the expected survival. Depending upon these factors, we have different options are there. Probably before you will complete like this, he will say, okay, leave it. But meaning by it will give a good impression that you know the answer, you know the chronology of the events. If you do not know the answer to a question, better to say sorry and go to the next question. Don't try to answer in haphazard manner, because this way you will waste the time, and whatever the question you might be knowing, probably that question will not come to you. Answer to a question, when we are talking about the bedside, the question's answer should be relevant to that particular question. Suppose the same question, how will you treat the malignant pleural effusion in a patient with small cell lung cancer? Then there's no need to repeat such a story. You know what is the treatment option for the malignant pleural effusion in the patient with small cell lung carcinoma? Straightforward tells us it is a systemic chemotherapy which will take care. That's all. There's no need to tell everything like we have discussed in the earlier question. And last, don't argue with the examiner even if you are correct. Not necessarily that examiner is correct all the time. He may be wrong sometimes. Just say, sorry, sir, I remember like this. I will check it again. And there are few suggestions for the faculty also, that give a small bunch of the questions, the different aspect of the disease, physiology, or recent advances on the monthly basis to the students. Ask them to prepare at home and bring the answers. Be friendly, but always keep some distance. Invite visiting faculty to your department for the war rounds or case presentation at regular interval. And lastly, encourage residents to participate in local and national conferences like this. And lastly, before I complete this presentation, Karm Karo, Phal ki Chinta Mat Karo from Gita. Put in your best, your hard work and perseverance will help you to succeed. Examination are the part of the assessment, but whatever you have studied, what you have learned, shall reward you throughout your life or a career. Thank you. Who will be the next?
Good afternoon, everybody. So examination of MD. This is my topic. I have 4 minutes. Now, written paper, there are 4 papers as per in Kolkata University. First paper is on basic science. Second paper, non-tubercular lung diseases. Third paper, tuberculosis and other mycobacterial infection. Fourth paper, recent advances and epidemiology. You have 100 marks and you have 90 minutes time. But please note it that examiner has 1 hour time to look for all the theory papers. And so you do not write the descriptive essay type, main points to be highlighted, clinical significance to be mentioned, use diagram and use flow chart so that examiner find you your answer and give you appropriate marks. Practical and oral examination, within these you will get about 1 hour time, and within that you have to produce your 3 years struggle. You want to express your depth of knowledge. What is the difference generation gap you can call? You want to express your depth of knowledge, but what examiner want from you? They want from you your basic knowledge, analytic power, and whether you are eligible to be a specialist. This is very important. What examiner want from you? Examiner will assay your knowledge, attitude, practice. Be well dressed, alert, sober, polite, and confident. Be reasonable. Do not be stubborn, arguing, or arrogant. You may not be fluent in a foreign language, but your idea should be fluent. Do not try to bypass any question. If you do not know the answer, please tell that I do not know it. Utilize the clue given by the co-examiners. So long case. Tomorrow morning, I will discuss long case, so I will not go in detail, but I can recall my examination date when I was given a case, younger age group, non-smoker, biofuel exposure, COPD patient. I diagnosed that case and established my diagnosis, but examiner was not satisfied. I answered all the questions, yet not. After that, he asked me, what is knuckle sign? I told I do not know. Then he was satisfied. It is very important that examiner has some ego. Examiner expect you to know everything from old to new, but they want you to know less than him. So examiner ego must be satisfied. Short cases, there are 2 short cases, and you will get 15 into 2 minutes. It is general survey and examination of the respiratory system, sometimes lymphoreticular system, and the crossing will be on your findings. So your finding must be true, whether you can explain it or not. You cannot have a misdiagnosis or something. Your finding must be right. Then there is X-ray, and X-ray usually not known because examiner will carry X-rays from rare X-rays, and most of them indicates a specific diagnosis. If you cannot diagnose it, start with descriptions. Instrument and chart, they are usually known and they are easy to answer. And frank oral, that depends on your previous answer. If examiner want to give you some marks, then they will ask you some difficult questions, and that depends on them. But one thing I want to highlight, that your pass marks is 50% and honors marks is 75%. If you cannot answer the basic questions, and you can answer most of you for the honors questions, then we will get 75 minus 50, that is 25, and we will definitely fail. Thank you.
So we have changed the schedule a little. There are other 2 small talks, one for USMLE, another for the MRCP, which we'll do later. But I will straight away request Professor Arup Kumar Kundu to present his experience as a teacher, where the students flaw in the examination. Arup, please.
Good afternoon, students. I was just calculating after getting the invitation from Partho, probably have taken 276 examinations all over India, except Jammu Kashmir. I know the pulse of the students. I know which students is going to pass and which student is going to fail. Students assess the examiners, and examiners is on the better side of the table. If they say you are an ass, you will tell I am an ass with four-legged ass. So you must know what the examiner wants. I am just repeating for 1 to 2 minutes what my previous speakers has told. It is to be followed in MD, MSCP, MBBS, DNB, everywhere. Be smart and polite and courteous in your gesture. Don't rush. A lot of physical and mental stress is responsible for your underperformance. Believe me, not your lack of knowledge. It is your mental stress that I am not going to pass. You should look confident, not overconfident. Never show overconfidence. Be precise. Don't talk nonsense in the hall. Just correct yourself. Listen the question carefully and answer to the point. Speak out slowly in a clear voice. Don't try to be clever. Don't go over the examiners. This is the tendency of few students. I am the first boy of the class. So what they will ask me? Yes, they have got something in their pocket to fail you for 10 years next. Be methodical. Mostly the errors made by making cursory and incomplete physical examination than due to lack of knowledge. Due to cursory examination, I know how to palpate the spleen. That's why I have done the examination of spleen within 1 second and asked my sir that I have completed my examination. And your examiner is observing you from the oral table. He is just by the side, just 2 feet away from the long case. While examining, you should have a fine and gentle eye and show respect to your patient and your examiners. Not too much respect, but respect should be shown. Just the next slide. It's not going. You come here. I'm not carrying it. Yes. No. Wait, this one. You may know everything. I told you, you got honors in physiology, anatomy, chemistry. So you think you will pass in medicine and pulmonology, MD and MSc. It's not like that. I had a friend. He took 9 times to pass MD medicine. One of my friend is giving his examination of entrance examination still now. Just believe it. It is so difficult. Now, so prepare. You may not know everything, so prepare for the unexpected. Unexpected, because it is for the students, not for the teachers, not for the senior doctors. Because your examination hall, many a time become nostalgic. It is the firing squad, and your examiner's face is the 7th cause of mask faces. He never laughs. He never laughs. It is the 7th cause, I think. Now, don't be panic. Never argue with your examiner, what Dr. Gupta has told. Don't interrupt him. Let him complete his sentences. Don't be biased. Try to be alert and focused. Try to answer in order of frequency. This is a really sine qua non type. Try to give the answers in order of frequency. Means from common to rarer cause. What is the commonest cause of pneumonia? You told it is COVID. You will never pass. You will never pass. So common to rarer cases. Remember, the difference between success and failure is marginal. You got 50 out of 100. I got 49. I have failed only by 1 mark. So the difference is marginal. Remember it, then you enter in the hall. Remember, your examiner is not your enemy. He always tries to help you. This is my belief. Everywhere I have seen all the examiners try to help you. Your lack of knowledge and lack of practice is your enemy. The tips and the loopholes. What I have seen. Tips during presentation: practice and more practice. Present case in the hostel, in the canteen, in the bedside, in the corridor, in the roof of the hostel, anywhere. Try to present a case to a friend. Look into the examiner's eye. Eye contact is very important in the examination. Don't look repeatedly at the patient while answering. Suppose you are in a long case or short case and your examiner is asking you some question, you are just looking at the patient. Don't do so. Try to have an eye contact with your examiner. Look confident even though you do not know anything. You must be look confident because the only motto you have to pass in the exam. In the long cases for the postgraduate examination, I think they miss it commonly, the comorbidities. There is a chance to ask the patients what is the disease you are suffering from, what is the complaint. So common comorbidities, we all know: hypertension, coronary heart disease, diabetes, dyslipidemia. Obesity is a comorbidity. You must write it down. Hypothyroidism, one of the commonest comorbidity. Psychiatric disorder means anxiety or depression, the common two. And the early Parkinsonism. Recently, I took one DNB examination. One student missed the early Parkinsonism. I could not make him pass in the long case. Believe me, because it is a license to kill. If you get the license, you are allowed to practice in the community. So examiner is always on the better side of the table. While giving a patient of cirrhosis of liver, patient has got tremor. All the tremors are not flapping tremor. You have to judge it. This is your long case. I'm not going into details. If your examiner says in short case, look at the patient and do the relevant examination. What is relevance? It is your judgment. It is your corpus callosum. It is the function of hippocampus. So if a patient is having respiratory distress in pulmonology in the long case, and your examiner have asked you, just go through 3 common general survey, you must see for decubitus of the patient. Remember, decubitus is #1 in pulmonology. Number 2 is you have to see in a dyspneic patient cyanosis, because examiner is looking keenly while you are examining. The sequence of examination. During examination, do as fast, as complete as possible. Because after you, there are so many candidates, they have to complete it. Good examiner will guide you through the exam. Because according to my experience, majority of examiners want you to pass through. Nobody wants you to fail. Nobody wants you to fail. Believe me, nobody wants you to fail. It is only the idiots who do some silly mistakes, they fail. It is not due to lack of knowledge, never due to lack of knowledge. It is the cursory examination. I'm not going into it. There is a 1-hour class of OSCE. Now in the DNB section, this has been added for last 2 years. It is a deadly thing. I warn you, it is a deadly thing. Just in the last examination, I have seen, I was just by the side of the students in the OSCE examination was going for 2 hours. There are some questions and immediately questions are dispatched by the computer to the Delhi, the central DNB office. One of the question was a picture of just the real scenario was spider nevi. Everybody has written it is telangiectasia. Then the next question, they were right. What are the common differential diagnoses? Common differential diagnosis. Somebody has written something 1, 2, or 3. Common write down 3 differential diagnoses. I have seen at least 10 boys have written 8 or 7 differential diagnoses. If they have asked 3 differential diagnoses, you are not allowed to write 10. What the examiners do, just listen to me. There is an instruction comes to the examiner. They cut down the last 7 or the first 7. Now you are at a fuss. You do not know what is there. There are common 3 you must write. You are not allowed to write more than 3, what they are asking. So this is a common mistake in OSCE. And in the OSCE class, one of your teacher will describe it. Remember, for the DNB examination, you must take some OSCE special classes. It is something different. It is something different. Some tough questions are coming. There are some clinical correlations are related. And all the investigations they give it. All the parts of internal medicine and pulmonology. No part is exempted in OSCE. because it is very difficult. I tell you, because there are some courses of OSCE is going on. If you go through internet, all the South Indian and Western part of India students, all are within this course, 20,000 rupees in 1 month. I have seen this and everybody is asking me. So go through the classes because practice makes a man perfect. Your viva table, your first impression is the best impression. আগেকার দিনে লোকে দাড়ি কেটে আসতো না, আমাদের সময় দাড়ি থাকতো, মাস্টারমশাই জিজ্ঞাসা করতেন দাড়ি কাটার সময় পাওনি? না স্যার, এত কষ্ট, এত পড়াশোনা। Days have been changed. You must have a clean shave. The male persons, you must have a clean shave. Be alert about your own appearance, your dress, because the first impression is the best impression. Avoid casual attitude. Maintain etiquettes in the examination hall. I can remember one of the boy, I was then the conductor. Now 1994, I can remember one boy was chewing pan masala. I'll never forget. One of the teacher from Assam told me, kick out that boy, kick out that boy. I went to the boy and see he pleasantly chewing the pan masala. What I did, I gave him a slap. This slap made him rescued. The examiner told me, why are you beating him? Tell him to come here and sit down and clean the mouth. So don't chew anything in the exam hall. This is a common mistake, chewing gum. And some students take their parents as if they are standing with coconut water. Never take your parents in the exam hall. If the examiners see, like me, it is a danger is waiting for you. Wear a clean apron. Apron must be clean, with roll number mentioned by paper or something. Switch off your mobile phone, the dangerous part. Better to keep it outside. If they allow it, switch off. In DNB examination, nothing is allowed except your undergarments and pant and shirt. Now, it is better to say, I think, I do not know is a bad term. I cannot recollect it is a better term. Because I am a learned man. I knew everything all over the world. I cannot recollect, sir. I am not sure. This is another better term. Than to know, than to tell, I do not know. Two good terms are good morning, good evening, sorry. Sorry is a beautiful term. Anywhere you can apply it. So apply the term sorry when you are at a fault. Be humble and courteous. Most examiners, this is the last part, is very important. Ignore your minor mistakes. They don't take care of it. They want to make you pass. Answering simple questions usually gives you guarantee of passing. Answering simple questions. Your examiner is on the better side of the table. I am telling you, he is always on the better side of the table. You are an under person. So don't be biased, don't guess, and don't try to cheat him. Small but important regarding examiners. They are coming from different states, whether MD. Believe me, in MRCP examination, when MacLeod in 1968 was taking the examination of MRCP, the students in UK tried to go to his home. How many wives he have got? The personal queries in disguise. It is not a criminal offense. You must know everything about your examiner if the opportunity is there. Nobody will do it anything harm to you. But churi bidya, boro bidya, chup kore korte hai. From different states, they are coming from different regions with different depth of knowledge. Somebody is very sincere about clinics, somebody about theory, somebody about etiquettes, the hall management, etc. Try to know the bias of your teachers. Within 10 minutes, you see the examiner taking examination of your friends. And you can know that he's a man from endocrinology. He's a bias on hypothyroid, asking everybody about myxedema. So try to do it. It is not a criminal offense. The dress code is very important, especially when I teach the civil service examination. Their dress code is dangerous. Your dress code is a bit mild. It differs from winter to summer. So should be decent, formal pants and shirts for boys, half sleeve in summer and full sleeve in winter, because this is usually accepted. And churidar kameez or sharis for girls. Don't go through the third part. These two are very important. Closed toe footwear. Don't wear choti. Closed toe footwear. No perfume. Avoid jeans. A clean shave. And ponytail or tie the hairs. Recently, I saw one lady was giving his examination. I asked him, to percuss the abdomen. How she will percuss is lots of hair is over the abdomen of the patient. So how many times he will do it? And I left the place. She did not know I have left the place. So lady candidate must tie their hairs. Time management is very important. Especially there will be a targeted focus for OSCE. OSCE, every question, your teacher will tell you 4 minutes. You will not get a single minute extra because the screen will be off. So time is important in long case, short case, spot case. I'll show you for 5 minutes, after a few minutes, 5 spot case, how it is taken. Now, preparation. Medicine means pulmonology or medical science because medicine forms the platform on which other subjects dance. I believe that gynae is the commerce, surgery is the arts, and medicine is the science. And that's why I told once that gynae is the work of 2 fingers. My teacher, शिक्षक আমাকে খুব বকেছিলেন, it is the work of 2 fingers. Sir, क्या करते हैं आप लोग? सर्जन लोग 2 हाथ से काम करते हैं, मेडिसिन का आदमी 2 हेमिस्फीयर से काम करता है. This makes the difference. Medicine can never be managed. Try to cook whatever there in your kitchen because kitchen is ready everywhere, in Grand Hotel to ITC, Sonar Bangla to here, everywhere material is there. How do you cook? It matters. So ingredients are same in everywhere, but what matters, how do you cook? You see, 2 boys are being examined. Ask them a simple question. The single question, tell me 2 important causes of central cyanosis. You will see by the delivery examiners we see, it is different among the 2 students. Somebody gets 5 out of 10, somebody gets 10 out of 10. It is just a practice. Always do the practice. Practice makes a man perfect. Rehearsal, that's the practice. Few mock tests for oral and practical examination is a must. Instrument to carry in the examination hall. Everybody knows we have to take the stethoscope, torch, hammer, etc. And in the postgraduate, logbook, not always required, but many a time they may ask. 1 or 2 examiners are very naughty. Believe me, very naughty. Because they remember their cases. They passed 3 times, in 3 times. That's why they are a bit naughty. So they may ask for your dissertation. Dissertation is usually not required in oral and practical nowadays. But if anybody asks, you must be prepared for that. Suppose they will ask you, what is the title of your dissertation? You are so talented, you have forgotten it. So you take it with it. Special for pulmonology. One is measuring tape. It is a must because for the movement of the chest, this is very important for you. And 2 cardboards for anterior, posterior, and transverse diameter. I tell you, one of the examiner was asking how to measure the anterior, posterior, and transverse diameter. So cardboard now is the DNT students are taking. I am taking class all over India. One go here, one go here. So that will give you the transverse diameter. One here, one there. Transverse diameter is measured by 2 cardboard. Wristwatch. I saw one boy, student is crying because of this. I have written this in my book also. Don't take the digital watches. There is no hand of second. You cannot count the pulse. This is a real problem in the hall. Take the old HMT watches or Tata watches. 2 1 rupee coin for your coin sound. In pulmonology is very important. 2 15 centimeter ruler for neck venous pressure. This is required. 2 15 centimeter means 6 inches ruler. It is required for measurement of hepatomegaly, splenomegaly, and jugular venous pressure. Ophthalmoscope. Anybody may ask you about ophthalmoscope. One thing in pulmonology very commonly asked in your patients of pleural effusion. I have seen many of the teachers asking, have you got any ophthalmoscope? Yes, sir. Go. Such one finding that will prove your etiology. Yes, your answer will be choroid tubercle. Be ready for ophthalmoscope. If you get papilledema, think of SBC syndrome and COPD or type 2 failure, respiratory. These are very important. And the most important instrument in your exam hall is your confidence, not overconfidence. So confidence is must. Be alert about 4 unavoidable things. If you clear this one, you will be clear in your exam passing and delivery. Allotted case may be unpredictable. You have never seen that case. You have never seen this case. I can remember in my MD examination, I have seen a case, I have never heard of it. One boy with exophthalmos proptosis, high bridge of the nose, that is called Crusoe syndrome. I only knew the name of Crusoe syndrome when I passed. So prepare for the unforeseen. This is the unpredictable cases may be given. The patient may be non-cooperative, especially in the second half or in the second day, because they know you are not a doctor, you are a doctor under construction. So they are now cautious. So what they do, they will not allow you to touch. Recently, I saw, just 1 year back, one guy is crying. I am going to examine you. Please, I will not hurt you. No, 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 you go. आपके पहले जो आया वो मेरा पेट फूटा कर दिया. He is not allowing the girl to touch her, because it is your duty to examine the patient, because nobody, no conductor will help you. Nobody will help you. Nobody will change your case. Nobody will change your case. Remember, একটা বাচ্চাকে তোমার কোলে দেয়া হয়েছে. One child or one 6-month baby. আমি নিয়েছি. I have taken in my lap. He is crying. But if you take, he is not crying because you know how to hold the baby. I do not know. This is examination. Remember, every word is important, because I am telling you the summary, because you will not get a chance from me next time. This is very difficult. I am telling you the summary all over India, what is going on. Just a minute. Limited time period, the theory of relativity. Your time is fixed. Your teacher will tell you what is the time you are allotted. Liking and disliking of the examiner, you must give importance to it. The known face of your examiner, suppose you entered the examination hall and suppose you saw someone, you met him on conference of Pulmocon in the first floor while taking mutton. Remember, familiarity breeds contempt. Don't try to gossip with your examiner. That is a special species. That is a special species. It is your exam hall. I tell you, it is the firing squad. I may be nostalgic because it is the most dangerous day for a student, for MD or MBBS examination or DNB examination. Hey, idhar aa jao. Hey, edike esho. Baba, edike esho, eta ekটু বড় হয়ে গেছে, দেখো তো। দেখো। And mock test দিতে চেষ্টা করো with all the friends, 4 or 5 friends. Recently, Mumbai, they started mock testing in lieu of money. In lieu of money. Go through mock test, you will definitely pass in the exam. That will make you pass. Few students are there who think in the examination hall, the case will be given to me and I will pass fluently. No, it never occurs. Nothing called stage makeup. Nothing called stage makeup. Now, probably the last slide, but it is the most risky slide, where you do the mistake. Number one, female patient. Female patient for a pulmonology examination, they will not change your patient. A female of 18 years is given to a 26 years male candidate. Remember, your examination starts, it is your pleural effusion, you have to percuss over the breast. What to be done? Be methodical, be sensitive about the patient, go through Hutchison Hunter, repeatedly they are asking it. You cannot hurt the patient. If the examiner thinks you have hurt the modesty of the patient, you are gone. Believe me, you are gone. So ask him repeatedly, ask one female attendant, ask for the curtain, go through slowly. This is very important about the female patient when the examinee is a male candidate. It's not a problem for a female candidate. Okay. So this is a real problem, and ask for the curtain. 5 cardinal rules in your long case or anywhere. Remember, always stand on the right side of the bed because you are right-handed. If you are left-handed, stand on the left side. You have to stand on the right side of the bed. Remember, it is a rule of the thumb, believe it or not. If you are left-handed, you can stand on the left side. Number 2, write all the system. It is a pulmonology exam, but nobody has hindered you to examine the cardiovascular or gastroenterology. Everything you have to write. Write down all the ornaments in the patient's body, like Ryle's tube, like the urinary catheter, like the IV drip, etc. And then female patient, I told you. Then never forget to examine in all cases these 4. One is scrotum, first ace. Those who have read my book, everywhere I have written it, and this is now a must in MRCP. And they are asking me all over from the UK and etc. because they are fond of this. Scrotum is a must. Spine is a must. Breast is a must. Fourth, I have added supraclavicular fossa, means neck glands. You must examine this four because we forget to examine the spine. Because your patient is got a pleural effusion, but you have not seen the gibbous, it will not make you pass. It's not will be fluent. Nutrition. What you do nowadays in nutrition, examiners think you will write BMI. Everybody knows BMI. BMI means weight in kilogram divided by height in centimeter square. So you must be acquainted with your BMI examination. BMI. How to do it? Not like that patient is emaciated or cachectic. BMI below 18.5 is normal. You all know. More than 40 is morbid obesity. You know the classification. I'm not going to teach you. So they want to ask you waist hip ratio, because nowadays your longevity is determined by waist hip ratio. We Indians have got like tummies, abdominal fat is more. So what is waist hip ratio? I'm telling you, recently one teacher not in general medicine, in another stream, asked about waist hip ratio. I'm telling you, waist hip ratio, waist spine and lower costal arch. The midpoint of it is mid-axillary line. Take the circumference. More than one in a male, you have got a metabolic syndrome. You are more prone to develop IHD, hypertension, etc. So go through BMI. What is cachexia? They ask you. Cachexia means severe emaciation. No, it is anemia, anorexia. Anemia plus anorexia plus total loss of body muscle and fat. Remember that old days nutrition measurement have been gone. What we did, skin fold thickness, muscle mass, and signs of vitamin mineral deficiency. No, nowadays they want you will do BMI, and with this BMI you can diagnose obesity, etc. Suppose at your age your weight should be 70. If it is more than 10% higher, 10% means 77 plus, you are overweight. If it is more than 20% of the same age and sex, that means 14, 84 plus, you are obese. Pallor and anemia are not synonym. Nowadays, everybody prefers, every teacher, you will write pallor, not anemia, because there are 100 causes of pallor. Anemia is the commonest of them. So pallor means waxy paleness of your skin, and it depends on the thickness and the color, melanin of the skin and the blood flow underneath the skin. This is called pallor. They will ask you, can you tell me there are some condition, one or two, more pallor than anemia? Patient looks very pale than anemia. Every student must know chronic renal failure, whether you are giving pulmonology or cardiology and myxedema. They want you will tell this to answer. How to examine for polycythemia? What is the commonest cause of polycythemia in a tertiary care hospital in pulmonology MD exam? Remember, it is COPD. No other answer will stand. Not congenital cyanotic heart disease. It is COPD. COPD. If you are asked what is the commonest cause of hemolytic anemia in your hospital, your answer will be thalassemia, because you see thalassemia more, hemolytic jaundice or hemolytic anemia. So polycythemia examination, they will ask you same as anemia, means lower palpebral conjunctiva, then the tongues, then the palate, then the palm sole, then the nail bed. Same. How the polycythemic patient looks like. There is a cherry-red tongue, facial plethora. They ask it, the adjectives, suffused conjunctiva. And many a time, other than the face, there is palmar erythema. Cyanosis. You all know what is cyanosis. I'm just going through the flaws. What are the questions they ask? One examiner is asking, suppose I am asking in Calcutta, what is the commonest cause of peripheral cyanosis here in Calcutta? One boy answered me, according to Harrison, frostbite. Will you pass? If you go through the English books, this will occur. And second boy answered cold air. Cold air is causing cyanosis in front of APC Road at NRS Medical College. Is it a fact? The answer is peripheral circulatory failure all over the world. Then if it is a Antarctica, you tell about frostbite. So remember, they will ask you in this way, what is the commonest cause of central cyanosis or peripheral cyanosis? So it is very clear, central and peripheral. Only one thing I'll tell you. Recently, I saw no student is giving clear about the cyanosis. Central cyanosis is examined. Peripheral cyanosis is examined with the tip of the nose. You place your hand here. That is peripheral cyanosis. Tip of the nose, outer surface of the lip, outer chin, earlobe. Just this is tip of the. This is peripheral cyanosis, along with the tip of the fingers and toes. Central cyanosis means, along with this, there is the oral mucous membrane, that is the tongue. Centrally deoxygenated blood moves all over the body. They will take your periphery view. So if you see your fingers are blue, it may be central or peripheral. If you see your tongue is blue, it is central. So if you are asked to examine central cyanosis, believe me, for what sake, after the tongue you must say this and this. Nobody is doing it. The language of Kumar and Clark, where I have written 2 chapters, the centrally cyanosed people are peripherally cyanosed. This is the cause, because the centrally deoxygenated blood is roaming all over the body. This is a common mistake. Cyanosis. Then jaundice. Jaundice. They will ask you how to examine jaundice. You all know. You all know. In obstructive jaundice, many a patient comes with obstructive jaundice. What is the common signs or symptoms? Nobody tells about the pulse. Amra nari tepa doctor. Just go through the color of urine and stool. Urine is obstructive jaundice is yellow, and China white in stool. And pulse is sinus bradycardia. They are waiting. Examiner is waiting to listen from you about the pulse, because a patient with jaundice with bradycardia means obstructive, because SA node is inhibited by bile salts. Okay, I will go to jaundice in the spot case. Clubbing. Clubbing is very easy for you. Remember one thing, clubbing diagnosis is very easy for you all. Etc. How to examine? First step is onychodermal angle. So if you want to see the onychodermal angle, you all know this. Patient is lying down in the bed. So what to be done? Hold his hand and you go down to impress your examiner that I am giving a tangential. The patient can go up. He's ill. So you go down. Examiner is waiting for that. Believe me, he's just seeing how to examine. Onychodermal angle, sir, it is more than 160. I think so. It is clubbing. Others, you know. Pack ear. Pack ear, you all know. A cigarette contains 20 cigarettes per day. You are smoking 1 packet per day for how many years? And there is a lot of interest, you know, when it crosses 30 or 40, COPD, carcinoma lung, etc. JVP, I am not going into that. JVP is very important in pulmonology after cardiology. One of the JVP is one thing the students know, and they don't know anything. Teachers don't know anything. It's the toughest part in clinical medicine. Nobody knows about it. If you see it, many a time I have seen after measurement, I have done 100% wrong. So try to see how to examine. Never, ever hold the patient by your arm. Try to do this proper relaxation. Ask for a tactics. Your conductor will get what you want to do. Just remember, you tell your examiner, I asked you. It is an exam. So remember, everything is important. Everything. আমি যখন পরীক্ষা দিতে গেছিলাম আমার পেশেন্টটাকে পারছি না, আমি হিস্ট্রি অফ এক্সপোজার জিজ্ঞাসা করেছি, পেশেন্টকে কি সাধু হিস্ট্রি অফ এক্সপোজার, সে হাউ হাউ করে কাঁদতে কাঁদতে বিছানাতে পড়ে গেছে, অ্যানসার দেবে, আমি ভয়ে বলছি। Then I asked the conductor. Then I asked the conductor, sir, how can I continue the examination? Patient is not answering. He told me one answer. And it is coming in my last room. This is your count. I don't know. So you are alone in the examination hall. Nobody is going to help you. And that requires a mock test. because that is your examination. Next, lymph nodes. This is a very important thing. One thing I'll tell you, lymph nodes you all know. The lymph nodes of our body are cervical one. We have got at least 500 lymph nodes all over our body and 100 in neck. So neck is very important. After that, we have got lymph node in axilla, epicochlea, mediastinum, abdominal, inguinal, occipital. Cervical. All the nodes cervical should be examined from the back. Two nodes you are asking the exam. How to palpate the scaly node, how to palpate the mucous node. I'm telling you, there is no patient I can ask one that why was that node. I'm telling you. A parto, কোনো ছেলে আছে? It was not you to ask. And get out of it was not good for a because it was not reach 5 things. Breast, lung, and melanoma, stomach cancer, vesicular. Single calculable window. One life because of the eyes left sternomaster. Left sternomaster. So what to be done? Hey, chele pule ache kyo? After bacha chele ko non-medical ko pade na. I বলে দিই একটা কথা বলি এখানে ছেলে না because that I am satisfied put your hand to the right side cheek ask me perfect that's so from the back you can calculate that from the back examine it and put your finger as you are go back to the people that is the people that now straight the face place your hand right side of the chin it is the people the healthy node you have to examine healthy node deposit on the left healthy node lies in the retroclavicular behind the head of clavicular vein. So what to be done first? Ask him to start that. Other than pictures. আপনি আমার হাত আমি দেখতে পাচ্ছি if my weight extra if that two hits start on one side now let it say this example cervical gland and obi examine the front remember if not examine what to do they will ask you to examine the because that then they will observe you they are going the back to down in the front and they are waiting for that they're just not waiting now this is what এইটা গেট অফ প্ল্যানিং এটা করতে পারে এই স্টাডি করলো ডিপ ডাউন হলো হেডের পেছনে ডিপ ডাউন করো এবার সোজা করো ইউ আর ওভার দ্য স্কেলিনাস অ্যান্টিকাস দিস ইকুয়াল পার্টস ইন ব্রঙ্কোজেনিক কার্সিনোমা আমি আর ডিটেইলসে যাচ্ছি না নাও ওয়ান থিং pulse you all know I'm not going into details. When you are asked in pulmonology, describe the pulse. What you do? You do 15 seconds into 4. No. That's my repeat the examination. So try to for 1 minute 4. You do not know on the 59th point. You never know. So try to calculate it for 1 minute full. And what the students do, sir, rate is 80 per minute. Any other point? So describe this, what I have described, rate, rhythm, volume, condition of arterial wall, radial delay, radiofunctional delay, whether all the pulses are palpable, special character. Time is 1 to 2 minutes. So have to describe all these points because everybody wants. Because if you do not describe, you will describe. And the number is 8 out of 8, the examiner will reduce it to 1. You will get 10 out of 8. So pulse should be described in all points. Next, edema. Another important thing. Students are asked to examine for edema. In uncontrolled common cases are chronic pulmonary. We all so examination. First stand on the right side of the patient. Place over the. This is medial medial. Place over the medial. Then above the medial. Over above. Then over the dorsal because you have missed the dorsal. But you have got no right to examine the dorsum at the first one. You have to examine Pulmocon. That is convention. That's medial. Over the medial vellular, above the medial vellular, compare with other side. Then the dorsum. Then over the sheath. Then the parietal humor over the thigh or the abdomen. Both your teacher in the college they will teach you. This is an undergraduate class and edema pulmonary examination is complete when you turn the patient. That has examined the sector. Otherwise, they will examine and pick up while having any care of that. So, turn the patient. Okay. Then they will ask. They may ask you whether you will examine. Okay. No, sir. If you allow me, I will examine the upper part. Upper part is over the waist, over the polycranum, over the clavicle, sternum, like the sacrum over the vertebra. And many book write in UK and USA over the forehead. This is examination. Because the upper part, ABCD SBC syndrome, you do not know the case. So you have to complete your examination. Now, examination of breast, spine, and testis has gone. Special reference to give birth. Give birth is very, very important in carcinoma, metastasis, and tuberculosis. Shape and back of the chest. I'm not going into details. And MCL. Many students may be very brilliant. They don't know what is the definition of mid-clavicular line. Because in chest, percussion, auscultation, everything is done in mid-clavicular line, mid-axillary line, and scapular line. I'm just telling you the definition. Scapular line means the patient is standing. The vertical line from inferior axillary scapula. Mid-axillary line is middle of the anterior axillary fold and posterior axillary fold. Anterior fold is pectoralis. Posterior is scapular. Mid-clavicular line is wrist. Mid-clavicular line means midpoint of tubular notch. Midpoint of tubular notch and acromion process. Midpoint of this. So midpoint of tubular notch is 1 point. Acromion process is 1 peak of the acromion. Midpoint of this. Line goes vertical. There is 2 big. Let's say this E. Symphysis, pubis, and anticipate iliac spine. That's midpoint. The latest classification of this because your examiner has read, so you must know this. Mid-clavicular line is very important because in the upper border of hepatic percussion, and this one, everywhere you have to do this. Then, back of the chest. Back of the chest, I tell you, in pulmonology, when you are asked to examine, inspect the back of the chest, what to be done? What to be seen? Mind it is inspection, time is very short. So, patients will be start is open. The female patient is careful. So what are the things you see? Just to see. You are in the back. Here is the patient. First is drooping of the shoulder. Then is kyphosis. The patient is standing there. Kyphosis. I have to see. Kyphosis cannot be done. Behind the then what do we say? Inferior angle of scapula. Both are in the same plane or not. Interscapular distance. That is scapular. Straight back syndrome. The drooping of the shoulder is low. And last we have to examine if we are allowed to do the palpation, the movement of the chest and the condition. So back of the chest examination is very important. Remember, system other than, we are in the last part of today's discussion, symptoms other than respiratory system. The patient of pleural effusion have been asked, what are the other systems you have? You have to give the answer. Go to your books. The common thing in a patient of pleural effusion, if you get spleen, if a patient of spleen, Probably the left-sided pleural effusion has spleen has descended down. Or if spleen is enlarged in the case of pleural effusion, think of lymphoma, SLE or other. So push and pull, push. So other system you must examine. Now, trachea examination. You all know trachea examination, three things. Hands by the side, everything flex. I have asked at least 300 clinicians all over the world. Few books like neck must be extended, flex. But I have to push our stand must be up. So right before examining trachea, you must be watchful whether there is whiter presence or whether whiter. You can ask the beginning. Now, that's by the side, cheating the next time, you start the tracheal palpation. Lower border of precoil. Lower border of precoil is C5 and 6 junction. Here. Then the precoil. So you are allowed to ask tracheal palpation. Don't put your finger here. You go from precoil to down. Precoil, lower border of precoil is the birthplace of trachea. Okay, then you know how to palpate the trachea. And both the patient and your head should be in the same place. Patient may standing, you may stand. Now, percussion or auscultation, I'll tell only one thing, not in details. Percussion is very difficult, you all know. Whether in no one, one is conventional percussion, second is wild percussion. Because tidal percussion, nobody does. It's not the older examiner. It drops this one. Upper order of 2%. Up to like many students like. That's it. As soon as I have the book, 100 of students writing. The examiners are asking this. Writing is not the conventional percussion, shifting. One thing I'll tell you, one day I was asking Shupriyo how to do shifting dullness in the chest. Because in medicine and pulmonology, there is a bit simple difference. In pulmonology, what will you do? In a patient of hydropneumothorax, patient is standing or sitting. Pneumo part is above, hydro part is below. In the sitting position, you start percussion. Suppose after percussion, from here there is dullness. Okay, there is dullness. But they do, Supriyo has told me, they do the percussion at the back. So in the sitting position, lower part will be dull. Then they ask the patient to bend forward. So the fluid gravitates and the upper part will be air. So whole of the back will be now tympanic. The lower part which was dull in sitting position. This is shifting dullness like ascites. You can do it in the front. Sitting position, this is dull, this is tympanic. Then lie down, supine position. After half a minute, the air will go in front. Now, one thing I'm telling you, coin percussion, you all know, I'm not going into methods. One thing I'm giving you warning. Few of the clinical method books have written tidal percussion should be done in the front. Believe me, tidal percussion, if you are asked, it should be done at the back. Tidal percussion means diaphragmatic movement. Whether in inspiration and expiration, my lung is moving one space above or down, nothing else. It has got its value, no value, because there is chest X-ray, ultrasonography. It is very crude method. Now, I will just show you one thing. Percussion of trough space. Trough space, nowadays, trough space is not within the abdomen. The boundary is left side, mid-axillary line. Mid-axillary line. Above, it is the lower surface of the left lung and diaphragm. Below, lower costal arch. So remember, the space is here. In the upper part of abdomen, small triangular space that contains the fundus of the stomach. So how to percuss? The man is famous. His name is Barkun, B-A-R-K-U-N. Now Harrison has commented it. I knew the name of Barkun 30 years back when I passed the MBBS. Barkun is a famous man. What he did, he placed his hand like this. Placed his hand like this. And in the fourth and fifth space, you go like percussion in the interscapular region. Fourth and fifth. If you do it, there will be a tympanic note of fundal gash. If the it is dull, that means either fundus gas is gone, that means fundal carcinoma, or spleen has enlarged, or there is pneumonia, or liver has enlarged, or there is dextrocardia. Very simple medicine. If there is no top space percussion tympanicity. So cardinal rules of percussion, if you are asked, you will do this. I will percuss from more resonant to less resonant area, or resonant to dull area, what I know. Second, the line of percussion will be line, upper border of liver dullness percussion. It will be pleximeter finger should be placed parallel to this, and line of percussion will be perpendicular to that. This is the very important subject. That's why I am doing percussion like this. Third one, for superficial viscera, it is a light percussion. For deep viscera, this is a heavy percussion. For the percussion at your back, you have to give more beats because big deep muscles are there. If you are asked to percuss the upper border of liver dullness, that is a heavy percussion because upper border of liver is right fifth space. It is underneath the lower border of lung, right sixth rib. And lower border of lung percussion is a light percussion because lung is floating. So remember, these are undergraduate courses. Now, I am telling use of diaphragm and bell. Recently, in many of the countries are using bell for auscultation of pulmonology because all the respiratory sounds are low pitched, like mitral stenosis, the murmur. That murmur is low pitched. So bell, if you use, nobody will tell you anything, but to maintain the time, the diaphragm is more, so more spacious. So we are using diaphragm. But it is written in many books that bell can be used because the lung sounds are low pitched in quality. Top space, movement of the chest limits, SBC syndrome. Veins over the chest. Veins over the chest, you are asked. I have asked just recently to one girl, there are some veins over the chest. Veins over the abdomen was there. Just to examine. She went to the patient and started what he has done. I cannot remember, but completely wrong thing. If you are asked to show the examiner the flow of the blood, make him seated. The first point. Make him seated, he must be seated, not in lying down position. Then you milk it. This is the vein. You milk it, open it. Rapidity of flow, you see, then you do it, then you release it. Rapidity of flow. That will give you the diagnosis, but make him seated. If you make him seated and to make it prominent, you have to ask him to do Valsalva maneuver. What is Valsalva maneuver? Forced expiration in a closed glottis. Try to do it, forced expiration in a closed glottis. During defecation, what you do, this is Valsalva maneuver. They will ask you, during defecation, this is the common thing you must tell. And what is the second example? বাড়িতে তোমার মা যখন শাঁখ বাজায়, খুব বেশি এক্সাম্পল নেই কিন্তু, সেই জন্য they ask these questions. So conch shell যখন বাজানো হয় অথবা during defecation, forced expiration in closed glottis. Forced expiration in closed glottis, you do it, within a second there will be tachycardia. And after 15 seconds, if you release it, there will be bradycardia, you will have vertigo. I have done it 100 times. You do it today at your home. This is Valsalva maneuver. For eustachian blockage and many things, we do it. What is the during Valsalva, the veins will be prominent. So patient will do Valsalva, make him seated, you do this. If your examiner asks you to show me the veins, ask him to cough. Cough engorges the vein for a few seconds. Just pullo chole gelo. But Valsalva you can do 15 seconds, 20 seconds. You have got time to do this. And the opposite term is Muller's maneuver. Force inspiration in a closed glottis. You cannot do it. Example only one. Drowning man. Drowning man tries to force inspiration in a closed glottis. Remember, Muller's maneuver nowadays is used to determine the causes of sleep apnea. This is a recent development. Now, okay, leave it. Flapping chamber, spleen chondo. Last two things. You are asked to show you the flapping chamber because you have got a patient of respiratory failure type 2. What to be done? Most of the students are showing me this. This is a good method, but there are some tidbits. Ask the patient to stand like this. Like do the dorsiflexion, and you have to place the hand for 20 seconds minimally. 20 seconds. What she does? He does status like this. And with lateral, lateral. Just it is called bat swing chamber, as if the patient is flying from the world. But the best method is hold his hand here. He's lying in the bed. Hold his hand. There must be some understanding with the patient. ওর জ্ঞান থাকতে হবে, নইলে হবে না। You do like this and ask him to hold the hand like this. You release. He cannot do this. He cannot do this. Why? It is the function of reticular formation. There is lapses in the posture. You will be asked why flapping tremor occurs. You will tell it is the neurological lack of joint and joint and muscle sense. This is a very difficult question. Joint and muscle sense formation. Next, Valsalva cardiac percussion. Last, I am showing it to you because it is very difficult. If anybody কোনো দুষ্টু এক্সামিনার জিজ্ঞাসা করতে পারে কার্ডিয়াক পারকাশন উঠে গেছে, বিকজ দেয়ার ইজ ইকোকার্ডিওগ্রাফি, দেয়ার ইজ চেস্ট এক্সরে, ফিমেল ব্রেস্ট অসুবিধা করবে। এছাড়া আমি যদি পারকাস করি, যদি কাউর একটা থ্রম্বাস থাকে, দ্যাট মে ডিসলজ আফটার AMI, দ্যাটস ওয়াই ইট হ্যাজ বিন লস্ট। সো হোয়াট টু বি ডান? হাউ? I have got 4 borders: right border, left border, inferior surface, upper surface. To percuss the right border, you have to first percuss the upper border of liver dullness. If you do the upper border of liver dullness, examiner will be very happy. So after the upper border, it is right 5th space, then go 1 space above, 4th space. From 4th space, go this side, because this is the border. This finger will be parallel to this. So in the 4th space like this, 3rd space like this, put 2 points with the convexity. Then in the left border is difficult. You have to palpate the apex, because cardiac percussion is done in pericardial effusion. In pericardial effusion, apex is not palpated. If you are showing it to your examiner will tell you in this way. You will tell with difficulty, I have delineated the apex. Now for the upper borders, there is an arbitrary line called acromioziphoid line. Acromioziphoid line. You have to percuss along this line. And there will be dullness, 2 or 3 points. You join it, finish it up. So right border, left border, and upper border means, upper part means the base of the heart. Right 2nd space, left 2nd space. You percuss through like this, like mediastinal percussion. How you do it? In mediastinal gland, right sternal border, left sternal border, parallel to this. Keep it parallel to this one. If there is dullness, and sternum is percussed directly, because clavicle, sternum, and scapula are percussed directly. These are bones. Okay, I must stop here, Partho. There are so many things. Acha, just a minute. আমি একটা জিনিস কিছু এটা একটা কথা বলে দিই। This is a new thing in cervical gland. Many of the teachers, your teachers know, students may not know. The cervical glands, many of the students are telling me the station of the glands. This is a new thing from carcinoma. It has come. The classification of cervical gland carcinoma. There are 7 stations cervical gland. Read it from the book. You have palpated submental, submandibular, tonsillar. You all know preauricular, postauricular, occipital. There are 7 level stations. Suppose a gland is palpable. If it is submandibular or submental, it is called level 1. Then upper jugular, middle jugular, lower jugular, 2, 3, 4. And ultimately superior mediastinum is 7. Recently, one examination I took it, and every student has written this. So in somewhere, in some states, somebody is teaching it. If this occurs, if your examiner is coming from outside, they will expect you will do it. So it is called it's a very new thing. Station of cervical lymph nodes. Okay. Okay. Partho, তুমি লং কেসে ওটা আরম্ভ করে দাও। আজ পডকাস্ট পরে 5 মিনিট দেখিয়ে দেবো। Thank you,
Kundu, for such a wonderful teaching. So next session is on long cases, and we have got examiners like Professor Kundu himself. I'll request all the examiners to be on dais. All the examiners are requested to be on dais. The examiners include the faculty for this session: Professor Kundu, Professor ML Gupta, Dr. Supriyo Sarkar, Dr. Supriyo Sarkar, Dr. Radha Munje, Dr. Nimesh.
Please.
Okay, sir. Okay. Excuse me, sir, because they have got flight to catch. We are preponing OSCE. After that, we'll go to this session.
Okay, no problem. No problem.
Yeah, sir. No
problem.
No, it's all right.
I will listen.
No, you do it with adequate time. So I'm sorry, we'll go straight to OSCE session. And there's another announcement. In the other hall, we have got a symposium on career option. It will start from now. So those who are interested for that session may kindly go to the hall 2. Symposium for young pulmonologists regarding career options. So OSCE session, please be started.
Just an announcement. Those who are interested to participate in the OSCE session, kindly occupy the first row of the podium. Kindly come up in the first row. Kindly come up in the first seat, first row of the session. Just a gentle announcement. Those who are interested in listening to a talk by Dr. Guleria and Dr. Sandeep Salvi are invited in the hall B for the respective session.
Good afternoon, friends, and very sorry to break the plan which Dr. Partho had done. And in fact, it was so good to listen to all eminent teachers. And what we have actually seen and heard is their experience of so many years that was being spoken. It was not a book knowledge or a theoretical knowledge being transferred from the books to the slides and then from slides to you. In the same manner, we would be now myself and Dr. Animesh would be speaking on OSCE. So what is OSCE? It's an objectively structured clinical examination. Similarly, we have OSPE, which we call for non-clinical subjects, where you have to perform an experiment or perform some task which is told. It is called as objectively structured practical examination, that is OSPE. Now, what are we going to see? What is actually OSCE? Me and Animesh would be taking it, like an extempore form, even if we have prepared, and we'll be sharing the presentations also. Like Dr. Kundu was telling, we always say and underline that you should really respect and honor your examiners, whether they are internals or externals, known to you or even not known to you. And he also said that do not offend. But why OSCE has come is that all over the world, it was observed that many of the examiners, I'm sorry to say, even if I'm on this side, have a little bit of bias. Like, for example, you did not perform a particular test in this way and hence you did not get marks, or something was not written what he wanted and hence you did not get marks. So that is not true. The task of performing a clinical examination is divided into many small parts. So for example, I'll give an example just for you to understand that if you're going to cook something, what other person is getting a ready-made dish to eat, but the person who does it have so many things. He has to buy the objects, prepare it, cut it, saute it, fry it, put all masalas and salt and pepper and then serve it. Similarly, in OSCE, the task is divided into many things. Like Dr. Kundu has said that, for example, if you have to examine a person and you have to look for the trachea, the first and foremost is your patient should know what you are looking at, because you're going to put a finger over the air pipe, which may be very uncomfortable. So one is you are going to tell, second is you are going to ask him to flex his neck, then you will put your fingers over the trachea and then slide. So these are 4 small steps. So one step may go wrong, but for that you won't get 0. You would get less marks, but still you will learn to score if you know the steps. That is actually a fundamental of OSCE. However, it is not possible to do all these things. So what we do usually, and whenever there is an exam, OSCE stations are prepared and not too many questions are asked at one spot. So one spot will have one question with a predefined one answer, so that we look how well you have understood. We know whether you have answered properly or not. And for each proper or right answer, you go on scoring marks. So उसमें बहुत objectivity है. आपका आंसर मुझे अच्छा नहीं लगा is not valid. आपका आंसर for that question, if your answer is correct, you will score it. That is what is actually OSCE, and how it is applied, that we'll see. So what we have learned in last 2 hours from all our management teachers are that whenever you teach somebody, you learn it twice. So to teach is to learn twice. And what is OSCE, I have already said. And we have different cases here. I mean, you will be taking that right now, or this is coming? I'll just go. अगर पेन ड्राइव लगता है तो कर दो ना. Did all of you get answer sheets? Are there going to be answer sheets? All those who are postgraduate students? All those who are postgraduate students, please come on this side. And not like an exam, you are not going to be asked.
Two cases, right? Yeah, good afternoon, everybody. My name is Animesh. Right. So I'm not sure. So do we have only 4 postgraduates here? I'm sure there must be more. So I mean, if you're, this is not going to be a firing squad, right? This is not going to be deadly. You're just going to ask questions. You're supposed to supposed to write down the answers. And once you collect the answers, I'm told that there are prizes up for grabs, right? And it is going to be a bi-directional educational thing. Nobody is going to be slapped or kicked or killed. Sure. Absolutely. Do that. Right. So we are settled, are we? So just to, introduce myself, my name is Animesh Rai. I hail from this city. Right. I'm working in the Department of Medicine as an associate professor. So what am I doing in a pulmonology conference? Well, I've been to a lot of places, done my MD medicine, and then I have also, done my DM pulmonary medicine, and I've also appeared for a couple of OSCE examination. And I've just managed to pass in an OSCE examination. That was the MRCP. And I actually failed once in one of the OSCE examination, that is headache part 2. I had to reappear again. That was in a foreign city. That was in Prague. I had to reappear again. And that one I cleared comfortably. And now I'm expected to take OSCE tables in my institute. That is All India Institute of Medical Sciences in the Department of Medicine, which caters to both MD medicine as well as DM infectious disease. So I can tell you that, I kind of, OSCE has become my kind of a friend of mine. Okay, so what we'll do is we'll just talk briefly about OSCE, because what I understand is, since I'm from this city, I understand that, people from here, we are infatuated with examinations. We like giving examinations. We like degrees against the name. So I'm sure that a lot of you, you're going to, go to clear your MRCP and whatnot. EDRM does not require, you have to just give an examination, but you're going to go and appear for a lot of OSCE. So my idea is to just give you a feel of OSCE, right? So I'll just introduce the topic. We'll discuss 2 cases. I'll discuss 2 cases. It would be such that, first study questions. Now, the problem with this OSCE is that I cannot introduce a clinical part to it. It's very difficult because we don't have a live patient. So what we'll do is that we'll be taking some forms of OSCEs and not the other ones. Here, my emphasis would be on giving you the clinical part, right? As much as possible through a presentation, and you would be expected to, answer them. And what we'll do is after we close a case, so 10, 11, 12 questions per case. So once you have finished writing the answers to the questions, we collect that, the question, the answer papers, then we discuss that question, right? Discuss it quickly. And then we move on to the next case. So I'll do 2 cases. Madam will be doing 2 cases after that, right? Okay. So if you have any questions, there is an August gathering here. If there are any comments, that would be more than welcome, right? Okay. So, OSCE, why OSCE is required? Come on, it's an objective structured clinical examination. The name says it all. So this is from an MRCP examination. You can see multiple stations, right? And the examinees, they are moving around in circles. So why? Because, everybody, depending on the MRCP, suppose if you are talking about MRCP, each station can consist anywhere between, say, 20 to 30 minutes. In some OSCEs, it is 5 to 15 minutes. And the candidates, they go to every station, right? Usually different examiners are there. So it's different from our long cases where, one person determines your whether you're going to pass or fail. You mess up your long case, you're not going to pass. Not for really OSCEs, because you go to multiple stations. So multiple examiners kind of assess you, right? Important is same questions and same answers. It is objective, right? So I'm not going to ask you about, where who Onbrugger was, because I was asking you. No, it is going to be a structured question and a structured answer. So more objectivity, right? So this is, again, what the Europeans do. They want the examination to be more objective. So, it does not depend on the examiner's whims and fancies where he is going to take you as the long case progresses. So more objectivity. So objective, structured, it is broken down into parts. Clinical examination, as simple as that. You can very well understand what the benefits and the disadvantages are. You can cover a lot of things that are the benefits. There is decreased bias. I don't like you. I'm going to give you less marks. I don't like the jeans you're wearing. I'm going to give you less marks. That does not happen in OSCE. It is practicable because it is, you don't need patience. I can take an OSCE examination during the COVID. OSCEs were taken without the media of patients. You can do that. There are disadvantages. OSCE is a very labor intensive process. I and Madam, actually, we had conducted, I think, 2 or 3 Zoom meetings, and we had discussed it, we are trying to discuss, what the answers are going to be. So examiners have to prepare the questions and the standard answers. And, time is important. So making OSCEs, they take a lot of time. So they are expensive, if I can say it. And it can be of various forms. It can be OSPE, it can be OSATs, it can be OSFE. So what we are going to do here is we are going to do more of, interpretation of data. So objective structured practical examination. There are something which is going to be, objective structured video examination. Some videos we would be showing and some questions regarding to that. Technical skills, obviously, it is not possible directly. We'll try to introduce it a little indirectly. Right. So coming to the question. So I just want to know, so this group here, they are writing the answers, right? Right. Sure. And who would be collecting the answer papers? You would be. Okay, good. So the caveat is, come on, you would have to do it individually. It's understood because it's for your own good, right? There's no point in, come on, we are all adults, we know that. And you try to just write it briefly, whatever it is. Suppose some part appears to you as being more subjective. Don't worry about it. You don't have to write answers, just the points. Because when we are going to screen through the answers, we are going to see, whether you understood the basic tenets. That's it. Okay. Right. So here is the first case. 25-year-old man presents with wet cough and shortness of breath for 3 years. Right. Young man presenting with cough with expectoration and shortness of breath for 3 years. It's a very easy case. On examination, his hands show this, right? So my question to you is, what will you examine and how will you examine to confirm the findings, right? So Dr. Kundu was also talking about this, so I'm referring to, you understand, right? What are you going to do in real life? Just think about the patient in front of you. What are you going to do? You're going to do 1, 2, 3, 4. Okay, so this is a question. So we'll move on to the second question. So what I mean to are you catching my drift? The point is, you understand what this is, right? The nails look abnormal. So how would you confirm it in real life? You won't just say, oh, this is this. You're going to do something, right? You're going to touch the patient and do what? So Dr. Kundu was talking about some angles. I look at what angle? You're going to do something, So what are these? And suppose you diagnose this. So how would you complete the examination? Suppose I'm telling you, like, is it okay for you to see 3 fingers or you want to see something more related to this? Okay, so just 20 seconds for this. I'm sure this image is, you must be seeing it very common in your wards and your OPDs, right? So this is not an exotic thing. This is very common, right? Just so don't think it's very exotic. No. OSCEs, again. So I hope you have done it. So this is 3 common causes, right? So this nail findings that you see, 3 common causes that you know. As simple as that. So 20 seconds for that. Yeah. I hope all of you are writing the answers, right? Right, 20 seconds. Almost there, right? Okay. Okay, so you start examining the patient. Respiratory system, inspection, palpation, percussion, they are fine, right? So you So what I was trying to show here was, I was trying to show you some, sound out some auscultatory findings, right? So, but I think the audio jack is not here. We'll just see. Yeah. I mean, right. I hope everybody got it. Like, it's very simple. Come on, you're getting this, some changes. Right. So these sounds, you're getting it on auscultation. And I hope you got the question, right? The question is, right. So you want to hear the sound again, or it is clear? I mean, it's very easy. Come on. Front row. It's very easy for you. Very good. Okay. Right. So just to, clear it, this patient had the sounds on the right infraclavicular area, right? So fifth intercostal space. And I hope you got it. So this was, this was a biphasic sound, early inspiratory as well as kind of pan expiratory, right? No discussion, please. Front. Don't do that. Okay. So this is, so my question to you is, which lobe do you think is a lung sound emanating from, right? So right infraclavicular area, fifth intercostal space. So anteriorly, you're getting the sound on the right infraclavicular area, fifth intercostal space. Okay. So which lobe is the lung sound emanating from? Okay. So you should take 5 seconds to answer this. It's very simple. Is it the right upper lobe, the lower lobe, the middle lobe? Okay. So related to this, is how do you draw the major and minor fissure on the right side? Now here again, I don't expect you to write, we'll draw a line from this, just the salient points, 30 seconds. Now, the major fissure, I would start from here. I'll go here and then here. That's it. Minor fissure, I'll start from here and go here. That's it. Right. I hope you have got it. So the question is, what do you think the sound is due to? Again, those nail changes are there. You're getting this sound, which is inspiratory and expiratory. And you have heard the character of the sound. You know where it is coming from. So what do you think is the etiology? As simple as that. What is connecting all of this? What pathology in the lung? So 5 seconds for this. You just need to write down this. Right. I think you got it. Now, this may be related to this previous question or maybe not. So what are the common causes of bronchiectasis in India? I want you to write three points for that. So 1, 2, 3, 15 seconds for that. Right, so 2 more seconds. Okay. Okay, so this patient, this young man who had this, auscultatory findings, what this Neil changes. Now he gives a history of expectoration of a strange colored sputum. You can see it. You can see the color, it's not normal. So he's taking this out. What is this? What can be the reason for that? So what I'm trying to understand is that now that you know the pathology in the lung and the patient is giving a history of this colored sputum, what will you think of? So this is something that we routinely ask in the history, right? But sometimes it so happens that we ask in the history, but we don't know it. So if you have seen it, you'll not forget it. So I want the name of the condition. Should be 5 seconds if you know it. Okay. Which investigation would seal the diagnosis of the, so, I told you, already I've told you that this patient is having bronchiectasis. So which investigation would you do? Would you do an ECG? This is too simple. Would you do an ECG? Would you do a blood count? Would you do a, MRI, CT scan, X-ray, name it. Or a PET scan, right? So you think about it. Right, 5 seconds. Fine. Okay, so now coming to, CT scan, what are the typical features that you see on CT thorax? So I want you to write 3 points for it. So when we are seeing a patient, say, of bronchiectasis, we are seeing the CT scan, we see these 3 points, say 1, 2, 3. Or if you talk to your radiologist, they would say that, this is bronchiectasis because 1, 2, 3. Right. 5 more seconds for that. Right. Okay. And look at this PFT. Come on. I think there's going to be a session on PFT interpretation. But look at this PFT. The FVC is 3 liters. So Z-score, do you people see PFT on the basis of Z-score? Or do you see it on the basis of percentage predicted? So, worldwide, people are moving to Z-score. Why? Because Z-score is the more scientific thing to do. We have moved on to Z-score. So, I'll just give you Z-score means it talks about, how. So I do have a slide after this. Yeah. So Z-score is this one. I'll come back to the question. I'll come back to the question before that. So Z-score means the lower limit. So Z-score means how far a particular value is from the mean. So suppose I tell you that the Z-score is somebody's 2. It would mean that the patient's value is 2 standard deviation away from the mean. So the norm is you have to remember one value, that is 1.65. So if the patient's any value, be it FVC, FEV1, TLC, it is less than 1.65 Z-score, it is abnormal. So 1.65. Now the beauty of this thing is that it is same for all the measures. FEV1 same 1.65, FVC same 1.65, even TLC it is same 1.65. Even better, TLC, if you would see plus 1.65, so it would actually tell you, where the total lung capacity is more. So Z-score actually tells you the distribution in the normal population. So till minus 1.65 and till plus 1.65, it is normal. So which is shown by the green area, the light green area. If it is less than that, it is less than normal. So the beauty of it is you can use it in any population. If you have got normative data for that, you don't have to remember, whether it is 70% or 60% or 80%. You have to just use the Z-score. So Z-score is actually more scientific. So I hope you got a hang of it. So look at this, FVC, Z-score. Remember I said minus 1.6, if it is less than minus 1.65. So here it is actually towards the normal. So I'm just helping you with the first one. FVC is 3 liters, Z-score is minus 1.25. FE1 is 2.4 liters, Z-score is minus 1. F1 FVC ratio is this. TLC is 4 liters, Z-score is 1.1. So remember what I said, minus 1.65 to plus 1.65, right? So whether it lies, if it lies in between this, it's normal. On the other side, it is supposed to be increased. On the lower side, it's supposed to be decreased. So what is the interpretation? So I'm talking about the same patient here, young patient, 26-year-old, nail changes, that particular sound, and you have made a diagnosis, and you have gotten a CT scan done, and you're sure that the patient is also having brownish mucous plugs. I mean that mucous plugs, and you're trying to you know what the patient is having, and now you get a the pulmonary function test, right? So what is it? Okay, right. So you have to just write it. It may also be normal, right? It may be normal. You can say if it is normal. Okay, fine. Right, so we got this. Acha. So now, this patient also underwent a special test. I'm not sure whether you do it. You guys do it. We do it routinely in young patients with this particular condition. So let's see if it works. So this was actually the patient's investigation. Upper one is the patient's, lower one is an abnormal one, which I'm showing. So my question to you is, what is the test seen? And what is the interpretation? You can see this, right? Come on. You can see this, right? You can see, I mean, you can see some cellular structures, and there are some hairy structures moving like this. I'm not sure the bottom video is playing. Okay, so if you know it, you write it. If you don't know it, we'll discuss it. Right. Right. Now, this particular patient is, you go to him, you refer him to the pulmonology rehabilitation center, and he's told that you would have to pursue ACT. You have to do ACT, which is airway clearance technique. So my question to you is, if you can see this video, what is this most commonly done airway clearance technique called? So I've also, for you, I've marked the stages. Stage 1 is breathing control. So if this is an OSV, what will happen is maybe the stages, they are not going to be written over there. So you might be asked, what is it? And name the stages. Okay, so that concludes case 1. So can somebody, may I request somebody to collect the answer sheets, please? Excuse me, madam. Excuse me. May I request somebody to collect the answer sheets? So if you have collected the answer sheet, probably we can, we can put it all together there, right? So that we can start off with the next one, right? Thank you so much. Thank you. Thank you. Yeah. Or maybe who's the, Dr. Kaur over there. Right. So very quickly, I mean, we all kind of know this, but, I and Madam, we have tried to go through these questions, and we have tried to, pinpoint that these are supposed to be the answers which are expected. So what will happen in real life scenario is 4 examiners or 5 examiners, they are going to sit together and they are going to write 1, 2, 3, 4. These are the 4 things that needs to be seen. And it is going to be vetted by all the examiners. It's not going to be on the basis of, say, one book, what MacLeod has written or something like that. It's not going to be that. What do you do in clinical examination? What is expected out of the examiners. So that is the beauty of objective structured clinical examination. So very quickly, I mean, I am sure you guys have got it. This is clubbing. What we do look for, you look at the angle, you look at the fluctuation, you look for it everywhere, all the digits and angles. And, in order to know the extent, we have to also look for the HPOA. You are certain whether it's, what is the degree and whether it's painful or not. Because if it is painful, there are certain conditions which might be more common. So this is very simple, but you need to think about it because the patient is not in front of you. You only have the clinical finding in front of you, and you're supposed to write it. Okay. 3 common causes. You can write any of these 3: carcinoma, bronchiectasis, lung abscess, empyema. Now, the point is, you would say, okay, but I have written something else. I have written foreign body, right? So how do you know this is true? Now, what would happen in OSCE is, okay. So what would happen in OSCE is, I would show you for another slide. There, even the evidence is going to be reviewed. And so, the most cited systematic review on this, it is going to be discussed with amongst the examiners, and they are going to show that, where the exam is conducted, these are the 3 common causes. So that's how it is going to be objective. Okay. Say patient had normal findings. Remember the question, right? An auscultation, we could hear, those lung auscultatory sounds at the right 5th intercostal space, right? So what is your interpretation? So here you can either write, coarse crackles during both inspiratory and expiratory phase, or you can choose to, elucidate. So because, when we are doing clinical examination, it is not really sufficient to just say coarse crackles. You're supposed to say whether there's a continuous sound or a discontinuous sound. So coarse crackles, usually they are discontinuous, non-musical, explosive sounds, which you have to then say the extent. They are both inspiratory and expiratory. Then you're supposed to say whether they change by any maneuver. So, there is change during cough or not. And finally, you're supposed to say whether it's transmitted or not. Because, one practice, though it's not very common, a lot of people do it, is auscultate on the mouth. So if you auscultate on the mouth, coarse crepitation, which are emanating from the airways, which are coming from the airways, they might be better appreciated. You compare that with fine crepitation, which are usually coming from lower down. So if you're auscultating on an open mouth of the patient, now you can try it and you will get it. This is not something which is bookish, but if you auscultate on the open mouth of the patient, you can actually get it. So what I'm trying to say is, lung sounds for OSCE, probably you can write coarse crackles. If you have said what is your interpretation, you can also choose to describe it under the heading which I just said. Describe the sound, which phase, where it is, how it is changed by maneuver, and where it is transmitted. So that makes, that makes it more scientific. Okay, which lobe? I mean, I think people must have got it. So if you know the major fissure and the minor fissure, you would actually know the you would actually know the where it is. So major fissure comes from T2 along the medial border of the scapula to the fifth rib at the mid axillary line, and then finally it moves on to the 6th rib at its costochondral junction. So this is a picture from Google which actually show you that. And minor fissure, as simply from the major fissure in the mid-axillary line, you draw a line which is horizontal to the fourth costal cartilage, right? So anything, so obviously it is fifth, it means it is below fourth. If it is below fourth, it is supposed to be right middle lobe, right? Okay, so this is simple. What do you think the sound is due to? I think you must have all got it. It is obviously due to bronchiectasis, clubbing and coarse crepitations. And the patient is giving history of wet cough for a long time. So you think about bronchiectasis. So what are the common causes? So here I'm saying that, the examiners, when they discuss it among themselves, I'm not sure whether it's projecting properly, they would actually see the evidence. So, this is from the Embark registry. You can see the most common causes are post-tubercular, post-infective, right? ABP is also there. And finally, here it is tuberculous, post-infective, ABPA, right? So these are the common causes. So yeah, right. So tuberculous, post-infective, ABPA, and you can say idiopathic. These are the 4 common causes. The patient gives a history of brownish colored sputum, right? So I'm not sure whether you guys have seen it during clinical practice. So if you have seen it once, you will not forget. So it is ABPA. So which investigation would seal it? I'm sure you must have got it. It's HRCT thorax. In fact, the next question kind of gave away the answer to the first question. If you're talking about the features, which features are you supposed to look for? So we look for the signet ring sign, that is the airway to the arterial ratio. We look for non-tapering of bronchi. And finally, what we look for is, if you can see some airways within close to the pleura, we say it's bronchiectasis. So CT scan, I mean, you're also supposed to, it's not by rote. If you have seen a CT scan, you can also, identify it, or you can write it down. Right, so this is just showing the CT scan of the patient. I mean, this is the right middle lobe, and this is bilateral, just to show you, I mean, the signet ring sign. So if you can see somewhere over here, you can see a vessel and the dilated airway. So the airway to the arterial ratio is more than -1.5, much more than that. So it's bronchiectasis. Okay, so I think here, where a mistake has happened. So FVC is normal, the FE1 is normal, and the F1 FVC ratio is normal, and the TLC is also normal. So the answer here should be, it should be normal, right? So it should not be non-specific ventilator defect. So what is non-specific ventilator defect? Would anyone of you venture a guess? What is non-specific? So if you guys are reading Hyatt, as far as pulmonary function test is concerned, they talk about a non-specific ventilator defect. So what is that? What is that is FE1 is reduced, FVC is reduced, ratio is normal. So what is that going to? It's probably restrictive, right? But what is the hallmark of restrictive lung disease? It is TLC. TLC is supposed to be reduced. But you combine this with normal TLC. So what I'm saying is FE1 is reduced, FVC is reduced, and the ratio is normal. So it cannot be obstructive. So you're thinking, oh, this has to be restrictive ventilator defect. But you do a TLC and you see normal total lung capacity. So restrictive is out, because the hallmark of obstructive ventilator defect is a reduced FE1 FVC, and the hallmark of obstructive is reduced ratio. Hallmark of restrictive is obviously a reduced TLC. If there is normal TLC, it cannot be restrictive ventilator lung defect. So this is what is called a non-specific ventilator defect. Neither obstructive, neither restrictive, somewhere in between, right? So what are the common causes? So the common causes are seen to be, some conditions like, say, bronchiectasis can give rise to that. Asthma with obesity, it can give rise to that, right? So these are some of the conditions where you might get a non-specific ventilator defect. So good to know. But the answer to this is wrong. I'm sorry about that. Which is this test seen? So this is what we call HSVM. What is HSVM? High speed video microscopy. I'm not sure whether you guys do it. HSVM or HSVA, high speed video microscopic analysis, where you actually take nasal scrapings and you see it on the microscope. So our patient had beating cilia. The patient which I showed, on the bottom did not have beating cilia. So the patient has, what is the reason for bronchiectasis? The patient also has infertility. The patient also has, so primary ciliary dyskinesia, right? So within primary ciliary dyskinesia, if the patient has, beside bronchiectasis, rhinitis, sinusitis, and infertility, and situs inversus, then we call it cardiogenic syndrome. So so PCD, that is primary ciliary dyskinesia, is a big circle within which a small circle is cardiogenic, right? So if you're suspecting young patient, normally these patients present very early, first decade. But if you're suspecting, then what we'll do is, so any patient, 20s, patient with bronchiectasis, no definite history of tuberculosis, we would do this test done. We would get this test done, sorry. Okay, so the interpretation is normal. And within airway clearance technique, so normally what we see, patient has bronchiectasis, you know, go and have lung physiotherapy done. But you're also supposed to know the basic tenets of, lung physiotherapy. So which is, ACBT. ACBT is active cycle of breathing technique. So normally what happens, there's 4 stages: breathing control, deep breathing, forced expiration, which we call huff, and finally coughing. So why is it done? To dislodge the secretions and to take it out. So this is something which is very commonly done. A lot of centers, they have this printed video. So if you would go to the Oxford site, they would have this video there, and they would give this video to the patient and they can just see it and learn it, right? Okay, so ACBT, right. So that concludes the discussion. Are there any questions from the audience regarding this? Sir. No. No. So it was this inframammary. Was it infraclavicular? Okay. So I apologize for that. So there has been actually multiple versions to our PowerPoint presentation. So it is anteriorly, as I said, it is inframammary, and it's in the right 5th intercostal space anteriorly. Right. So, yeah. Right. Sir, I mean, thank you for your question. But sir, even ABPA nowadays, what we normally do is we classify into ABPA-S and ABPA-CB. So ABPA-S is ABPA serological, and ABPA-CB is ABPA central bronchiectasis, where we are seeing that the end organ damage is happening. So, so normally when in our clinic, what happens is, an ABPA patient, we have to, at baseline, we always get a CT scan done. So my question was from that point of view, if there is end organ damage, then you have to up the ante and you have to continue steroids and or azole for possibly a longer duration to ensure, because the end organ damage has started to happen. The patient is having bronchiectasis. Very quickly it might so happen that the bronchiectasis might progress. So here your vigilance would be much more. Please. Please. Right? No. So you're right. So I mean, what I wanted to say, 3 common causes of clubbing. So again, no. So young patient, we are not thinking about bronchogenic carcinoma. So this was. I mean, here what normally happens in OSCE, you have to be very careful what you're showing. So it was actually not in the context, because this is a made up case. This is not really a true case. So you can understand, I'm moving from ABPA and I'm moving to HSVA. You're right. So it's not that I'm talking about a particular case. So my intention was to, to just ask you about the common causes of clubbing. Madam. Right. No, so again, this patient did not have cardiogenic syndrome. This patient did not have ABPA. My aim was just to introduce the topic of HSVM, because suppose, as I said, OSCE is about interpretation. So suppose you get this video, and you're told to interpret. I mean, not you, I say, suppose our esteemed residents or postgraduates, they're told to, so they must be knowing that this is HSVA, right? So here I'm not thinking about bronchogenic carcinoma. Here I'm not thinking about ABPA. Here I'm not thinking actually about a cardiogenic syndrome. This patient was not a case of cardiogenic syndrome. Any other questions? There must be some questions. Yeah, right. Yeah. See, I agree with you. Then, I admitted it when I was presenting that, the second part actually lets you into the answer of the first part. But again, I was not sure that if I would just have said that, once you're diagnosed, how do you diagnose that condition? I just wanted to test because this is also a kind of a quiz where we are going to mark it, right? So our aim is to see whether the candidates know the features of bronchiectasis. So that is what it is. But it's a nice point because, when you're making osteo, you have to be absolutely clear that the subsequent points do not divulge the answer. But I'm sure I could see a lot of people writing the answer of the first part after they've seen the second part. So that would normally not happen. Yeah, absolutely. Yeah, absolutely. I accept that. Absolutely. Okay. Any other points from the someone? Come on, you guys must have picked no, this doesn't match. No, this doesn't make sense. No comments from the postgraduates. Come on. I mean, sure. You want to say something, please? You're not able to see the causes. Bronchiectasis, you mean, right? Right. No. So if I'll talk about the causes of bronchiectasis. What I told you is, so if you can write anything, you can write idiopathic, right? But the point is, I just give you reference for that in the Embark registry. So here you're also supposed to use your theoretical knowledge. Embark registry, have you read it? If you have not, just read it. It's from, this part of the, somebody from this part of the world. And they have described pan-India kind of, not all the centers were included. So there they have said, this is the most common thing. This is the second common thing. So somebody can code this and write, this is the key, right? So what I'm saying is, this is supposed to be objective. How it is objective, I'm just letting you into that. There is an article which quotes, these are the commonest causes in India. So nobody can, raise questions regarding that. Does it make sense? Any other question? Okay. So we start the second, case. Right. Okay. So a 30-year-old man present with insidiously increasing shortness of breath over 8 months. That's the history, right? Okay. Examining the patient, right? BP is normal. Pulse rate, there is no tachycardia. There is no tachypnea also. Respiratory is 20. And saturation, it is lower side, right? So you see this. So I need you to interpret this. It's very simple. Come on. Patient, the patient is having low 88%, and the patient is lying down. The patient is having 94%, right? So what is it? And the patient is also complaining of increasing shortness of breath when he's sitting up. So there's not really heart failure, because heart failure is the other way around. So Dr. Kundu was talking about decubitus. So the patient is saying, I'm sitting up, I am feeling breathless, and I'm lying down. I'm more comfortable, right? So what is the cause? So what is the condition that we're talking about? Come on, it's very easy. Okay, so I hope you have got it. 5 more seconds, right? So the answer. So the question is now. Actually, your time starts. So what is the condition called, and how do you objectively define it? So condition called. I am sure you guys have written it. This is the condition. Now I also want you to say that how do you define it, because somebody would say this is this type of decubitus is this, but there has to be a definition. Suppose it was 94% and 93%, 94% and 95%. So if you know it, it should take again 10 seconds. If you don't know it, then there's an opportunity to just go through it once. Okay, fine. I think you have got it. Okay, so I've kind of, let you on to it. So what are the common causes of platinum orthodeoxy syndrome? So the previous one was POS. So what are the common causes that you know of? So I need you to write 1, 2, 3. I hope you have got it. Okay. What more? The patient had this finding on lung auscultation. So, I mean, you can understand, right? You can hear something. It's definitely not it's not a musical sound, right? It's a non-musical sound. And you're auscultating the lung bases, and you're getting this, you're hearing this. So if you know it, so if you have to think about the causes of platinum orthodeoxia, because this patient is having this, I've already told you that, and lung auscultation, you're getting that. So what is it? Okay. So just to right. So here it is what we are seeing: inspiration, expiration. So it is towards the latter part of the inspiration. Right. So describe it. What is your interpretation? This is the third question. So did I get it wrong? So this is 1 second. What are the common causes I told you? We heard this, right? So this is question 3. Describe it. Right. So 4, 5 words. This is, I don't know, non-musical. This is this. And what do you think this sound is due to? Right. So 5 more seconds. 10 more seconds. Okay. Right. Okay. Right. So if you would see, so you heard the sound as well. So what are the differentiating points? So I try to sound out the 2 different type of these 2 entities, that is fine and coarse. Just the points. How do you differentiate it? Think about what you do in clinical practice. What would you do? 1, 2, 3, 4. Right. Okay. As a continuation of this, if there is a plural rub, how do you differentiate? Again, 1, 2, 3, 4. So this sound is not, coming as neatly as it should have, but this is what a plural rub sounds like. So this is from an article in NEJM in 2014, written by a very famous Jewish doctor from Israel, who has worked all his whole life on lung sounds. So right. Okay. So right. So coming to the next, did I get it right? Yes. Question 5, question 6. Okay. So what are you doing is, now you remember this patient, right? I'm talking to the same patient. This patient had some thin lung bases and you were able to hear it. And what you're doing is now you're auscultating on the posterior aspect at the T5 level of the vertebra, T4, what happens is a T4, if you remember, what are the anatomical landmarks there? Just below that T5 level, you're hearing something. थोड़ा सा तेज कीजिए इसको, I think. थोड़ा सा कम. So you can hear a harsh sound, right? I'm letting you into it. You can hear a harsh sound. So you're auscultating, Right. Okay. So what is the possible reason for that? So this is something that we, it's not very common, but it is something that we read about and sometimes we find it in the clinical practice. I just want to know whether you can put it all together and you can tell me what this is. It's possible reason, if you know it, 5 seconds. Fine. Okay, so this is very simple. Common causes of fine, you all know this is MBBS stuff. Come on, 5 common causes. 1, 2, 3. Okay. Okay. So suppose you're talking about a patient of interstitial lung disease. Apart from the crackles, what other findings would you look for in the examination? This is my question number 8, right? So, interstitial lung disease, normally what we see is we look for typical lung sounds. But what else in the history? So you think about a patient with interstitial lung disease, what else do you think? What do you see in the general examination? 1, 2. What do you see in the respiratory examination? So 1, 2, 3, 4, just think about it. I mean, just picturize the last interstitial lung disease patient you have seen, advanced perhaps, and what are the points that you have seen in that particular patient? Yeah, okay, great. Okay. So look at this page. So now you guys are conversant with Z-score, right? Okay. So FVC, 2 liters, Z-score of, on the other side of minus 1.65, FEV1 1.2, less than 1.65. FEV1 FVC ratio is also decreased, right? And the TLC is also, Z-score is minus 2.65. So ratio is, it's less, and the individually FVC, FEV1 and TLC, all of them are less. So what is interpretation? Whether it's, of the PFT, whether it's obstructive, whether it's restrictive, whether it's non-specific, whether it's normal, whether it's, I don't know what. Right. Okay, if you have got it, I think 5 seconds, just if you know it, you have to just write 5-lettered word, that's it. Okay. So my next question is, which condition cause combined restrictive obstructive ventilator defect? So if you can remember for your clinical practice, 3 causes, 1, 2, 3. These 3 causes, these 3 conditions, they cause combined restrictive obstructive ventilator defect. So 10 more seconds for that. We're talking, please. Right. Okay. Very stuff. You get an X-ray of the same patient, say, and these are the 2 or 3 points that you're seeing. So you remember that patient, right? Who had problem in, sitting up, lying down. And this patient had, these findings on chest auscultation. That same patient, you got a chest radiograph done. Right. Similar vein, what are the chest CT features? So I've given you a lung window and I've also given you a medicinal window. So parenchymal window and a medicinal window, both. So look at the parenchymal window, it's on the left, obviously. And on the right side is the mediastinal window, right? So 1, what is that? 2, what is that? And you also remember this patient, right? This patient also had that lung finding, on auscultation on T5. So it's got something to do with this. Right. So 5 more seconds for that. Right. So I think that's it. So that's my last question, case number 2. So madam, may I request you again to collect the papers once again? No last minute discussions, please. The first row. Sure. इसके बाद फिर मुझे लगता है एक और केस ही हो पाएगा, एक ही और केस हो पाएगा. आप मैडम right? We got it all. Thank you. Right. So quickly, we have one more case. So quickly the answers. So I'm sure you must have guessed it. This is a POS. So how do you define it? So if you don't know it, you're supposed to know it, right? Because it's not simply platypnea. There's a component of, orthodoxy as well. So you define it by saying that saturation drops by 5%. And if you're doing an ABG, there would be a difference of 4 millimeter of mercury. So you need to know this. Okay, what are the common causes? Again, most common cause is cardiac, right? So this is the reference. Most common cause is cardiac. So cardiac, these are the common causes. And within, lung, most common cause that we see is usually HPS, hepatopulmonary. I'm not sure whether you guys see it in your respiratory ward, but medicine ward, patients have liver disease. And they have these features, and they also complain that I'm fine when I'm lying down, but when I sit up, I have this problem. Okay, and we have also reported a couple of cases with COVID-19 and ILD. Also, we have reported, and it's there. In the literature, yeah, it's there that interstitial lung disease can also cause platypnea, Yorkshire syndrome. I'm not going to the mechanism. Very easy to understand. So any disease which predominantly involves the basal region. The same thing happens as in HPS, and there is a problem when the patient sits up. So those shunts, they are exposed, leading to hypoxia. Right, fine. Okay. So here, it was typically, Velcro crackers. I'm sure you guys must have guessed it from the sound or from subsequent questions. So as I was telling you, again, if somebody wants the interpretation, it should be non-musical, short, explosive, phase of inspiration, how it is affected by cough or gravity, and transmission, whether it's transmitted to the mouth. Right. So how do you differentiate? Again, these are, kind of theoretical, but when we are hearing it bedside, this is what we do. So hearing during mid to late expiration, fine crackles. So the position important is altered by body position. Coarse crackles, it is, changed by coughing. And again, as I was telling you, coarse crackles, it can be transferred to the mouth because they are more, they are originating from more proximal part of the airways. Fifth question, how do you differentiate? Again, pleural friction rub. I think, I think we all know it. Probably we don't listen to it a lot because this finding is transient. But if you have listened to one, it's a scratchy sound, biphasic, no change after coughing. And, if you are pressing it with the stethoscope, it might disappear. And the patient might have tenderness there. So these are the points you're supposed to write. Okay, so this is, I don't know whether you guys have written this. So it's a bronchial breath sound. It's a harsh lung sounds which you could hear. So bronchial breath sound would do. And you're hearing it on the back. So it was actually a DS spine sign. Right. So I think you guys know what a DS spine sign is. Come on, we have read it. But if you remember, this patient had, from the CT scan, I'll just show you, had a huge subacral lymph node, where you would probably would not require an EBUS to get the diagnosis. What you need is, you need to, if at all, you can do a conventional DNA. Okay, so what are the common causes? So this was about, if I remember correctly, I'll just see it once. Fine crackles, we are talking about. Fine crackles, right? So these are the common causes of fine crackles: resolving pneumonia, evolving pneumonia, resolving pneumonia. You can see it, besides pulmonary edema and ILD. Right. So other findings that we normally see, if you're getting Velcro crackles, we look for clubbing if you're not picked it up in the general physical examination. Some cases there might be squeaks. Right. So I'm sure, I don't know whether you guys must have. So squeaks. So, short musical sound, which is, mainly inspiratory, generally accompanied by crackles, right? So this is what a squeak is. There might be, other features of cor pulmonale. So I want clubbing. I want, you can write squeaks, features of cor pulmonale, if it is complicated, and features of underlying disease. What underlying disease? Again, this, if it is, so if it is ILD, you look for features of underlying CTD. So whether it's scleroderma, dermatomyositis, rheumatological condition. This is theoretical. I'm not going to that. Okay. So here again, as I kind of told you, everything is decreased. Right? So here again, the interpretation is wrong. So, everything is decreased, even the ratio is decreased. So it should be mixed ventilatory defect. I'm sorry, here, interpretation is wrong. Right? So everything is decreased, even the ratio is decreased. Okay, which condition causes combined? Again, this is a staple question. Sarcoidosis, HSP, bronchiectasis, post-TB sequelae. Right, so you got this. This is easy. X-ray, come on, this is a case of ILD who had predominantly basal involvement. So you're supposed to write linear reticular shadows. There's an apico-basal gradient, and probably the mediastinum looks a little enlarged. CT features, so you're supposed to mention the features of ILD. So, so ILD, writing ILD won't do. So increase interlobular septal thickening, right? You can see some amount of GGOs, some amount of stacking of cyst, suggesting honeycombing. And I think you must have got it. That is the mediastinal lymphadenopathy which I was talking about, giving rise to the DS spine sign. Right. So this is again theoretical. So that is it. So any comments about this? Any comments, sir, about this particular case? Any comments on the, because we have one more case and I think we have 8 minutes to finish it. If there are none, then we'll move on to the next case. Right.
Thank you, Animesh. And Dr. Animesh has done my job a little easier because by this time, everybody who is in the audience, be it our senior colleagues here or the students who are writing answers, have understood what we have done. What we have actually done is construct, each case may not be classical one, but based on our experience, we have constructed a clinical case. So necessarily the first one was a case which depicted in history and findings, a case which has parenchymal involvement, right? The second one, which Dr. Animesh has shown you, is a typical case which shows, which has interstitial lung involvement. I'm not going to label a particular disease. And that is how, when you are examining, I'm sure Dr. Kundu, Dr. Gupta, and Dr. Sarkar also, they all, whenever they go and examine the patients, before you are allotted cases, what is done is, they would see that each student is examined in different parts of the respiratory system. So you will get one pleural case or one airway and a combination of interstitial or a parenchymal or a case of say mediastinal widening or other syndromes or associated with the presentation of malignancy or a lymphoreticular involvement. So this is how the cases are chosen, and that is how even we have selected and tried to create a scenario in, and we have tried to follow the course. यानी आपको कौन से flow में questions पूछते हैं. That is what we are going to do. What most of the time happens in PG activity are 4, 5, 6 teachers are sitting together. So everybody will ask a random question to you and you start getting confused, or we try to answer each end. What we are trying to tell you is the importance of going in a very methodical way when you examine a case. The first is history taking. Then in history taking also you would ask some questions either to support or to rule out whatever are the thoughts which are coming in your mind about the disease, and then about a very systematic examination of general examination, the respiratory system, then the various investigations which are needed. And each of the question that we asked is actually an OSCE station. यानी एक छोटा history लिखे आपको पूछ सकते हैं depending on the history, what is your suspicion, right? 1, 2, 3, 4, right? Or this is an ABG, write your findings. This is a ECG, what is the abnormality or what is the condition? So the answers would be many times a single word or a single sentence or only 2, 3 words. That is how the objectivity is defined for a particular scenario. So I'll go now ahead with the other case scenario which I have. And this is a 60 years male who presented with history of gradually progressive breathlessness and cough with expectoration since 3 years. He has increased symptoms since last 3 days when he came to us, and he also gave history of audible, something like whistling sounds, right? So the question is, what other things you will ask in the history? You can start writing. What other things you will ask in the history? Shall I go ahead? Okay. Okay. Shall I go ahead? Okay. On general examination, the patient was fully conscious, oriented, afebrile, had tachycardia, blood pressure was normal, respiratory rate was increased. The saturation was 84 on room air. Respiratory rate was also increased with use of accessory muscles. Then he had bilateral lower limb edema feet. He did not have pallor, icterus, clubbing, lymphadenopathy, cyanosis, and his JVP was raised. So the question is, which is commonly asked are, name the accessory muscles of respiration. Have you finished? You should be able to write at least 3. Whenever such question is asked, you should have some objectivity. So do not, if you remember 3, 4, you just tell what you remember. Do not try to collect and bring all muscles into respiration. Right? Okay. So with this history and whatever the examination findings which I have told on general examination, what could be the most probable diagnosis in this patient, and are there any differential diagnosis? So if you feel that there is one diagnosis, write only one. If you feel there is a differential diagnosis, write in the order of probability that you feel, which fits with this history and general examination. Shall I move ahead? Yes. What does this picture show, and what is the physiology behind this? So you have to answer only one question, that is, what does this picture show? This is something which I did not write purposefully in the general examination. Shall I go ahead? It's a single word answer, and that is how we are trying to make each question very objective. A question, a answer. Okay. Now, when we examined the patient, we went ahead with the respiratory system examination, and on inspection, this is what the patient is. Can you label the type of chest in this patient who had this history and examination findings? I agree, for few of us, this may not be a very classical picture. Shall I go ahead? It's a single word answer. Then when we examined in inspection, we found this, right? The upper picture is on inspiration and the other one is on expiration or at stable speed. So what chest sign is being shown? Single question, single answer. If you can identify, you write. If you cannot identify, write the question number and keep a blank. Question number nikke blank rakh do, so that there will not be any confusion later on for the question number, right? Then when we examine the patient, what is the normal cricosternal distance is the question. I remember when I was listening to Dr. Kundu, he categorically explained to you where is the cricoid and from where you should start counting or examining. Right? So this is very important. And what is the normal cricosternal distance? Okay. Shall I go ahead? Yes. When we came to percussion, the percussion note was, the first point is written last, so I'll read that. Bilateral hyperresonant note on both the sides. Liver dullness was in the 7th intercostal space on right. The trop space was on the left side, very faintly heard in the 7th intercostal space. And right heart border was retrosternal. On auscultation, breath sounds were decreased bilaterally. There was polyphonic expiratory V's on both sides, and vocal resonance was equal on both the sides. There were no other adventitious sounds like crepitations or pleural rub. Right? So the question is, with this, what are the causes of V's? And Polyphonic wheeze is heard in cases of the various etiologies or underlying diseases. Shall I move ahead? And with this, we come to the question, which is, what is the final diagnosis based on history and examination of the patient? Is it done? Everybody has written? Don't change it. Now the question comes, which has already been discussed, is what is this? Is it commonly, don't write the answer. Whenever there is no question number given, don't write the answer. You write answers only for question numbers. Okay. So what is this? Is it commonly seen in COPD? And if it is associated with COPD, what are the causes? Okay. We'll be discussing each and everything again. Now question 11 is, what are the X-ray findings? I'll give you 5 seconds to write because it's very easy. I think you must have seen at least 100 such X-rays, if not less. Could you write? And in the same patient, these are the CT findings. Can you see? If you can't, it's, I think the onus is on me that the CT should be more explanatory, better visualized than what it is being shown. Shall I move ahead? Okay. What is being seen in this patient and what is the significance of looking for this? Is it significant? Why? So you just write what is being seen. We will discuss what is the significance later on. Then these are the ECG findings in this patient. So what does ECG show? Can you see? दिख रहा है? Not able to see? Can you see? If you say yes from that corner, then students must be able to see from the center seat. So thank you for that. Okay. And then what is the PFT finding? Is the real time, huh? And then we come to we'll come to the last question. What are the ABG findings, or what is the diagnosis based on ABG finding? Right? I hope you can see. You don't have to make many calculations because history and everything is given. You have to look at what is visibly seen in this report of ABG. Is it done? If the answers are written, Abhishek, can you arrange to pick up the answer sheets? Yes. I know everybody is waiting for, because we had postponed your presentation. I'll just take a quick recap of answers and finish off, right? Okay. Everybody has given, please write your names and hand over the papers. You can help even passing on the papers from one end to the other to make it very quick. So with this history, general examination, the examination of respiratory system, as well as the reports which we have had of chest X-ray, CT, ECG, and ABG, what is the final diagnosis? The final diagnosis is COPD, or chronic obstructive pulmonary disease, with exacerbation, with cor pulmonale, with type 2 respiratory failure is the complete diagnosis. Okay, so the first question was, what will you ask in the history? And it's important to ask for history of hemoptysis whenever there is complaints of cough, loss of weight and appetite, because he had complaints since a long duration. Is there any seasonal variation? Is there any change in voice, prior hospitalization, visiting the emergency rooms? Has he received nebulization or any other rescue treatment anytime? What was his occupation, comorbidities, and above all is a smoking history, which should be very complete with the duration, the number of cigarettes, and so on and so forth, because you will be asked further questions based on this history. The answer for accessory inspiratory muscles are the sternomastoid, and the whole list expiratory are abdominal muscles. But in fact, when a patient is breathless, probably he takes help of each and every muscle, though they are not labeled as accessory muscles. He even would take help of his shoulder girdle also to help him assess the respiration. Then the third question was, what could be the most probable diagnosis? And it can be, the first though we say COPD, it can be asthma, it can be COPD, it can be underlying CA lung with all this history, and of course interstitial lung disease. Then the picture of that man who was blowing with the lips was pursed lip breathing. I know you must have thought of sneezing, blowing, deep expiration, pursed lip, but pursed lip breathing is the answer. And why it is so, I personally call pursed lip breathing as a physiological NIV, okay, or physiological positive pressure ventilation, right? Because it increases the airway pressure by tightening the lips and prolonging the expiration, as well as causing a passive pressure over the airways. It prevents the small airways from collapsing and closing and reduces the functional residual capacity. It allows time for oxygen transport, as well as more CO2 to be exhaled also. And it is a feature of emphysema that you have to always remember. Then the shape of chest was barrel-shaped chest. I have already apologized that the picture may not be very ideal, but this is how you measure and recognize a barrel-shaped chest, where the AP diameter is more than the transverse diameter. And you have to know at which site you have to measure, how you have to measure, and how you have to see for lung expansion, because expansion would be reduced. Then the other sign, when the patient was lying flat and you could see the intercostal spaces which had become prominent, was the Hoover's sign. And it is best appreciated by placing the first and second fingers on the costal margin near the anterior axillary line. And I'm not going to define the lines. Dr. Kundu has already defined and shown you where these lines are. Hoover's chest sign develops due to inward pulling of the lateral rib cartilage by the flattened diaphragm. And that is why it is seen. Then the cricosternal distance, which we mentioned, is the distance between the inferior border of the cricoid cartilage to the upper border of the sternum. Remember, it has to be measured with the patient's fingers and not your own fingers. Patient fingers are important. Normally, at least 3 fingers should be the distance. It would decrease in patients of COPD. Why? Because yes, the rib cage moves as a whole upwards and the trachea is being pulled down for all practical purposes. Then there would be questions whenever it is there would be other questions about the single breath count and the forced expiratory time. And what is important in forced expiratory time is that you measure it with the bell and not with the diaphragm. Then differential diagnosis of wheezing, you can have intrathoracic, upper airway, either tracheal stenosis or all other pathologies which would cause obstruction to the airflow. There can be intrathoracic lower airway involvement like COPD, asthma, then even in bronchiolitis, heart failures, and a long list. And extrathoracic can be vocal cord pathology or laryngeal stenosis. And many times such patients do not only have wheeze, but those who have laryngeal pathology will present with stridor. It is more noisy and it has, I don't say musical, but thoda sa usme, whenever it is at the level of larynx, it's as if the sound is gurgling through the fluid. And whenever a patient of stridor comes, you can make out from the door. Then monophonic wheeze is generally due to obstruction or compression of a large or central airway, and it is at a single site. Whereas polyphonic is more likely heard in the setting of diffuse small airway obstruction or compression. Then the answer, which when I showed clubbing, was clubbing is never associated with COPD, but whenever clubbing is present, you should think whether there is underlying bronchogenic carcinoma, ILD, fibrosis, or other chronic lung infections like bronchiectasis, lung abscess, or empyema, and this can always occur. Then the commonest finding, there is a long list of radiological findings, but the most important which you should not miss are signs of hyperinflation where more than 6 anterior ribs or more than 10 posterior ribs are visible, flattened diaphragm, tubular heart, hyperlucid lungs, and costophrenic and cardiophrenic angle becoming obtuse. Then the CT showed centrilobular emphysema. Pedal edema has to be seen in patients of COPD because it indicates right-sided heart failure, or what we term as cor pulmonale. It develops as a result of pulmonary hypertension. It's actually everything is going back, right? And the ECG showed findings which suggest cor pulmonale, where you are seeing P pulmonale, right bundle branch block, and S wave is of a longer duration than the R waves. Then in the PFT, you could see that it was typically of COPD where FEV1 FVC was less than 70%. FEV1 is also used to classify the severity of COPD. Why I've said this? Because this question may be asked in this particular scenario, and DLCO will be reduced. And the last answer for the ABG which you have seen is during stable disease, PaCO2 may be more than 60 and bicarbonates more than 30, which says that this is a COPD with a case of COPD and the patient is retaining carbon dioxide. But when patient comes to you in exacerbation and you look at the PAH and the other findings, then you would label them to be having a type 2 respiratory failure. Other questions which can come up is what is the normal single breath count? What is the normal forced expiratory time? Demonstrate, because this is a clinical examination. So demonstrate, how do you look for single breath count? Demonstrate, how do you see for FET? Measure in a particular patient and tell. And that is what you are supposed to know, practice, and demonstrate. And remember, many times what happens, there are signs which you don't come across, so you don't demonstrate. Do not think that only positive signs are to be elicited. Even negative signs have to be elicited. For example, single breath count may be normal, but we don't see usually in patients of COPD, or you don't look for post-expiratory time also. And that is all that I have. That's it. Thank you. I have overshooted time, so I'm not going to take the next case. And that, as it is, you are going to have a case on pleural effusion, so it will be discussed later on. Thank you. Yes, at that time they didn't have. Plain and simple COPD is not associated with clubbing, but there may be other reasons which give rise to COPD. So thank you everyone, and have your cup of tea and relax before the next session of exam starts. And we are sure this methodical way will help you to score when everybody will be taking and judging you for the examination.
হচ্ছে। Now, for appearing for the emergency cases, all candidates will have already passed the part 1 emergency written examination within the previous 7 years, and most will also have sat and passed the part 2 written examination, although this is not mandatory before a case is attended. And all will have had their readiness to sit endorsed by a proposer, usually the candidate's current or most recent education supervisor or more recent supervising consultant. Most centers usually examine 15 candidates per day, and there are 5 stations, each lasting 20 minutes. 2 examiners assess each candidate at each station. The passage of 5 candidates through the carousel of 5 stations is known as a cycle of paces. And station 1, 3, and 5 are divided into 2 separate patient encounters. Station 2 and 4 each contain 1 patient encounter. A total of 8 patient, therefore, encounters occur. There is a 5-minute interval between each 20-minute station, and start and finish of each station is clearly sounded by a bell. The carousel of 5 stations takes about 125 minutes to complete, and approximately that takes around 2 hours. Station 1 is usually physical examination, respiratory and abdominal. Station 3 is also physical examination, cardiovascular and neurological. Station 2 is history taking, that is interaction with either a patient or a surrogate. Station 4 is communication skills and ethics, which is also an interaction with either a surrogate or a patient. Station 5 is pretty tough, where there is 2-patient interaction with this integrated clinical assessment, where you have to take a history as well as clinically examine, which is different from station 1 and 3, and station 1 and 3, as I said, is just clinical examination. Now, at this point of time, you should know that which are the most important parts of each of these stations. Now, for timing, for 20 minutes each station, for say station 1, respiratory and abdominal, 1 respiratory case patient interaction, examination, and abdominal case examination 6 minutes, and examiner interaction is 4 minutes each. And that is same for station 3, cardiovascular and neurological, 6 minutes each, and 4 minutes of asking questions by the examiner. History taking, where there is interaction with the patient or a surrogate, is 14 minutes patient interaction, 1 minute of reflection, and examiner interaction is 5 minutes. Communication skills and ethics, similarly, 14 minutes patient interaction, where you don't need to touch the patient. 1 minute reflection, and examiner interaction is 5 minutes. Now, station 5, brief is 2 cases, which includes clinical examination as well as history taking. This is patient interaction is 8 minutes for each, and examiner interaction asking questions is 2 minutes each. Now, the station 2, 4, and 5 is virtually candidate finishes and they can ask questions, and if they have finished before time, they can think about it, they can reflect. Station 1 and 3 is appropriate when you finish 6 minutes, your questioning time starts. And it is important that these are the 7 course clinical skills are assessed in the PCS examination. A, B, C, D, E, F, G. A is physical examination, where you're expected to demonstrate a correct, thorough, systematic, and appropriate, fluent, and professional technique of physical examination. B is identifying physical signs which were correctly and not finding signs which are not present. C is clinical communication, elicit the clinical history relevant to the patient's complaint in a systematic, thorough, fluent, and professional manner, which is in station 2 and 4. D is differential diagnosis. We create a sensible differential diagnosis for a patient and management for and number E is clinical judgment, select and negotiate a sensible and appropriate management plan for a patient relative or clinical situation. F is managing patient concerns, seek, detect and acknowledge patients and address patients and relatives concerns, which is in station 2 and station 4 and sometimes station 5. And lastly, G, which is maintaining patient welfare, treat the patient or relative respectfully and sensitively and in a manner that ensures their comfort, safety, and dignity. And each of these skills are receive marks as follows. Satisfactory is 2 marks, borderline is 1 mark, unsatisfactory is 0 marks. That is, if you have you've picked up signs which are not there, you're likely to have unsatisfactory. If you come out with a differential diagnosis which does not fit in with the underlying diagnosis, then this is unsatisfactory. And the underlying diagnosis is usually set before the start of the examination by the 2 examiners. Then this is for calibration before the start. And the 2 examiners clearly set the questions that are supposed to be answered and which questions are rightly should have the answers and which answers should be expected. Anything beyond this is, and if it is not fitting in with the picture, suppose there's a mitral regurgitation murmur and you pick up a mitral stenosis murmur, or if you don't pick up a murmur, that is unsatisfactory. Say, for example, if you have a neurological case and if you don't pick up paraplegia and you ask the patient to walk and to see how good is the gait, then it's unsatisfactory because the patient has paraplegia and cannot be walked, cannot be taken for an ambulation test. So these are important. So each of these marks for each of the skills A to J are separately summed up, and therefore you then get a total number of points. So the maximum for the total test score is around 170 and minimum is 0. So candidates are required to attain a minimum standard for each of the 7 skills. I hope this will give you some guide about immersive paces. And if there is any further questions, I will be happy to answer later. Thank you for being there.
We have one more video about the USMLE. Yeah? One more video is there. No?
video আছে গো চলো দেখো ঠিক আছে
Good evening, everyone. I'm Dr. Kolkata, and I'll be talking to you all about preparing for USMLE examinations. I'm very thankful for the organizers to give me this opportunity. And over the course of this presentation, I would like to convey various aspects of applying for postgraduate education. The very first step in this process is to apply for ECFMP application number. And you have to go to the ECFMP website. Your medical college needs to be the director of the medical school. Database of medical colleges that are registered and all that out. And then you need to give verification of your credentials from the medical college. So if you have your ECFMP number, go ahead and register for step on examination. This would test your basic sciences as person taking a basic exam. You can give this test after you have completed your second MBA. It would take about 6 months to prepare. You can give this test in India. It would give 8-hour-long test, and there are 7 blocks of 48. It used to be a score, but now that's changed to just a pass, fail, or go. Step of clinical skills will check your pre-final and final MBBS subjects. It can be given only after you have passed your final MBBS exams. You would need about 3 to 4 months to prepare for this one. Scheduling registration is very much similar to step 1. It's 8 blocks here, 8 MCQs each, to like total about 9-hour-long test. You would get a 3-digit score here, get as good a score as possible. Give this test only when you are completely prepared for it. If you get a low score, you cannot attempt it again for 7 years. And if you fail, it goes on your transcript that you have to take a second attempt. These are some of the resources that you would need to prepare for step 1 and step 2 exams. UWorld is a question bank that is very helpful. First aid is about with high yield concept, and NCME self-assessment would give you estimated score based on preparations. Occupational English test is a replacement for step 2 CS exams. It's just a test of English. You probably can prepare for it in about a week. There are some online courses that would help you with that. After completing all these examinations, getting your diploma transcripts verified, ECFMG would give you a certification that you are an ECFMG certified physician. Once you have that and if you can go ahead and appear for step 3 as well. It is not required for your residency application, but having a good score here will give you a boost to your applications. You need to give this test in the United States. This can't be given in India, and it would be over 2 days, which includes MCQs and calculations. Master of the Boards is a book with high-yield topics and concepts for this test, and there's a question bank for you to practice. If you have US hands-on experience, that would help you to an extent in the simulations. The next thing you need in your application is to have good clinical experience in the United States. If you haven't graduated yet, then you can apply for clinical electives. This can be done only before your internship completion. This would be a hands-on experience in which you interact with actual patients in US hospitals. If you have already graduated, then you'll have to apply for observership. It's a hands-off experience. And this would not count as a clinical experience requirement for some of the programs, not all. Some people would do a research assistant that would be a 6-month to 1-year commitment in a research lab, but this can be an opportunity to get some presentations, letters from faculty in the United States. All these things would take several months to apply for and to get in place. There might be visa requirements. Some places would need a step 1 pass score for you to give these electives. So accordingly. Around September of each year is when ERAS opens up. There's an online application process which generates your standardized CV. You have to put in a personal statement of what is your interest in the field, what are you looking for in the program. You would need some documents from your medical college, and other stuff just gets transferred over from your ECFMG account. This is a list of specialties in which foreign graduates were able to secure spots in the last year's batch. Internal medicine is the most common one with IMGs. Family medicine, pediatrics, pathology, psychiatry, these are some other IMG-friendly specialties. If you are interested in a surgical specialty, it's difficult but not impossible, but there will be far fewer people who are matching into those. This is just a sample criteria from one of the residency programs. Every program will have their own things they're looking for with the graduation year, their cutoff for your USMLE scores. You need to research which programs will be applying to. This data again comes from last year's match. For internal medicine applicants, which is the major chunk, the 58% of IMGs were able to secure spots. This number might not look bad, but when you apply in the match, you have put in about 2 years of work and maybe $15,000 to $20,000 through this process. Even after that, there are 40% who do not match. This table just gives you a comparison of US and non-US IMGs, that is like the citizens versus people who would need visa sponsorship, and people who match versus they didn't match. You know, higher scores, more presentations, more publications. All these will help you to outshine others. Other things that you can do to improve your chances of matching is to spend some time in the United States. If you can get letters from US faculties, that would be in your advantage. Reach out to alumni from medical colleges. They can help you with the process and they can help you with the interviews. And just to sum up, if you are looking for 2024 match, apply for ECFNG number and register for these exams as soon as possible. You'll have time until end of July 2023 to complete all these examinations, verifications, and to get clinical experience in the United States. September of 2023 is going to be the time where ERAS opens up. That's the place where all your residency applications are going to go through. October through end of start of February would be the time where all the interviews will be held. This year, they're going to be virtual. Next year, they might come back into an input model, probably. In March is the deadline to put in your preferences. That's the rank order list in NRNP software. And in third week of March is usually the match day where you would find out where you have obtained your residency spot. July 1 is the start day of residency each academic session. These are some of the websites which would have some important information for various. Thank you for paying attention and good luck in your journey. This is my email address. If there's anything that I haven't covered here, and feel free to send me an email. Thank you very much.
Thank you, Paptoda. This is regarding my talk. Now, MRCP.
Now we'll have 5 spot cases.
সে কোথায় গেল? আমার এই স্লাইডটা পেছনেই আছে। ডক্টর কুলু লেখা আছে কুলু। ওই যে আমি যে স্লাইডটা বললাম ডক্টর কুলু ওটাই লাস্ট। ওটা 6টা 5টা স্লাইড চলে যাক। তাই হবে তো না? Last presentation, just few spot cases for the students who are here. Then Dr. Gupta and Dr. Shorkar will take the long case. কিরম ছবি আসছে? ছবিগুলো বড় করা যায় না? কেন এরম ছবি আসছে? এত বড় ছবি ছিল। It was a big one. এই ছবিটা বড় করা যায় না? তুমি প্রিভিউটা বন্ধ করে দাও না, প্রিভিউ আমার কিচ্ছু অসুবিধা হবে না, পরপর দিয়ে দেবো তো। স্লাইড শো করে দাও না। Five minutes talk, nothing else. আচ্ছা না, তাহলে ছবি দেখবে কি করে? এটা তো বড় আসবে। কোথাও একটা প্রবলেম করছো। এটা স্লাইড শো করে দিন তো বড় করে, এরকম প্রিভিউ এগুলো দরকার আছে, ছবিগুলো না দেখতে পেলে তো ওদের ভালো লাগবে না। ও কিচ্ছু থাকে না, কিচ্ছু থাকে না, আর একটু চেঞ্জ করে দাও।
ইনেবল এডিটিং করুন প্রথমে।
একটা বেসিক এডিটিং এ কিছু করা আছে, তাড়াতাড়ি করো, ওরা সব নিচ্ছে না। একটা ছেড়ে দাও, আমি এতেই দেখিয়ে দিচ্ছি। Okay, this is for the students. They will show you a picture, a patient's hand like this. আমি কিছু দেখতেই পাচ্ছি না, এটা বড় হলে ভালো দেখতে পেতে। যে what is called, this is spot case means, I tell you, in Calcutta University in MD examination, short case, long case, spot case, and spot case is there also in DNB in everywhere. It means your diagnosis and reasoning. Only 1 minute time or half a minute time, you say the answer and go away. This is the hand, and there is the middle finger and the index finger has been shown. If it was a big, you can see there is a nicotine stain. This is the nicotine stain. And the question comes about back ear. This comes, what is the probable complication of cigarette smoking? How to take the history of smoking? This is how the spot kits are given. This is the patient. I don't know how clear it is. 4 or 5 pictures are there. Just you see this picture. Can you diagnose this? Not a classical book picture, but there is something clue. It is given in my book. This is a $100 case. What is that? Yes, lateral 1/3 of the eyebrow is lost. This is called madarosis. What I have written in my book, and this case is given in the exam. This is madarosis. In pulmonology, they will ask you, tell me 2 complications of myxedema. It's a classical case of myxedema, bilateral madarosis. So madarosis commonly found in, commonest cause is leprosy. Second is myxedema. Third is amyloidosis. Fourth is immune reaction. Fifth is alopecia areata. Commonly 5 causes are there. But this is the second or third cause. Just you see, this patient came to me with 390 TSH. I still remember. I did it 390. He's not totally obese. So if you are asked in pulmonology, what are the 2 complications? Can you tell me? Anybody? Student, doctor, non-doctor, anybody? Well, one is pleural effusion. Then that question will come. There is more lipids in myxedema, but what is the quality? It is transudate or exudate in pleural effusion. I have seen examiners ask this question. In majority of books, it is written pleural effusion from myxedema is transudative, not exudative. Bottom line, in few books it is written exudative, but in common book it deals with transudative, though the lipid contents may be high. And second is sleep apnea. Second is sleep apnea. There are 2 complications respiratory. Can you see the picture? It's a beautiful picture. Diagnosis. Spot case. Chest and upper part of the abdomen. One patient came to me with some problem. Anybody, quick. There are 3 or 4 pictures. They will show you this picture. Patient is lying in bed, or you are trying to see the venous flow. Patient is being seated. Any clue, any clue. gynecomastia, and anything else? Dilated veins, Partho is telling. Partho is my brother, come student, come everything. Partho, what is the diagnosis? It is a game. Gynecomastia, dilated veins, single diagnosis. No history. Superior vena cava syndrome will give venous prominence in the chest. It is in the abdomen. There lies the point. The boy who gave me the answer, I gave him 0. It is in the abdomen, not in the chest. There lies the problem. Portal hypertension. What is the cause of gynecomastia? Last question. Last question, very treacherous question. What is the cause? Commonest cause of gynecomastia in a case of cirrhosis. It is a case of cirrhosis. It is spironolactone therapy, golden line of Sheila Sherlock, not cirrhosis of liver. That's why these are the lakh dollars picture. So it is a very good picture. It is not a superior vena cava syndrome. Yeah. Might be, but it is a case of cirrhosis. It is in the lower jaw. And the examiner will tell the students the flow is away from the umbilicus. They will give a clue because they know the case. This patient came to me at NRS Medical College 1993. This patient ultimately referred to Partho-like doctors, Dr. Bhattacharya. What is this condition known as and why he has been referred? This is your spot case. The answer is, I am giving the answer. If you try to pinch the skin over the fingers, you cannot hold it. It is called sclerodactyly. Sclerodactyly with ulcers, with thick skin, classical scleroderma. Classical scleroderma. And this patient recently, day before yesterday or something, Arup Haldara sent me a patient. This patient is suffering from ILD, very common. And they will ask you, what is the last drug, newer drug you are using in ILD? There are so many drugs, many doctors. What is the newer drug? Nintedanib. Ekdom. Nintedanib. Okay. These are the simple questions. This patient, this time, I can remember the last DNB medicine exam, they selected this patient. This is my patient. They selected this patient in DNB medicine. Diagnosis. Beautiful picture. Herpes zoster ophthalmicus. Just you see, ophthalmicus, only one side of the head, not both the side. What is the dreaded danger of this patient? Single question. Blindness. Absolutely. That is the only answer. Blindness treated by valacyclovir or anyone else. 1 or 2 questions. Anybody? Very recent picture. Patient came in my chamber. No, it is not recent. It is 8 to 10 years back. Somebody sent it to me. I took the picture and gave it in my second book. No clue. I am telling, giving you one clue. It is in the forearm. It is not very clear. It is the forearm. Huh? Severe Mantoux reaction. Absolutely correct. It is grade 4+ or grade 100+. So the question in pulmonology will come, what are the patients who is giving Mantoux negative in spite of active tuberculosis? Just like OSCE. Give me 3 or 4 or 5 examples. But the Mantoux is boldly negative in spite of active tuberculosis. HIV, not necessarily. Miliary, number 1. Measles, sarcoidosis, measles, leukemia, and lymphoma. Measles is very important. Remember, measles gives you negative Mantoux test. Okay. This is in these patients, we measure the transverse diameter as 10 millimeter, not the erythema, but the induration. In that is positive Mantoux, and it is a severe reaction. In HIV, the Mantoux is positive if it is more than 5 millimeter. Oh, sorry. There is a name of this condition. Recently, I heard in giving a lecture in Jaipur, the students told me a new terminology. I did not know the terminology. It is clubbing. They told me it is pan clubbing. It's a new term they are using, every student. Pan clubbing, I have never heard of it, but just sharing it to you. So for pulmonology, there is clubbing and cyanosis. Tell me 4 important causes. Mind it is clubbing and cyanosis. It is your exam. They will ask you in this way. They will show you the patient. Congenital cyanotic heart disease, leave it. Next, cystic bronchiectasis. Next, AV malformation. This is very important. Pulmonary AV fistula. Cystic fibrosis. These are the common 4 or 5 causes of this and this. If a patient has got only cyanosis, no clubbing, if they ask you what are the causes, you can tell host of causes. But remember, answer will be given in this way. If they ask you, if there is only cyanosis, no clubbing, your answer will be the causes of only cyanosis is central cyanosis and acutely developing central cyanosis and peripheral cyanosis. Now the examiner will mind what are the causes. This is in a simpler way. This patient has been admitted in RG Medical College before my retirement in 2010 in chest department. Why? And the question is why. You will, it is very easy for you. They will give the answer. This is all a real life patients. What is this condition known as? Quick, or only one photo is there? Huh? Ocular myasthenia gravis. Okay, this is bilateral, probably equal ptosis. What is the size of the pupil? They will ask you, see the pupil. Myasthenia gravis never changes the pupil. It increases at the end of the evening, end of the day. Why? He has been admitted in chest department. This is the question. Mediastinal mass is thymoma. Not because of thymoma he has been admitted. He has admitted because of respiratory failure. Myasthenia gravis is a very important cause of type 2 failure. Okay. Yes, mass is there. So somebody may miss this is thymoma is there. And one of the treatment of myasthenia is operation of thymoma. What is this? Chest. Excavatum, pectus excavatum. What is the 2 or 3 complications patients may suffer from in pulmonology? These are your question of spot case. No mercy, 1 minute time. It presses the right ventricle in such a way the heart become pressed. It is called pomfret heart. Pomfret macher moto hoye jay. As it presses the right ventricular outflow tract obstruction, you can get a murmur like pulmonary stenosis. And ultimately, restricted lung disease occurs. And patient may develop pulmonary hypertension. Prepare for these questions. This is the last question. I went to Europe. Probably, I think it is a photograph of Geneva or something. I will ask you only one question. It's the city of Michelangelo. This picture you will get in internet. This is a beautiful picture. I stood there. I remember one of my teacher's class by standing in front of it. What is in your mind after seeing the picture? And if you utter this, just Google the utterance and you will get this picture. I got it. I took the picture 2 years back before just Corona. Any clue? There is a man who cut the throat of a person. He has got curly hairs. You read in your book. This is called Medusa. Medusa hair has been cut in your book. In all the theory book, it is written by this person. And it is converted into snakes. That is called caput medusae. The caput medusae nomenclature, the cirrhosis of liver with portoconvulsion came from this picture. Thank you.
Hello, hello. Mic is working. As they are preparing for the cases, I want to tell you something. And what is that in examination? What we mean by education. Examination is a way to evaluate education. And education means three things. So let's say three things. One is knowledge, one is attitude, another is practice. So when we ask in the examination, show me the shifting down, we want to know whether you know that, how to perform it. Number two, your attitude towards the patient, whether you are comfortable with the patient or patient is comfortable with you. This is the second thing. And number three, whether you have practiced it earlier or not, whether you have gone to ward earlier or not. This is the things. So you may see that, you may wonder why we are not asking many things. But if you can demonstrate how to see the shifting dullness, then examination is over. And if you can satisfy the examiners, they will give you marks. Yes.
Yes. Good evening, everyone. We are from SSKM, Department of Pulmonary Medicine, SSKM Hospital. First, Dr. Ritobroto Mitro, our resident, senior resident, will present one short case. Dr. Mitro.
Thank you, sir. Thank you, respected chairpersons. So today, our first case, Mr. IH, a 65-year-old male farmer from Malda. He actually, after admission, rapidly deteriorated, so we couldn't make the video in details. However, his chief complaints was shortness of breath with cough for 2 months, swelling of face and neck for 1 month, and difficulty to swallow solid food for 1 month. He was apparently well 2 months back until he developed gradual onset shortness of breath, progressive shortness of breath upon walking upstairs initially, to shortness of breath even at rest over next 2 months. No diurnal and postural variation associated with cough with occasional production of scanty mucoid sputum, not associated with history suggestive of paroxysmal nocturnal dyspnea, orthopnea, bipedal swelling, hemoptysis, or wheeze. Regarding the swelling of face and neck, it is of 1 month duration, insidious onset, gradually progressive, associated with swelling of both upper arms, more in morning after getting up from bed and upon leaning forward. Actually, there is a new term for this condition, that is shortness of breath being increased upon leaning forward. It is introduced in 2022 guideline. Apart from this, there is a difficulty in swallowing food for 1 month duration, insidious onset, gradually progressive, mainly for solid food, not associated with any pain during deglutition. There is no history of any fever or weight loss.
So what we think at this stage, a patient has an history of 2 month duration of a progressive breathlessness, cough, swelling face, and dysphagia. What we think that what is might happening in the thorax in this patient? Pardon? Causing shortness of the breath. Okay.
What mediastinal mass can produce shortness of breath?
I think we can just possibly it has compressed
there
over a
is a-
large airway to begin with. That's why there will be dyspnea. And subsequently, there is an obstruction to the superior vena cava. That's why he has developed. But what is odd? Usually, superior vena cava is an entry structure. Esophagus is a posterior structure. So there should be a very massive involvement of the mediastinum to cause both the symptom in one patient. That is very, very unusual. That a single patient is having
superior vena cava as well as dysphagia. That is seen in this patient. That's quite unusual. So possibly the person has a massive mediastinal involvement in this patient because of the two things which are happening at the same time or a shorter duration. What else we think? It is an inflammatory, it is some benign, or it is some malignant? It is. So shorter duration, superior vena cava obstruction, dysphagia, and the shorter history all favors that there must be a malignant process is going on in the thorax. We can
Proceed.
So history of past illness, no. History of significant medical and surgical illness. So there is no history of fever, weight loss, any hemoptysis, chest pain or wheeze, palpitation, syncope, loss of consciousness, convulsion or vomiting. No history of any joint pain, skin rash, smoky or reddish urine. No history of any hoarseness of voice or stridor.
So anything more we have got from this negative history? Are we become more wise, whatever we are having in our mind prior to that? In spite of posterior mediastinal involvement, superior vena cava, possibly aortopulmonary area is still spared because there is no hoarseness of the voice is there. One thing we can say like that. No fever, probably we go away from the inflammatory, but we expect a weight loss in a malignant process over a period of the 2 months, which is missing over there. But why did you ask for the reddish urine? What was in your mind?
That is the standard history of CTD ILD,
That's I will come to. You see, the negative history should be relevant to that patient only.
It is not relevant, basically.
It should be relevant to that situation. Not that whatever negative history you can include, you can just push over there. Like. Irrelevant things doesn't give much weightage to your presentation. So negative history should be relevant to that particular case.
The negative history should be taken that will lead to a diagnosis or that will exclude some diagnosis, not haphazardly anything you can ask.
No history of significant medical and surgical illness, no prior hospitalization. Regarding personal history, married with 3 living children, no alteration of bowel and bladder habit, sleep recently disturbed actually, not normal, appetite diminished, addiction, smoker with 3 to 4 BD per week for last around 30 years, stopped for last 1 year. Family history, nothing significant. Treatment history, due to shortness of breath, attended private nursing home 3 days before admission here, where some reddish colored fluid removed from right side of back, but no relief of symptoms.
So
from that history, what is your impression? This is the question commonly asked. From this history, what is your impression regarding the disease? Anybody can tell?
So there must be pleural effusion. Along with that, either it can be mediastinal mass, huge mediastinal mass, or there may be a possibility of lung mass which has invaded into the mediastinum. Any other possibility?
So it is better to tell there is mediastinal involvement.
Yes.
It may be mass, it may be something else, yes, or it may be metastasis, or it may be continuous spread.
So what do you think the process of development of the pleural effusion started first or mediastinal invasion started first in this patient? We believe the growth may be somewhere in the lung parenchyma, and then it has spread both the sides. One side mediastinum, one side on the pleural space. So which might have occurred first time. Patient had dyspnea only to begin with. That we can explain with the presence of effusion only. Superior vena cava obstruction came late. So possibly mediastinal invasion and involvement of the superior vena cava is a later process. And if person is having a right-sided disease, so probably right hilar and subcarinal node will be enlarged, and that can cause dysphagia and superior vena cava both. Aortopulmonary will be spared in the right-sided disease.
So whenever dyspnea is for 2 to 3 months, always think of pleural effusion first, then other diseases. And whenever there is pleural effusion, you must ask in the negative history whether pleural thoracic chest pain is there or not. If the disease started with pleural thoracic chest pain, then it signifies something else. What it signifies? Thoracic chest pain, if it is present, then it indicates inflammation of the pleura. So it goes for benign disease. And in absence of thoracic chest pain is very significant, that indicates something else. Another important thing, when there is a history of smoking, always what happens in COPD patients, they ignores their symptoms, firstly as smoker's cough, then they adjust, particularly in rural area, they adjust that by change of profession or something else, lifestyle modification. So the history may not be so short. You have to take carefully. The history taking is very important regarding the onset of dyspnea. In patients of COPD, they usually tell that 2 months the dyspnea has increased, but that doesn't mean that disease is of 2 months duration. If it is truly 2 month duration, please think of pleural disease. And thoracic chest pain is a very important negative finding. You must ask in all cases of thoracic pleural effusion.
So to summarize, a 65-year-old male farmer by occupation, smoker, normotensive, non-diabetic, presented with gradually progressive shortness of breath along with cough for last 2 months, and insidious onset of swelling of face and neck, more in morning after getting up from bed, and upon leaning forward, and also difficulty to swallow solid food for last 1 month, with history of reddish fluid removed from right side of back, but no relief of symptoms.
So what does it suggest? A patient pleural fluid was aspirated, but there was no relief in the symptom. And what are its treatment implications? What is the lead with this last line? Reddish fluid removed from the right side of the back, but no relief in the symptom. We have a very important lead from that. This. Pardon? No. Person might be having endobronchial obstruction. This means after aspiration, lung has not expanded. If lung would have been expanded, patient would have relief in the symptoms. So if a situation is like this, probably by putting a chest tube also, you will not give the relief to the patient. So chest tube insertion should be avoided in such patients.
After aspiration, there should be some immediate relief to the patient. And after that, there may be reaccumulation and reappearance of the dyspnea. But if there is no change of dyspnea, it signifies what sir has been told.
You see, when the person is sitting, probably under the effect of the gravity, some amount of the drainage of the venous blood occurs. But when they lean forward, probably that thing will be neutralized. So that SPC obstruction will increase on that. It will not feel. No. That position, probably if the background COPD is there, that person might assume that position. Otherwise, with plain SPC obstruction, I don't think that there will be some relation to that also.
The tripod position is mainly to fix the shoulder guard so that the neck muscles can work better.
Now, what is your provisional diagnosis from history?
Okay, tell your provisional diagnosis.
So we are thinking of a superior vena cava obstruction along with right-sided pleural effusion.
What
Now,
about dysphagia?
clinically, how to look for, how to diagnose malignant pleural effusion?
But in provisional diagnosis, because we have a dysphagia is a very prominent symptom in this patient, na? So that should also be included. And you can say that possibly esophageal obstruction. And
So when to suspect clinically malignant pleural effusion? One is massive effusion, hemorrhagic effusion, recurrent accumulation of fluid, associated manifestation, mediastinal involvement, okay, and massive effusion without mediastinal shift or mediastinal shift to the same site. In those cases, you should clinically think that it may be a malignant effusion. And my next question is superior vena cava syndrome can cause pleural effusion? So there are many causes of pleural effusion in malignancy, bronchogenic CL. The first cause is metastasis to the pleura, second is lymphatic obstruction, and SVC syndrome is one of the cause of pleural effusion, but usually it is a mild, small effusion.
If the obstruction is at the level of azygos or post-azygos, it can cause pleural effusion without malignant infiltration.
Now proceed further.
Yes.
Your examination.
Regarding general survey, conscious, alert, cooperative, decubitus sitting, build and nutrition, thin meal, malnourished, faces anxious and swollen, pallor present, clubbing grade 2, neck vein engorged, non-pulsatile on erect sitting posture, neck gland left supraclavicular, solitary, oval shaped, around 3 into 2.5 centimeter, hard, mobile, not fixed to skin and underlying structure, no discharging sinus, blood pressure 110/70 millimeter of mercury, left arm, pulse rate 108 per minute, regular, all peripheral pulse palpable, no radioradial or radiofemoral delay, normal arterial wall, respiratory rate 24 per minute, regular, abdominothoracic, temperature not raised, saturation 98% on room air, no obvious deformity. Regarding upper respiratory tract within normal limit, on inspection of the lower respiratory tract.
You see, often we use this word upper respiratory tract now. Anatomically, up to the larynx, we include upper respiratory tract, but we cannot examine that in our day-to-day practice there only. No? So rather than writing upper respiratory tract, we just say nose and pharynx only. No? That will be better. And we complete upper respiratory tract, we do not examine, and we cannot examine also. So why to say upper respiratory tract? Just say that nose and pharynx. That's all. Oral cavity, yes. That's all.
You can say visible part of the upper respiratory tract. You can say in this way also, visible part. And also oral cavity is very important. Oral cavity must be included. So you have to mention nose, pharynx, and also oral cavity.
Yes, visible part.
Visible part of the upper respiratory tract, including oral cavity. Oral cavity is very important. You have to mention it. Why oral cavity is important? More common thing. Please start
Hygiene.
with the common thing.
Hygiene of the oral cavity you have to see.
Oral hygiene is very important for anaerobic.
In case of lung abscess, bad oral hygiene.
Can you tell me one or two conditions where you can see the abnormal gums and there must be some pulmonary disease? Wagner's will be there, no? One amyloidosis, you can say.
Proceed.
Regarding inspection of the lower respiratory tract,
Again,
there is
you do not inspect the lower respiratory tract. That can only be done by the bronchoscope. No? So don't say the examination of respiratory system, you say that, or examination of the chest, you say like that. That will be better, I think. Yes. Because it looks like misnomer, na? Examination of lower respiratory tract. You can do only with the bronchoscope, not with the apnea.
Shape of the chest elliptical, movement of chest diminished on right side, trachea shifted to right, apical impulse left fifth intercostal space on mid-clavicular line, respiratory rate 24 per minute, regular abdominothoracic, accessory muscle flaring of iliac nasi, venous prominence, visible prominent dilated tortuous veins over anterior chest and abdominal wall in sitting posture, no fullness of intercostal space, no intercostal suction and depression. Skin, there is a puncture mark at right 8 intercostal space at dorsal scapular line, no gibbous and spinal deformity on back. Also, there is no drooping of shoulder, wing scapula or retracted nipple. Regarding palpation, temperature not raised locally, no local tenderness elicited. Corroborative finding of inspection, position of trachea shifted towards right, apex bit at left fifth intercostal space on mid-clavicular line, movement of chest diminished on right side with 1.5 centimeter expansion, anteroposterior and transverse diameter 21 and 30 centimeter respectively, vocal premitus increased on right intraclavicular area, decrease in right mammary, infraaxillary, infrascapular area, normal at left side. Palpation, direction of flow in superficial palpable veins in anterior chest wall from above downwards. There is no rib crowding and subcutaneous emphysema.
Okay, just 1 second. Huh? So with this physical finding of the inspection and palpation, there is a decreased movement, decreased vocal parameters, shift of the trachea. What is the other possible differential diagnosis? Physical examination, physical diagnosis, other than effusion, which we know by the history. What can be the other physical diagnosis? Collapse. One can be the collapse.
So classically, respiratory diseases are divided into 3 groups. One is mediastinum shifted to the same side of the disease. The same side disease means where movement is less. And that is the collapse, fibrosis. And when the mediastinum is shifted to the opposite side, it is effusion, pneumothorax, hydropneumothorax. And when it is central, it is maybe consolidation or a bilateral disease. So this is the usual. So when there is mediastinal shift to the right and right side is disease, so you have to think of either collapse or, and as there is aspiration of fluid and everything is going for, so there is 2 pathology. One is effusion, along with there is collapse. Why collapse? It is history is short. Number 1, number 2, there is no associated cough expectoration for long time. And patient is smoker, elderly person, so we can think of collapse.
Now, direction of the flow, it is demonstrated as the patient is very sick, so we could not demonstrate the flow in the sitting position. We did it in semi-recumbent position.
So you see, what is happening? So we first choose a relatively straight segment without tributaries. Then after milking it empty, the upper finger is lifted. So there is rapid filling compared to when we put up the lower finger. So flow is from above downwards.
What is the extent of this? What is the extent of these veins? They are below umbilicus or above umbilicus only?
Lower part here, what is the extent of this venous prominence?
Venous
is not exposed.
So they are up to the umbilicus? They are up to the umbilicus?
Yes, the collaterals is distributed up to the below the umbilicus also.
Below the umbilicus. So what does it suggest? Is it pre-azygous or post-azygous obstruction? It is post-azygous. Meaning, if azygous would have been serving the purpose, then you won't find the engorged vein below the chest. Then it will through intercostals, it will be the directed. But if it is post-azygous, it will come through the pelvic veins and through inferior vena cava. It will a long route and insufficient collaterals, insufficient drainage will be there. Patient will be more symptomatic in post-azygous than pre-azygous. It will be a long tortuous course. So if the veins are prominent below, you can see the umbilicus, then it is post-azygous obstruction.
So this is very important to look for the veins. And you have to differentiate between pre and post azygous, and you have to know the collateral circulation in both cases.
Anyone can tell how superior vena cava is formed? How superior vena cava is formed?
Internal jugular মিলে হচ্ছে বলতে পারছে না সাপ্লিমেন্টাল ওদিক থেকে লেফট ব্রেকিওসেফালিক
internal jugular and subclavian. And where the external jugular goes?
Again.
External jugular goes to the subclavian. So the right and left both, and obliquely behind the manubrium, at the end, at the junction of the body and manubrium, right and left innominate the joints and they form the superior vena cava.
So in SBC syndrome, one is the extent of the collateral circulation, that is important. Another, you have to mention in general survey about the JVP, whether jugular venous pressure is how much it is, and whether it is palpable or there is pulsation is present or not. Have you mentioned this?
সুপ্রিয়কে বলতেই হচ্ছে
No, no, no.
না বললেই হলো তোমার তো লোক ভালো হচ্ছে ও ক্যামেরা
Look for the
examiner of the East.
Actually, there was engorged neck vein even in sitting erect posture. So we need not examine in the recumbent 45-degree with back rest.
Which vein has to examine for JVP?
So it's basically internal jugular.
Internal jugular vein is normally visible. Is internal jugular vein normally visible?
So
No. Then by how we can see the jugular venous pressure?
Sir, by actually when the venous pressure is raised by sir making the patient semi-recumbent at around 45 degrees.
No, that is the point when you can see the pulsation. So internal jugular vein is not visible. You can see the pulsation. In why I am asking you that in case of SBC syndrome, you cannot see the pulsation. It is non-pulsating. Then you cannot see the internal jugular. So we are looking actually for external jugular. This is the difference.
Internal jugular from the distant.
This SBC syndrome. Okay. Now it is clear. So normally the internal JVP will look at the internal jugular vein. Internal jugular vein is not visible. We are seeing the pulsation at the point, at the level where the pulsation maximum is better visible. That angle we have to examine. It is 45 is the standard, but it is not.
Sir, even the patient is the raised JVP is at 90-degree sitting posture. Is it needed to?
90 degree to dekhte pabe, then you can take it 90 degree.
Yes. So regarding percussion?
Yes.
So it's along the right mid-clavicular line. There is dull percussion node in the second intercostal space downwards. Along the mid-axillary line, 4 to 6 intercostal space resonant, but it is dull 7th intercostal space downwards. And along the dorsal scapular line, it is dull from the 8th intercostal space downwards. And in the left side, it is resonant up to 6th, 8th, and 10th intercostal space along the mid-clavicular, mid-axillary, and dorsal scapular line, respectively. There is no shifting dullness elicited. Chronic isthmus dull on right side, sternal percussion dull, clavicular percussion dull on right side, cross-space tympanitic node.
Thanks now. So why shifting dullness is absent in this patient even in presence of effusion? One. And second thing, do you find any lead to your diagnosis with these percussion findings? As we thought that there might be some endobronchial obstruction, so underlying lung is collapse also. So you will not find that. Or fluid might be very massive. So there is no space to shift the fluid. But malignancy, we do not expect the low liquidity diffusion. Yes, external percussion dull. This means mediastinum has been involved with the lymphadenopathy. That's why it is dull. So there is a lead to the underlying etiology that possibly it is malignant.
Good. Regarding auscultation, vesicular breath sound present in all areas in the left side, right axillary, suprascapular and interscapular region. Vesicular breath sound absent in right mammary, infraxillary and infrascapular area. Bronchial breath sound present in right infraclavicular area with vocal resonance increased in right intraclavicular, but decreased in right mammary, infraxillary and infrascapular areas as compared to left, and equal and comparable in rest of the other areas. Forced expiratory time, patient couldn't perform.
You see, this is irrelevant now. COPD is not a very anywhere in your diagnosis, in your history also. No? So why you take the forced expected time in this patient and you are telling that your patient is sick also? Forced expected time, patient could not.
How can we examine for forced expiratory time?
And what is the need for that also? There is no need of that thing. Just we talked earlier that only relevant thing should be discussed in your case. There can be hundreds of the things which you can include, but irrelevant things, they do not give any credit. They just waste your time also. So there is no need to see things which has no relevance to that in that particular case.
How we can differentiate pre-pleural effusion from encystic effusion clinically? We are expecting pre-fluid, not encysted. How will it clinically differentiate? Yeah. What posture immediately? Huh? Not the true answer, actually. It's the wrong answer. Huh? So in pre-effusion, the highest point should be in the axilla. Highest point should be in axilla, anteriorly, axilla, and the posteriorly. The highest point should be in the axilla. And in case of encystic diffusion, according to the shifting. And what is the shifting dullness? We are pleural effusion, whether you can have the shifting dullness or not. Yes. What is the peculiarity? What is the difference of shifting dullness of pleural effusion from that of hydropneumothorax?
So in pleural effusion, we have to wait at least around 30 minutes to.
Yes, that is a delayed shifting dullness. Whenever there is a dullness, we must go for shifting dullness. And in case of pleural effusion, there may be shifting dullness, but it is delayed. But in hydropneumothorax, it is immediate shifting dullness. This is one thing. And if in pleural effusion, shifting dullness is present, what is the significance of that? Huh? Anything? Anything? It indicates that underlying lung is healthy. Cannot be in this case. Shifting dullness cannot be present in this case because though it is pre-fluid, because underlying. So in hydropneumothorax, what is happening? The fluid is replaced by air and air is replaced by fluid. And but here, what happens? The fluid is went away, but the underlying lung has to be aerated, and that will take some time to be regenerated. So if the underlying lung is not healthy, it will not be aerated, and the hyperregenerated node will not be regenerated. That is the problem. And how to look for shifting dullness? Common
This like a burning.
Yes. You want to answer?
The sign of the orange.
After some time means? 20 minutes, you have to wait. You got only 45 minutes to complete your long case. And you, that is. So classically, it should be done in the mid-axillary line. You percuss mid-axillary line up to the dullness, and then fix the finger over the dull area. Then ask the patient to be left lateral position with the disease side upwards. And after 3 breaths, 3 to 5 breaths, you can again percuss over that area, fixing the finger on that. And percuss over there too. And if it is resonant, that means the fluid has been replaced by air. Then again, ask the patient to sit and again percuss over that area to demonstrate that air is again replaced by air. This is the classical. Now this is shifting downless can be seen in the anteriorly, in the posteriorly, or in the lateral. But classical is lateral, the mid-axillary. And you can see anywhere. Posteriorly, because posteriorly is not preferable, because posteriorly there is thick muscle surface. So it is very difficult to do.
Other systemic examination within normal limit. So to
in other system,
what are you expecting abnormality? What abnormality you are searching?
Suppose you are having a muffled heart sound, then this patient.
Pericardial effusion.
Pericardial effusion might have been there. You have an hepatomegaly, enlarged tender liver, possibly liver mets. Possibly liver mets.
Do you have examined testes?
Yes.
Yes.
We examine the testes, but it is not shown.
You can go to next slide. You have already told me. Next slide, no? This is all repetition. Next.
What is our provisional diagnosis from after history taking an examination?
It's probably right lung mass, bronchogenic carcinoma with upper lobe collapse, extending to mediastinum, causing superior vena cava obstruction and esophageal compression, along with right-sided pleural effusion.
You see, first thing, you just in pulmonary practice, now you just give your first physical diagnosis. And after completing the complete physical diagnosis, you just give possible etiological diagnosis. So not to write that bronchogenic carcinoma in the first line. Not to like that. So one thing, why you say that bronchogenic carcinoma? If I say here's a lymphoma, what is the word for that? Patient did not started with a cough. Bronchogenic carcinoma, endobronchial disease, there should be cough first. There should be hemoptysis. That is not there. So why probably we are overstressing our assumption of a bronchogenic carcinoma? You may be correct, but by whatever evidences we are having, probably I will like to say just only massive right effusion, superior vena cava obstruction, and possibly esophageal obstruction, underlying possible malignant etiology. It may be bronchogenic carcinoma or it may be lymphoma also, I don't know.
Sir, actually, this patient is a
right lung mass. Why you started with
right lung mass?
So there is a cause for right.
You have started with the right lung mass.
Actually, from history, are suggesting a collapse, so it may be a endobronchial growth.
Right lung mass. What right lung mass means? What mass means? More than
Right lung mass.
What is the evidence of right lung?
A 5 to 6 centimeter lung mass will cause a chest pain. It is missing in your case. There is no chest pain.
To start with pleural, right-sided pleural, those are definite. You have to start right-sided pleural effusion with superior vena cava syndrome, with esophageal compression. You must like that. You have to start with that, and then the possible etiology may be malignant. So like that. But you cannot define that it is a mediastinal mass with bronchogenic carcinoma.
Okay, biopsy.
So how will you proceed now? I will proceed. You have chest X-ray of this patient? Okay. Show the chest X-ray. This is the X-ray. So what does it show? Some radiological sign which is described for this X-ray. Some classical radiological sign has been described for this. Golden S sign is there. And it suggests right upper lobe collapse. But mind you, golden S sign can be for the lower lobe also. It can be lower lobe also. Not necessarily that it is upper lobe. Sometimes we find lower lobe also. But effusion is missing, whereas it has gone. And you told that it has been aspirated also. A malignant effusion never disappears.
It was actually just taken after the aspiration of the pleural fluid aspiration. The
aspiration. Then aspiration was perfect. So probably last drop has been aspirated.
That was what we got actually. Maybe some fluid is there in subpulmonary part.
Subpulmonary part. How can you tell it is a subpulmonary?
So because there is slight lateralization of the highest part of the dome of diaphragm.
Raised diaphragm with the highest point lateral, shifted lateral. So you can say there is some fluid, but it doesn't look like malignant pleural.
That is an odd point, sir. Then we have CT scan. Heterogeneous mass in the right lung compressing the superior vena cava and also some prominent veins in the anterior chest wall, which is some anterior dilated chest veins.
Chest veins. Show me.
So this one. The point of the cursor at the top.
But in CT, you first look at the SBC. What is the position of SBC? Is SBC is visible or not?
Actually, the cursor is not showing here. So cursor is not. So cursor is in the screen, but it is not shown in the picture there.
Very faintly seen.
Yes. This is the SBC. I mean, that is compressed. Okay.
So actually, cursor is visible
here. Cursor, okay. You can.
On the top of that, sir, there
So
are some
after
dilated
seeing
chest veins.
after seeing the radiology, then you can see there is a mass. But clinically, you cannot say it is a mass.
So further investigation, the pleural fluid was exudative, lymphocytic and low ADA, and FNC in the left supraclavicular lymph node, it triple metastatic small cell lung carcinoma. Before the FNC result come, actually patient expired. We got the report later.
So suppose given the choice, you have two options: to go for the pleural biopsy, maybe blind, or to go for the lymph node biopsy from the supraclavicular node. Which you will prefer and why? Out of the two things for the tissue diagnosis. Pardon? The yield of pleural biopsy in malignancy is less than 50%.
Why?
Less than 50%.
Why it is less? Because the deposition are scattered, unlike tuberculosis. So in tuberculosis, blind biopsy has more yield, and in malignancy, blind biopsy is not preferred. If you have to do the pleural biopsy, then it should be guided by thoracoscope.
And probably from the node, if you have taken the biopsy representative sample, you can have a 100% diagnosis. So, and one more thing I will suggest that whenever you have an accessible lesion, if it is feasible, nowadays always go for the true-cut biopsy rather than FNAC. Because our oncologist, again, he will say, I need biopsy, I want markers, I want this one. Nah. So again, things will be at an halt. So just always try to, if you are having accessible lymph node, then better to have by 2 procedures. Just have a simple, single procedure only. So better to have a biopsy in this situation rather than this one. So this patient died, unfortunately, but just theoretical question, what are the various situations where you can consider chemotherapy in a patient of suspected malignancy like this without a tissue diagnosis? Can we give, your patient is sick enough, biopsy will take another 4 days, you are losing a patient otherwise. Probably you can just give something. What is rapid? Some defined indications are there. Airway obstruction. Airway obstruction is there, large airway obstruction, massive pericardial effusion, and increased intracranial tension. If these are the indications where you can give chemotherapy even before the tissue diagnosis in this situation, what we have.
And in these cases, FNSC and biopsy should be done simultaneously, because FNSC report will come within 1 day. Then you can plan for treatment. Another thing is that pleural fluid cytology gives more yield than blind biopsy. If you have to prefer between the blind pleural biopsy and cytology is always preferable. I think it's certainly good. Short part will go. Second case.
Second करेंगे.
Okay. Then let us stop here. Thank you.
Thank you, sir. Thank you, sir.
Okay. So just before that, how you just grade? Suppose it is you are your examiner, your own examiner. Out of the 10, how much marks you would like to give to yourself?
So I have already told in my lecture that if you can answer the honors questions,
or what are the
high-level questions without answering the basic things, then you will get 25, and you will definitely fail. So you must be careful. There are some areas, must-know areas. There should not be, like in tuberculosis, in NTP, etc., or in the basic things. You must answer all these questions. They are simple questions, and answers are simple. But if you can answer them, then you can go higher. And if you can answer the simple questions and also hard questions, then we will get 75, more than 75.
But overall, it was nicely prepared. Just only thing you can avoid unnecessary inclusions, which are not required for that particular case. The chronology of the things like bronchogenic carcinoma you have made first, probably that could have been last. So this with the smaller changes like that, not a major changes, probably you can improve upon it also. And even in your own department, even faculty is not available, among yourself also you can keep 1 case every week. By rotation you can present, you can improve by that yourself.
And diagnosis should be the structural, first pathological, then etiological, then complications. These are the 3 parts. And tomorrow morning, I will show you a one case on tuberculosis so that you can classical example so that you can find how to present a case.
So,
okay, thank you.
Thank you again. Already we are late by 1 hour for your patience. Thank you again.
Correct case.
দেখিয়ে দিতে হবে 5 মিনিটের মধ্যে কোনো কোশ্চেন অ্যান্সার হবে না, সেটা করতে হবে 5 মিনিটের খালি কেসটা দেখি ওরা এতক্ষণ রয়েছে। Giving you 5 minutes, you have to complete that within 5 minutes.
What?
You just tell your presenting symptoms.
You only tell your presenting symptom.
Good evening, everyone. My case is Mr. BB, 59-year-old male, resident of Havra, West Bengal.
No present, no slideshow.
Sir,
Slide.
slide is there. It's taking a bit of time, I remember.
No, but
should I present it?
No, just speak. So,
give your introduction first.
Yeah. Good evening. I am Akshat Gupta, resident doctor in Pulmonary Medicine Department at IPJMA. So I'll be presenting a case which was admitted in our ward. My case is Mr. BB, 59-year-old male, resident of Havra, West Bengal, who presented to our OPD with complaints of cough and shortness of breath for 2 years. Patient was apparently well 2 years back when he developed cough, which was insidious in onset, persistent and progressive in nature. It was non-obstructive with no diurnal and seasonal variation.
so can you tell me the 3 or 4 causes of cough and breathlessness of a 2 years duration?
Sir, it can be a COPD, most commonly an obstructive airway disease, as we mostly see in our practice. 59-year-old male can be a chronic obstructive pulmonary disease or an asthma patient, or can be a parenchymal involvement.
Like that, if you are telling chronic obstructive airway disease, agree. But if you are telling asthma, then better to say chronic persistent asthma. If you are telling asthma, then say chronic persistent asthma. If he is having persistent symptoms for 2 years.
Okay. Yep.
Don't say asthma only, then say chronic persistent asthma. What is the third?
Sir, parenchymal may be an interstitial lung
Maybe
disease.
diffuse pulmonary interstitial lung disease.
Can present.
Fourth,
most common will be these. Other that bronchiectasis can present, although it's a non-productive.
bronchiectasis is there, then don't say that. Now. That's the problem. Now. You think and then you withdraw yourself in the examination also. You don't do that thing. Now. Just think 1 minute and then speak whatever you speak. Now. If I say that person had an 2 years back, he had some pneumonic illness or some empyema, and that get organized. So that cough and dyspnea can persist for him. Just an assumption is there. Among the pulmonary disease, I can say like that.
Yes, yes, it can.
You can also say the cardiomyopathy as a cause of chronic cough.
Yes.
Another can be a small, slow growing, some benign mediastinal disease, mediastinal tumor that is pressing over the large airways and causing cough and dyspnea both. Pulmonary hypertension, idiopathic pulmonary hypertension.
Okay, continue.
Shortness of breath was insidious in onset, persistent, progressive, and exertional in nature.
So already the crux of the history.
Summary
of the history. Summarize.
So, should I skip all the slides?
Only summary. Summary of the case.
A 59-year-old male, advocate, assistant by profession, never smoker, without any significant comorbidities, with complaints of progressive dry cough and exertional shortness of breath for last 2 years, with history of exposure to organic dust from domestic birds.
At this moment, I will say that try to avoid the adjective without any significant comorbidity. Here you give the chance to ask the examiner, what is significant comorbidity and what is insignificant comorbidity. So try to avoid such words. Don't include that now. Never a smoker, no comorbidity, you say like that. Or what are comorbidities there, you name that only. And don't put such adjectives because you are trapped in after that also. You invite your questions your own.
Always do not use any adjective adverb which you cannot define. Massive hemoptysis, you can say because massive hemoptysis has a definition. Otherwise, do not.
So what do you think in this case?
So my provisional diagnosis at this point time is interstitial lung disease.
Interstitial, why?
The patient has a dry cough and exertional shortness of breath, which is persistent and progressive. And there is a significant history of exposure to organic dust from domestic birds, and the symptoms are temporally associated. The patient brought the birds at his home 6 months prior to the onset of symptoms.
What organic dust?
So
Specify
for
the
the
organ-
patient, patient domestic birds.
So suppose you take 100 patients of a cough and breathlessness from a community. So COPD, which is equally prevalent among the non-smokers, is more common, or an hypersensitive pneumonitis like this is more common?
COPD is more common.
COPD is more common. So with this, do not again overstress about the HP. Do not overstress. All those who get exposure to the organic dust do not develop the hypersensitive pneumonitis. So with this history, because, but sorry, you might have seen the chest X-ray and other things also.
Yes, sir.
Okay, but you told wheezing.
Sir?
In your findings, you are telling wheezing also.
Yes, wheezing was also there,
Wheezing
but there was no relief. Patient was taking inhalers, which was on and off prescribed by the local practitioners for the last 1 year, but there was no response to therapy.
So if you do not have a chest X-ray, if you have not seen the investigation, if wheezing is there.
Now, what wheezing signifies? What is wheezing?
Sir, the
What is
airway,
definition of wheeze?
wheezing is a musical sound, generally musical adventitious sound, which is heard maybe with monophonic or polyphonic, heard during the variable phase of the.
It is a continuous sound, added sound that is high pitched and may be visible without stethoscope. This is a wheeze, and ronchi is a low pitched continuous sound. Okay. So when wheeze is present, it indicates obstructive airway disease,
Yes.
not the restrictive.
Yes.
Okay, continue.
But the other findings.
Other finding you. So at the stage, you cannot say it is a restrictive lung disease because of the presence of wheeze.
Yes.
So you have to say it is obstructive airway disease.
Sir, it was in my differential, and obstructive airway disease is in my differential.
So after history, we will ask you what is your impression. Then you have to go for obstructive airway disease, then restrictive, because wheeze is signifies airway obstruction.
Yes.
Can you show the chest X-ray? Chest X-ray of the patient. So this X-ray favors a restrictive disease or interstitial lung disease or an obstructive airway disease X-ray. This X-ray at a glance favors an obstructive airway disease or a restrictive airway disease.
So there is reticulonodular shadows present diffusely all over the zones with slight shaggy hard border, although lung volume is not reduced. In both the X-rays, it is of November 2021 and this is of August 2022. The lung volume is not reduced, but there is definite reticulonodular shadow present.
This X-ray, whether you should tell it is restrictive disease or obstructive disease.
Sir, restrictive disease, I can suspect a restrictive disease. I will need a HRCT thorax more.
No, from this level. When we are asking from this level, you have to answer.
Sir, at this point, I will, after history and
then the positive findings, tell me.
the clubbing on examination on, sir, only the positive finding I should tell?
Only positive
on general examination, clubbing was present.
Okay.
Chest expansion was reduced. It was 2 centimeter, bilaterally symmetrical, 1 centimeter in the right and the left hemithorax. Lung border was discussed in the normal areas, and bilateral vesicular breath sound was heard in all the areas of the chest with end inspiratory creps heard in infraaxillary, interscapular, and infraaxillary area, infraaxillary, interscapular, and infrascapular areas on both the sides.
Tell me some causes of inspiratory capitation at the base, lung base.
Sir, apart from the pulmonary edema is very common and it can cause an end inspiratory fine creps, which is similar.
The history is not suggestive.
Suggestive of
pulmonary edema. Then?
So then should I proceed with it?
No. What are the causes of inspiratory capitation bilateral? One is definitely DPLD.
DPLD.
Pulmonary edema. Another.
So the
COPD can get.
COPD can get.
So that doesn't exclude COPD. Okay. Then X-ray, then CT. So describe the CT.
There is interlobular and intralobular septal thickening present with centrilobular nodules and few cysts with more in the lower zone with traction bronchiectasis and some amount of bronchial ectasis with mosaic attenuation. We don't have an expiratory film of the patient, so I can't say for sure whether it's air trapping, but some amount of mosaic attenuation is present.
So I'm not sure about the mosaic attenuation, but that is, then are any other thing? Investigation?
Then we proceeded with the PFT. It was showing a restrictive defect, but unfortunately the patient was not stable enough to perform a DL, so he was not able to hold the breath for enough time. But it was showing a FE1 by FVC was 87 with FE1.
Primary diagnosis is DPLD.
Yes.
Yes, primary diagnosis is DPLD. Then tell me some causes of DPLD where lung volume remains normal. In the early stages of hypersensitive pneumonitis and sarcoidosis, it can be normal. With a cystic ILDs like PLCH and LAM, it can be normal. With CPFE, combined pulmonary fibrosis and emphysema, it can be normal. The lung volume can be preserved. Mostly these will be the. And a combination of COPD and ILD. It's very important and very common. We often forget to tell this. The combination of COPD and ILD.
Yes.
Okay, so that may be. Yes. And how you can explain which in a DPLD patient?
Sir, some DPLDs have a bronchial, in which bronchioles can be involved and bronchiolocentric. Most commonly, hypersensitive pneumonitis and sarcoidosis can present with these also. And this patient had a history of these.
So your final diagnosis is chronic HP.
At this point, yeah, this will be the. We proceeded further with the investigation at this point.
Okay, proceed.
Although no CTD symptoms were present, but as a institutional protocol, we did a CTD markers for this patient, and there was a history of exposure to pigeon feather birds. So we did a IgG against bird feathers and droppings. It came out to be negative, and all the CTD markers was also negative.
Okay,
then we proceeded with a functional assessment. 6-minute walk test and echocardiography was done. 6-minute walk test was aborted after 3 minutes as the patient desaturated from 92% to 86%. And the distance covered was 120 meters. And echocardiography was done with no evidence of pulmonary hypertension. After that, we proceeded with the bronchoscopy. Bronchoalveolar lavage and transbronchial lung biopsy was done for this patient. The report came yesterday. There was BAL lymphocytosis was there. 33% lymphocytes were present. And on transbronchial lung biopsy, peribronchial tissue was infiltrated by lymphocytes and plasma cells, and with some histiocytes with some lymphoid cell aggregates. And alveolar interstitium showed fibrosis and infiltration by inflammatory cells, although no granuloma was seen.
So what is your final diagnosis?
At this point, we made a final diagnosis of fibrotic hypersensitivity pneumonitis.
But in valve fluid you are expecting?
Infiltration by inflammatory cells is there.
So generally what the ATS, now the nomenclature has been from acute, subacute, chronic has to move from non-fibrotic to and fibrotic. Generally on the radiology, the more fibrotic component was seen. And it's not that fibrosis is also present in the biopsy finding, although some amount of inflammation is also there. So as the fibrosis was predominant on the radiology also, we thought that the diagnosis can be a fibrotic hypersensitivity pneumonitis.
Progressive fibrosis in ILD.
So the PF-ILD, now known as a PPF, progressive pulmonary fibrosis, has been described. Generally, 3 components they have taken to decide ILD as a PPF: a clinical, radiological, or a functional assessment. If any of the 2 out of 3 is present, we can consider it a PPF. So for clinical, any increase in symptom or on radiology, increase in the intralobular septal thickening or a ground glassing or progression on the ILD, or on functional assessment, increase in FVC, decrease in FVC by 5%, or DLCO by 10% over 1 year, it is considered PPF.
So finally, thank you. So finally, before the examination, after your examination is complete, you will get some time. Do not be panic. Think of your diagnosis for the point, favor of your diagnosis for the points you cannot explain with your diagnosis, and what will be the probable answer. Please keep them ready so that you can face examiner better. Sir, your final point?
Thank you. Nothing else. Anything you can ask, you want to ask particularly? Any questions?
Onkon, your comment?
Nothing specific, but in this patient, after diagnosis, we started steroid, and we have to see the response of the steroid. No, not only there is fibrosis, but also there is some centrifugal nodule and air trapping and few ground glass also. So initially we started steroid, and steroid challenge for 3 to 6 months. If there is no improvement after 3 months, we may stop it and start antifibrotic.
So in HP, the treatment of choice is steroid, but if there is progressive fibrosing ILD, then you have to give the antifibrotic drugs. Okay, thank you.
Other than the medical treatment for this patient, avoidance of a possible source of exposures with the first treatment for this patient. If you will continue the exposure, then any form of the treatment will not help you.
আপনি আসছো নাকি? আমরা নিচে নাম না ইয়ে করলাম।